Hi everyone, very good evening guys. I hope I'm audible and visible to all of you. I would need a quick confirmation in the live chat box and then we can get going with the session. Welcome to INI-CET LRR Pathology, which is more of a one-shot session. We've not divided it into two this time. So whatever we are going to study for the LRR is going to be in this. Before I begin, I'll take 2 minutes for the orientation of what this session is going to be. The estimated duration, which most of you have asked me, approximately 4 hours, and I'll tell you how I've divided it. So that's also a little bit of a homework for you. So we are going to do time boxing like we already do for every exam. Before the exam, we are 15-16 days away from the exam, right? So we need to get into the time boxing mode. Approximately, I have 125 slides for you to do, plus what we have to discuss in this session, plus there will be 10 slides which I have added in this PDF, which is going to be a bonus. I mean, just revision of miscellaneous images, stains, which I just want you to look through maybe one night before the exam. So before the burning question comes my way that when will the PDF be shared, it will be shared after the session is done. And it will be shared both on the Prep Ladder app. It will also be shared on Telegram because I believe on the app it takes a little time for it to get uploaded. So you'll get it on the Telegram also. So be rest assured about this and don't keep your focus only on the PDF. Keep your focus on the real thing, and that is the session. So now I have a small homework for you. What we're going to do, we'll divide this into 4 hours. So now you have to, at the end of every 1 hour, give me a small little reminder that ma'am 1 hour is up. Why am I telling you to do that? Because I've kept an average that let's try for 30 slides per hour. That will just give me a good estimate that I'm going at the right pace. Because when you're closer to the exam, and listen to me very carefully on this, the time is not going to adjust as per you. You have the same 15-16 days. You will have to adjust as per the time. So if I have kept a duration of 4 hours, it is my responsibility that I have to finish my syllabus in the next 4 hours that I have decided. So this is the target that I have to achieve, come what may. And if I do that at the end of every 1 hour, I'll know that I'm going at a comfortable pace. And that is your job now. At the end of every 1 hour from whenever we start, you will remind me, ma'am, 1 hour up, and I will let you know whether we've completed 30 slides or not. And if we go at this comfortable pace, we will be able to finish our syllabus at the end of 4 hours. We are of course going in for the most important topics. For students who've been a part of previous sessions also, we'll divide it exactly how we've done it earlier. Maybe you've been a part of the RRR on the app, maybe you've been through other YouTube sessions in the past. So what I've done, I've picked the best of all. So these are going to be a mix of MCQs, slides, images, and everything that you need to know, particularly for INI-CET. A lot of INI specific topics like flow cytometry, TEG, platelet aggregometry are also in this session. So my only advice is that don't fall for that FOMO that ye reh jayega ya nahi. Everything will be covered, but of course you will require that patience of 4 hours which is needed, and I'm sure we'll sail through this. Okay, one more thing. If you have any doubts, which I'm sure you will, or you want something extra to be discussed, so we'll not break the session in between. What we'll do, we'll keep it for the end. Once I'm done and I've clocked in these 4 hours successfully, we will add maybe 15, 20, 30, whatever minutes are required. If you have any queries, questions, you want something to be repeated, or whatever you want to discuss, we will keep that when we are totally exhausted and towards the end. We won't put it in between the session. We'll try to make it very, very smooth, as smooth as possible, right? Okay, FMG students, of course you can attend. NEET PG students definitely should be attending. I mean, this is something which will not harm you in any way. It will give you the benefit that you require. Shall we start? Note the time, please, because this is your homework. This is not my job. I'm not going to keep a time or a check on the time. You will tell me at the end of 1 hour that, ma'am, 1 hour is done. Have we, and I'll tell you the slide number, that have we completed 30 slides or not. Okay, so time boxing also gets going alongside. Let's start. So now I'll say, as I said, I've picked up MCQs, slides and images from some of the previous sessions. So in some places you will feel there's an overlap. Ye to padha tha, but then it's something for revision also, right? That you will have to repeat it one more time before the exam. And then I have added the updates of rapid revision version 11 also. So that is also included in it. I think I've spoken a lot. We need to get started. Question number 1, we start with the easiest possible, warming up. So we need to get it right. There is a patient with very typical history in our country of TB, and we cannot get this wrong, right? And the histology is shown. I hope you could easily identify this giant cell. I mean, I don't even wish to ask you this. I know you are aware of the Langhans giant cell, the horseshoe shape arrangement that you see in TB. They will not ask you to identify it. It's an INI-CET exam. They will ask you the interferon. So what I asked you over here is interferon gamma. That is amazing. Now I'll tell you how else the question can come in the exam. They will ask you questions regarding all interferons. You know, they are interferon alpha, beta, gamma, gamma. Question number 1 for INI-CET will be, where do alpha, beta and gamma come from? What is the source? Who releases them? And that is LFT. When I say LFT, interferon alpha comes from leukocytes. What are leukocytes? White blood cells. So they will mention any white blood cell like a monocyte, macrophage, like that. Then interferon beta comes from fibroblast. Interferon gamma comes from T helper 1 cell. This means that T helper 1 cell releases interferon gamma, and that is responsible for all that TB and granuloma. And which hypersensitivity is TB and granuloma? Type 4. So indirectly they ask you which interferon in type 4 hypersensitivity, it is interferon gamma. Which T helper cell in type 4 hypersensitivity, it is T helper 1 cell. So all that integration happens. But where do I expect the question? What is the function? You know interferon alpha, beta, gamma, ABG is learnt as ABG. So most of you have learned that interferon alpha has antiviral properties. Recently I was discussing this as an MCQ also. I'll repeat it for you guys. They will give you some viral infection, maybe a hepatitis, maybe a herpes, some viral infection, and they will say a topical cream is being developed for that viral infection because it's involving the skin, for example. So if it is a topical cream that is being done, what is the composition of that topical cream that you would want to keep? It will be interferon alpha. Now here comes the INI question. Can you also use interferon beta? Mostly interferon alpha has antiviral properties, but can interferon beta also have antiviral properties? Because in INI you are getting those multiple questions wala na, multiple options can be correct kind of thing. So yes, interferon beta also has antiviral properties. Note that point in case you have missed out. But mainly interferon beta is used for the treatment of a brain disease, something to do with multiple sclerosis, and interferon gamma, G for G, granuloma formation. So TB ka koi bhi history aaya, you are dealing with interferon gamma. Is that okay? This question, especially this point which I have marked QQ, aakhri din, so you will not even have time to read these 120 slides. Last day, so you will only read whatever I've highlighted and whatever is a question marked, right? Let's move on to question 2. Again, something very favorite for INI exam. Frozen section. If they don't write frozen section, they will write the name of the machine, that is cryostat, right? What is this? This is going to be cryo, something frozen, so that I get to know. They are saying it is not used for what? If it would have been a real INI type of question, they would have said what is it used for, and then they would have given options like 1, 2 and 3, 2, 3 and 4. So that's how INI makes it a little more lengthier, right? What is it not used for? Very good. It is not used for conclusive diagnosis. See, when we talk about conclusive diagnosis, it is always, what is the gold standard? That histopathology, that light microscope, ma'am, that is always conclusive. Let's assume they give me a history of modified radical mastectomy or a breast cancer case. Do you think on the basis of frozen section I want to give a conclusive diagnosis of breast cancer to the surgeon? Of course not. So what is then it used for, ma'am? I'll show you a machine also. Have a look at this because the next question is based on this. This is the cryostat machine. Cryo means what? Frozen. So the temperature inside it is something like a -20, -30, like that. And you can see that whatever tissue I have kept it inside. I have frozen the tissue, frozen the breast cancer. This is the inside view. I have frozen it. Why? So that now I can give a stat, cryostat. I can give a quick diagnosis, and that is what I want to do. The surgeon is operating right now. He says, I want the diagnosis in 15 minutes, whether this is a cancer, whether the margin is free or not. So can this be done for margin assessment? Yes, because then the surgeon will get to know that do I need to resect more? Do I need to take out more of tissue if the margin is positive? Maybe some cancer is in the patient right now. Is it done for metastasis? Again, yes. Imagine a modified radical mastectomy is being done and the surgeon sends me the lymph node and asks me, ma'am, is the lymph node involved? Should I do lymph node dissection also? So then what will I say? That okay, that lymph node assessment I will find out on cryostat. I'll give you the report in 20 minutes. If the lymph node is involved, please take it out. Next, is it done for sentinel lymph node examination? Again, that's correct. What is it not done for? It's not a conclusive diagnosis. Conclusive histopathology hota hai, paraffin wax wala. Very good. But I have one more question. If they give you the same, this frozen section wala machine, and they say now you want to examine fat in it. This is a previous year. I mean, back in the day when INI-CET was not a thing and JIPMER and PGI used to be separate exams. This was a very, very old JIPMER 2017 question. First time it came then. No one knew it back then, but then after that it's been coming many a times. What is the fixation technique to examine fat? What do you do? Yes, I've told you, cryostat. Why, ma'am? Why are you not doing immunohistochemistry or formalin or paraffin? Fat mein kya hoga? Fat will end up getting dissolved. As soon as I treat fat with any chemicals, like, alcohol, it will dissolve the fat. Xylene, alcohol, these chemicals will dissolve it. So please don't use all these. Just do a cryostat, because are you using any chemicals here? No. All that you are doing is I'm freezing it. Freeze karne se to fat is not going to vanish. I will be able to look at it. And to look at fat, what is the stain? Very baby question I'm asking you, not even wanting a reply. You know it. Fat ke liye, ma'am, I will use oil red. Fat will come out to be red in color. We know all of these, basic things. So fat ke liye cryostat, and quick diagnosis ke liye I will use cryostat. I will never use it for conclusion. So these two questions spent good amount of time so that you don't get it wrong. Let's move on. Because you said conclusive diagnosis ke liye, ma'am, the proper paraffin and everything has to be used. This is what I'm adding. Maybe you didn't find this in if you've only gone through rapid revision, but then that is my intent over here, to add on something so that you are preparing for INI-CET, right? You have to arrange the following steps in the correct sequence of histopathology processing. Now in today's session, what I've actually done, from one topic, you will see I have built a connection for the next topic. So I've not got like general path, systemic path in that order, no. I've got it, if you just discussed cryostat and I said cryostat is not for final diagnosis, so then I will do what? I will do histopath processing. So tell me, what is histopath processing? Most of you are answering C as the answer. If you know it, excellent. If you don't, then listen to me for 2 minutes now. This is how a histopathology machine looks like. This is exactly how it looks like. You can see so many dabbas, containers over here. Every container has some fluid. Let's assume we were doing a breast case, right? A breast cancer case. Breast biopsy has come. First it will be put in this container, then this container, then this. This machine keeps moving. Why are you putting it in so many solutions? Because these are all the steps that you have to make sure. And for INI-CET only, they will be asking you this. This is not a NEET FMG question. What does this mean? I have learnt it as fix the concept in your brain. What is fix the concept in your brain? Number one thing that we do is going to be fixation. What is the fixative that we use? 10% neutral buffered formalin. Okay, the first solution that you're going to put the breast tissue into is a fixative, 10% neutral buffered formalin. After that, the second dabba in which you will put it, fix the dehydration. How is dehydration done? You want to take all the water out. You just want to look at cancer, right? So you'll say, okay, let me put all the water out of it. And for dehydration, the best is you use alcohol. Yes, alcohol is a dehydrating agent. Fine. The next thing that you put the tissue is clearing. Clearing means you just clean everything miscellaneous. See, you are very targeted. Mujhe kya dikhna hai? I just want to see cancer cells. Remove all the miscellaneous gaps and holes and water and everything. So for clean, you use xylene. Repeating, to clean the tissue, you use xylene. Rhyming, clean, xylene. So remember, fix for fixative, the for dehydration, fix the concept. So this means you have done what? You have done clearing. After that, finally, it is ready to make that particular. So ma'am, sab kuch to hata diya. You have removed all spaces, water, holes, gaps. Now you fill something. What are you going to do? You will fill it with paraffin wax. Impregnation means that you are adding something. I have added paraffin wax, and that is exactly what the next step is going to be. In this, I am going to impregnate. I am going to add paraffin wax. Why? Because by adding paraffin wax, I will make a block, and that block is going to look like this. I don't know how many of you noticed it. If you look carefully, the tissue is not just kept as it is. The tissue is kept inside something. So, जब freeze कर रहे थे, तो it was frozen. If I use paraffin wax, the tissue is kept inside paraffin wax. So that is what I've done. I have done impregnation. After that, you are ready. Now what will you do? You will make a slide, you will do cutting, you will get that tissue on that slide. After that, you will put the routine HNE wala stain, and now I will put that pink blue color, that is the routine staining. These steps are not asked, these are only for your common sense. You will add the pink and blue color, you will do mounting of the slide, and you will look at it under microscope. So mujhe kahan tak yaad karna hai? I have to learn it till here. That is why I said fix the concept in your brain. Can you remind me once again without looking at it? As soon as the question comes, fix the concept in your brain. So let me start. Step number 1 is going to be fixation. Step number 2 is going to be dehydration. Step number 3 is going to be clearing. Step number 4 is impregnation. यहाँ लिखा नहीं हुआ. Step number 5, make a block out of it, paraffin block out of it. वो भी नहीं लिखा हुआ. So what is the last step that I have left, which I will ultimately mark over here, is going to be mounting. Yes, that is what we do. So बस इतना याद करके चले जाओ. Fix the concept in your brain, and the 5 main steps of how a histopathology processing is done will be settled for you. Now I have some INI specific questions. Is this always the fixative? Many of you were so confident कि formalin use करेंगे ma'am, and answer is no. This is what you will now fill in the blank. You're gonna tell me all the fixatives throughout path, maybe a little bit in gynae, maybe in other subjects like surgery. Har jagah, every fixative that is used, you will be telling me. So for light microscopy, what you told me was right. 10% neutral buffered formalin. Focus on the 10%. They will mess up on the percentages. Options hoga 2, 10, 20, 40. So be very sure it is 10% neutral buffered formalin. That is for light microscopy. Next, for electron microscopy, what is it? It is 2 to 2.5% glutaraldehyde. This is not my revision. This is already written. I have done my job. This is your revision. You need to speak out, type out, whatever works for you. You have to revise with me. For electron microscope, it is 2 to 2.5% glutaraldehyde. On Monday, we'll be meeting again for microbiology, right? Over there, I will again ask you, but there, that time glutaraldehyde will not be used for electron microscopy. Glutaraldehyde will be used for sterilization, disinfection. Can I use this in the microbiology lab? I will write chota chota, but don't get confused. Do we use this as Sidex in the microbiology lab? Because for all the scopes we use Sidex. Laryngoscope, bronchoscope, endoscope, etc, etc. All the scopes are cleaned with Sidex, and that is nothing but glutaraldehyde. Very good. वो Monday बात करेंगे. अभी के लिए coming back, testicular biopsy, and next 3 questions is what I'm expecting in your INI paper. Testicular biopsy पढ़ के please, many of you just marked Bowens because हमने ऐसा पढ़ा है in the previous year questions. Today I'm telling you that read carefully, see what the examiner is asking you. Why has the testicular biopsy been done? If it has been done for cancers, seminoma, teratoma, ऐसा कोई कैंसर के लिए करा है, then तो you use the usual fixative, you use the usual 10%, sorry, the next answer got displayed, 10% neutral buffered formalin, usual वाला fixative use करा. But here's the catch. If the testicular biopsy is done for infertility, infertility means you are trying to look out for sperms. If I put sperms in formalin, formalin is very strong. Formalin will anyway destroy the sperms. Then what will you be able to see? Nothing. So for infertility, do not put the sample in formalin. For infertility, you will be using the Bowens fixative. So if they say there is a 25-year-old child, 25-year-old male who is now saying that acha, there is a testicular mass, you think it is seminoma, you have resected it. So seminoma ke liye to usual neutral buffered formalin karo. But if they say there is a 30-year-old suspected infertility, then you say okay, this is, I'll put it in Bowens fixative. Please read carefully. Agla, yahan par, this is something not even in your rapid revision. These are pointers. I'm adding a Q mark. This is for you to revise also. Bone marrow biopsy के लिए कौन सा fixative? Do I put it in formalin? Yes, डाल सकते हो formalin में. But INI ना, they want to ask you the ideal most thing. So you will use the Zenker's fixative or the B5 fixative, adding to your knowledge. Zenker's fixative and B5 fixative. Coming to pap smear, controversial question. If you ask a pathologist, the fixative for pap smear is, to be very precise, 95% ethanol. If you ask gynecologist, they will say हमारी book में क्या लिखा है? It should be ethanol plus ether. But now you tell me, see, if it would have been a surgery, I would have gone for the gynae textbooks. But this is a very pathology topic. Which book do you want to rely more on for INI-CET? For a pathology topic, I will rely on pathology books. They say 95% ethanol. So option A will be this, option B will be this. You will always select 95% ethanol over any other option. If this is not there, then please go ahead and select ethanol and ether. Then it becomes totally your choice. But single best answer, 95% ethanol for pap smear. Coming to the last one, what is for karyotyping? ये तो NEET PG FMGE में भी पूछा हुआ है. Car. This means which fixative? Karyotyping के लिए car. Neu fixative is used. I think we already know this. Perfect. We'll be talking more about these. अभी आगे चलते हैं. I think the main tough part of histopath processing, fresh minds, I have added extra knowledge to your mind. Now I will go on with the things which we know since a long time. Easy wala question. 11-year-old boy with a history of recurrent bacterial infections comes with fever and productive cough. There will be two set of diseases you will find maximally in your exam. एक तो वो कफ वाली हिस्ट्री बहुत आती है इंडियन एग्जाम्स में, एक माइक्रो में डायरिया वाली हिस्ट्री. दीज टू आर गोइंग टू फिल अप योर एंटायर पेपर. इफ नॉट दीज, it will be all about STDs. Be very aware that you will see this back to back in your paper. Biochemical analysis of the neutrophils shows some problem with oxidative burst, which means problem with phagocytosis. Mutation in which gene, encoding for which protein? Most of you say that this is NADPH oxidase disease. कौन सा बनाया? If you say NADPH oxidase, which is the gene that you think this is a problem in? This is the FOX gene, right? NADPH, FOX, phagocytosis कराने में help करता है. तो phagocytosis के लिए which gene required? FOX gene. What is FOX gene going to make? It is going to make NADPH oxidase. That is the problem. What is the name of the disease? Chronic granulomatous disease. यहाँ तक ठीक है. But the question was, patient is having lots of infections. Can you guess which kind of infections? They are catalase positive infections only. I have a small little homework which I will discuss with you on Monday. When we do microbiology, we will see catalase positive organisms कौन से होते हैं. Space is very commonly learned. That is how we did it. वो हम Monday revise करेंगे. So remember all the Staphylococcus, Pseudomonas, these are all the catalase. Maybe if I wanted to twist the question a little, I would have said that these are usually to do with lots of infections. Again and again the mother is saying that my child is having, look at my child's report, he has Staphylococcus, he has Pseudomonas. So that is how they're trying to guess and indicate towards you that acha, these are catalase positive infections. Please think of CGD. Now comes the previous year question. What is the screening test? What is the diagnostic test? Screening test we already know, NBT, nitro blue tetrazolium test. Diagnostic test कौन सा है? DHR, dihydrorhodamine. I'll repeat for you. Screening test, nitro blue tetrazolium. क्या होता है nitro blue tetrazolium? It is going to be a dye. Do I want you to know the nitty-gritties and the details of this test? Not at all, क्योंकि screening test है मैम, इतना क्यों पढ़ना? But do I want you to know a question for INI-CET? One little question. It is a dye. Whenever they will write a dye, they will ask you, अच्छा कौन सा color आया? Normal cell will give what color? Abnormal, this disease cell, let's say I've taken a neutrophil. Neutrophil में normal neutrophil of you and me will give what color? Nitro blue tetrazolium. Maybe it will give a blue color. But a person with CGD, उसमें क्या color आएगा? And that is going to be yellow color. So all that I want you to learn कि अगर yellow color आया, imagine they say nitro blue tetrazolium dye is giving a yellow color. What will you think? Normal या disease? You will think of disease. In childhood we used to do ना yellow dirty fellow पढ़ते थे. बस वही है. यहाँ पर also remember like that. Yellow dirty fellow will tell me yellow person has the disease. If the dye gives a yellow color, that is dirty fellow. That is going to be diseased wala fellow. But what is the diagnostic test? It is going to be the dihydrorhodamine test. It is dihydrorhodamine test. I think some of you are having, I mean, I am not getting this at my end probably because I have the admin access, but I don't know if are there ads that are coming up. I will have to put that across to the prep ladder team for switching that off. I know that can be a little irritating also to have constant, just give me a moment. Okay, I've left them a text. Let's see if they can do it mid-session, but I'll make sure that when we meet again on Monday for microbio, that is taken care of beforehand, but I'll try my best कि अभी भी ये end up हो जाए, right? Okay. Perfect. Now coming to the next, NADPH में क्या बचा? Diagnostic test अभी के लिए adjust करते हैं. Let's not put a break to it. I've put up a request. Maybe they can do it mid-session. If they cannot, then we'll try to figure a way out. Okay, some of you do not have, some of you do. So we'll see how that works out. Okay, anyway, diagnostic test is going to be dihydrorhodamine. INI-CET, dihydrorhodamine testing करते कैसे? On which machine is it done? It is done on flow cytometry machine. So some words that I'm adding here over and above your rapid revision is exactly why I'm preparing you for INI-CET exam. Okay, let's move forward. This was pretty slow. अब थोड़ा fast करते हैं. What is this? Very dumb question. NARP is what? I know this is a mitochondrial function disease or a mitochondrial DNA function problem. This is not not the question you will get in INI-CET exam. These are all the mitochondrial diseases which I will now prepare you for. Do we remember mitochondrial DNA, mother to all, father to none? वो वाला concept सबको पता है, of course. So which is the most common mitochondrial disease? That is MELAS. Which is the most common mitochondrial disease which affects the muscles? That is myopathy. That is going to be CPEO. Apart from that, LON, abhi pada, NARP, League syndrome, Pearson syndrome, Kern-Sire syndrome. These are all mitochondrial diseases. They all go from mother to all, father to none. Now let me prepare you for INI-CET. What kind of a mutation is happening? So remember, whenever I say mitochondrial DNA ka problem hai, I am actually saying that the mitochondrial DNA has a mutation. For all these diseases, this is extra, listen carefully. For all the diseases, it is a mutation in mitochondrial DNA that the mother is having. But when I say that there is a deletion in mitochondrial DNA, what are the three diseases that you will think of? You will think of Pearson's disease, you will think of CPEO, and you will think of Kern-Sire disease. I know you were not aware of this if you only read rapid revision, so I'm preparing you for INI extra stuff. If you want, you can learn it as polycystic kidney disease if that works for you, PCKD, but otherwise you have to learn these three. That is Pearson disease, the CPEO, and the Kern-Sire disease. ये होते हैं deletion of mitochondrial DNA, everything else is mutation. So now if I on the basis of this make you attempt this question, I think you will be able to, all of the following are associated with a deletion in mitochondrial DNA except, you said deletion ke liye ma'am, it is PCKD, which is not with a deletion. Your answer is going to be MELAS. Extra stuff yaad ho gaya. One last for INI-CET, another mitochondrial which will come as an image based question. What is this? This is MRF. That is, it is myoclonus epilepsy. So history mein epilepsy hoga. And along with that, there are red ragged fibers. When I say red ragged fibers, I can see those red ragged fibers. Where am I seeing this? It is going to be in the muscle. What are these red ragged fibers? Ma'am, it is a mitochondrial disease. So these red ragged fibers are nothing but abnormal mitochondria. Can you show me that abnormal mitochondria under the electron black and white microscope? Yes. The same abnormal mitochondria which is looking like red ragged fiber here is looking like this round. Remember in the old days, this is how our previous generations used to listen to songs etc. by these phonographic records. So this is how the abnormal mitochondria is looking. If not like this, तो वो ऐसा दिख रहा है as if cars are parked in any direction, pretty much how people park in our country, right? Parking lot appearance. So that is one appearance, that is the other appearance. ये सब क्या है? These are all abnormal mitochondria. Is that okay with everyone? So MRF के images हो गए. All the tough questions of mitochondrial is done. Let me move on to another. अब genetics ही पढ़ रहे हो तो let's do 2-3 genetics questions that will come up. Which of the following can change the gene expression by methylation and acetylation without changing the content of the gene? So now content means that can't be addition, deletion. Quantity is not changing. The function is changing. Yes, only the definition was needed. This has been an INI favorite topic. Epigenetics. What do you mean by epigenetics? It means above genetics. You are not changing the quantity. You are only changing the function. So by methylation, is it the gene becoming more active? No. Methylation matlab mute. The gene is becoming quiet. Whereas with acetylation, the gene is becoming active. Repeat with me. Methylation for muting the gene, acetylation for making it active. And you know what are the two diseases that have come up on it? It is always Prader-Willi and Angelman. So uske questions plus INI questions you add in it. When I say Prader-Willi and Angelman, which is the chromosome that we talk about, it is chromosome 15 for both. What are the genes? For Prader-Willi, it is the SNORP gene. SNORP gene is for Prader-Willi, whereas for Angelman, it is the UBE3A gene is going to be for Angelman. Now, SNORP for Prader-Willi, everyone remembers. UBE3A likha hota hai, to you remember for Angelman, but sometimes they don't write this. They write the full form of UBE3A. What is it? What is UBE3A? It is ubiquitin ligase. Agar unhone aise likh diya that ubiquitin ligase gene is defective, it is the same thing. It is what is UBE3A. You will still mark Angelman. Now you know what is imprinted. So imprinting ka matlab kya hota hai? It is silencing, mute, silence, imprinting, same. What is imprinted? What is deleted? So you know in Prader-Willi, Papa region is deleted. Papa region is deleted. So Prader-Willi mein paternal deletion happens. Angelman mein maternal deletion happens. What I'm not writing, I'll just draw. If they say there is a chota mota bachcha very bad photo, but you get the point, right? If they say a chota mota bacha, that is a short stature and an obesity kid, you are thinking of Prader-Willi. If they think about a very child who's forever laughing, happy puppet wala syndrome likha, so then you are thinking about Angelman. I hope these images will make sense. Only it will make sense to us, not to anyone else. But I hope you get the point. All of these diseases come under epigenetics. That's okay with everyone. Chromosome 15 से एक और चीज़ बताते जाओ, not related with epigenetics but related finish of chromosome 15, that is Marfan syndrome. I hope you've not forgotten Marfan's was the one where the person had very very long fingers, spider fingers. But what is the defective? Listen to my question carefully. Chromosome 15 पे what is the defective protein? Is it fibrillin defect or is it elastin defect? I saw this question on my Telegram a few days ago, so I'm confirming this one more time. It is a fibrillin defect. Elastin effect हो जाता है. Eventually elastin is affected, but the main defect is in fibrillin, FBN1 gene, fibrillin 1 gene to be very precise. And I think chromosome 15 stuff is done. We can move forward because we are doing genetics. We don't go by the question numbers because, as I said, I've picked up questions from all sessions which need to be done for INI. So they are a mixed bag everywhere. Which of the following options is not used for detecting abnormal gene sequences? Not for genetics. I think we know this answer. It is flow cytometry. So what you're going to do, all these gene and all these PCR related things you will tell me. But first tell me, what is flow cytometry used for if it is not used for genes? It is used for CD markers, ma'am. In a while you will tell me all the CD 1, 2, 3, 4, 5. All that we do with flow cytometry. तो वो एक अलग set of questions करेंगे. अभी के लिए all of these are done for genetic sequences. So let me ask you, when are you using RT-PCR? Because after lockdown and COVID, RNA viruses, so this becomes a very important question. Reverse transcriptase PCR is used for RNA viruses. Their favorite is COVID, which they like to give. Next, when do you use nested PCR? That is a question which, and what is nested PCR? I mean, it is just a regular PCR. The only difference is that the number of primers that you are using is going to be, yes, you are going to use 2 set of primers, or you want to call it 2 pairs of primers, whatever you want to say, it means the same. So ma'am, iska kya matlab hua? Does it make this PCR a little better? Does it make it a little more sensitive? Yes. तो ये तो हमें तब समझ आएगा ना, when I know what normal PCR looks like, and that is exactly what we will be dealing with. You will first tell me that in a PCR, what are the different steps that we have. This is what I have written for you. In a PCR, we have denaturation. पहले क्या होता है? PCR is a double-stranded DNA. First, you have to convert it into 2 single strands. That process is known as separating it. It is going to be denaturation. After you have separated it, now you are going to attach the primers. Attaching the primers is known as annealing. Normally, how many do you attach? Normally, ma'am, 1 forward and 1 reverse. But nested PCR mein, if I say everywhere 2 primers, 2 sets are being attached, then you will say, oh, then it becomes an even better PCR. Now it is going to become a nested PCR. So routinely I attach 2, but in nested PCR, I attach 2 sets of primers. After that you have done, you are going to do what? You are going to extend the DNA, and that extension is the last step. This you might feel a very dumb question, ye to 12th class ka question tha, but this came in the INI-CET 2024. They told you the 3 steps. In fact, recently also, then they said arrange it in the correct order. So first thing is denaturation, then you're going to attach the primers, that is annealing, then you're going to extend it, so that is going to be extension. So DAE is how you remember it. If they say regular, the normal 2 primers, but if they say 2 sets of primers, I'll repeat it once again. If they said 2 sets of primers, that is a nested PCR. What do I have left? What is this pyrosequencing? This is also a similar type of a PCR, but I use this whenever there is a low tumor yield. So if, and this is where INI question comes up, if they say there is a patient, he or she has only 8% tumor cells, 12% tumor cells, the tumor yield is very, very less, then pyrosequencing helps my way. But now what's the update regarding this? If they say there is 8, 10, 12%, very low tumor yield, number 1 option is pyrosequencing, but the second option given in the question is next generation sequencing. Always better than PCR. Now we have next generation sequencing. So till now, to only this has come in the options. At any given point of time, next generation sequencing comes in the options. You mark that over pyrosequencing only for this low tumor yield. So when you've done so many, why don't you quickly just tell me in one word, ye rapid revision ka screenshot aa gaya. As I said, all important slides from the entire, all different sessions are put up over here. So when I say what is the gold standard PCR, it is Sanger sequencing. When I say what is SBPE, single base primer extension, single base, I know exactly where to focus. For example, in BRAF V600E mutation, I know codon 600 needs to be examined. When I say JAK2 V617F mutation, I know codon 617 has to be examined. Can you tell me just one disease? JAK2 V617F के साथ the first disease coming to my mind is that Polycythemia vera. So in PV cases, I know which PCR needs to be done, SBPE, because I know exactly JAK2 gene has to be discussed. Then when I say their favorite hairy cell leukemia and इसका opposite पढ़ो Langerhans cell histiocytosis over there BRAF V600E. So for those cases, I will be doing SBPE. If I come back and read a question very quickly, over here you can see there is a man, chronic smoker since 20 years with fever and weakness. CBC pe hemoglobin of this man is 18, which is definitely high. TLC 30,000, normal is 4,000 to 11,000, so TLC is also more. Shift to left is there, platelet is also more, everything is more. Hemoglobin, white blood cell, platelet sab badha hua hai. Erythropoietin levels are suboptimal, below normal, because I expected it's a smoker. His hemoglobin must have gone up because EPO must have increased. They are saying EPO is decreased. That further gives me a very solid diagnosis of Polycythemia vera. JAK2 mutation karna hai. What are you going to do? Exactly SBPE. Can I ask you a question with regard to clinical features which is not written over here? Because this person's red blood cell is increased, what do you think will be the color of his face? This is for you to quickly tell me. The face is going to be plethoric because that's the red blood cell, that we have over here. So that is increase in hemoglobin, to be very precise. Because this person's white blood cells are increased, any pruritus, he says I'm going for a hot water bath and then after that I'm having very much of itching in my body, aquagenic pruritus. Why would this happen? Which kind of cells have actually increased? Mast cells, because they are the ones that will then release histamine, right? And that is why patient will have a lot of itching when he takes bath with hot water. You know it. And because his platelets are increased, imagine in the small capillaries of the fingers, those platelets were dhire dhire clump ban gaya. They start getting clumped. So this person will have a lot of erythromelalgia. Very good. This person will have a lot of burning. He will say that my fingers are burning. That is because all the platelets have clumped over here, and that is a case of erythromelalgia. If they wouldn't have given this to me, they might have written plethoric face, aquagenic pruritus and erythromelalgia. I would have thought of PV. I would have done single base primer extension. Perfect. ये भी रिवाइज हो गया. अब जब सब कर ही लिया, टेल मी द हीमोग्लोबिन लेवल्स एंड फिनिश ऑफ द मेडिसिन पार्ट ऑल्सो. इन मेल्स व्हाट इज द कट ऑफ फॉर पीवी एंड व्हाट इज द कट ऑफ फॉर फीमेल्स? सो इन मेल्स मोर देन 16.5 grams and in females more than 16 grams. That's the cut off that they say for Polycythemia vera. तो यहाँ पर तो males more than 16.5. This was a male and it is proven. Let me move forward. So I've understood how to apply questions of SBPE. This is settled. If they say there is a bone marrow with what finding, when will you think of hairy cell leukemia? Like I said, today's session is not going topic wise. Today's session is picking up a topic, whatever comes next. It's like a relay race. You keep passing it on from one topic to another. What is it that you see on a bone marrow biopsy? Biopsy pe kya dikhega? You will see the fried egg appearance, and then I'll be thinking about the hairy cell leukemia, which is the marker that I will test for BRAF V600E. Coming to the next, pyrosequencing, I think we have discussed. Whenever there is a low tumor yield, amplicon length analysis, very lengthy DNA. Can you give me one quick answer? Lengthy DNA, I think we know Fragile X syndrome. Why is lengthy DNA? What repeats are there? CGG repeats are there for Fragile X. We know this. Next, quantitative. You want to count something. Which PCR do you use? Real-time PCR. I'll tell you the question over here. They say there is a patient of CML. CML का translocation क्या है? 922, that Philadelphia chromosome, which we will talk about in a while. So BCR-ABL fusion is happening, na, basically. They say BCR-ABL fusion. The copies of BCR-ABL fusion have to be counted. Let's assume the copies are 1000. Starting में, when just an assumption, the starting में copies of BCR-ABL fusion are 1000. After giving therapy, and what therapy is given, they will say the patient was given imatinib. Now the copies have dropped to, let's say, random numbers I'm giving, 200. So how am I counting these numbers? If they ask you, you are counting it by which PCR? Real-time PCR. So I think you know how to apply these questions. Now tell me, if this has happened, is this a good sign? Of course, the therapy was given and the copies have decreased. This means the person is responding to therapy. So if I now want want to ultra twist it and say that which out of these PCRs can ultimately be used in a follow-up or for assessing the outcome of a treatment. ऐसा कुछ बिल्कुल out of the box. I mean, there's no link between these two, but if you join the dots, you will know, acha, this was the one where outcome of the treatment could be assessed, and that would be the real-time PCR. Understood if such a question comes. Finally, reverse transcriptase you have anyway done. It is done for RNA viruses, but for COVID, were we only doing reverse transcriptase PCR or were we doing a combination? COVID में मैम एक तो RT करना ही था, but you also had to count the number of viruses. So you were doing a combo. You were doing RRT PCR, छोटा वाला R for real time, big RT for reverse transcriptase. All your PCRs are done. If I go back, all these are done for genetic tests, but flow cytometry is done for CD markers. Now the question is, instead of writing CD markers, if they write IPT in the, this is how it's written in the AIMS. If you ever look at prescriptions of AIMS, or if you look at the hematology reports of AIMS. So if any examiner from there has said the paper, he would not write that flow cytometry has been done for CD markers. He will say, what is the test that you will do for knowing immunophenotyping? Immunophenotyping is just a very fancy word for knowing CD markers. It means the same. So then the answer will still be flow cytometry. Okay, let's move forward. Now this, I believe these two next questions will test your limits. I mean, they will tell your mind that ye kuch zyada ho raha hai. This is excess. Why excess? Because excess for NEET PG, not for INI-CET. So first 1 hour I have kept everything jo extra ho sakta hai, so that fresh mind mein you finish off. This is also not in rapid revision. It's there in main videos if you've seen it. What is risk and what does it combine with? It combines with, I think most of you have given me an answer, and that is single-stranded microRNA. But my question is, ye microRNA kya hota hai? Let's start with the first thing. Ma'am, microRNA means chota RNA. That is how easy it is. Yes, they will say there is an RNA with 20 to 22 nucleotides, that ATCG nucleotide. Chota, bahut kam, very few nucleotides are there. That is chota wala RNA, microRNA. How simple, but what does it mean? It is a non-coding RNA. Now a question from biochemistry. Maybe you've done it in biochem. Normally, what does an RNA do? RNA से क्या बनता है? DNA से RNA, RNA से protein. That is the job of RNA ना, कि आगे जाओ, make a protein. But non-coding RNA says, I will not do that. I will not make a protein. And now my question is, how does this non-coding RNA have the privilege that it is not going to do any work? How lucky it is not going to make a protein? So that is exactly what this question is all about. Now, whether आप ma'am you talk about a coding RNA or a non-coding RNA, RNA आएगा कहाँ से? It will come from a DNA. So the point is that the DNA is going to make an RNA, but this time the RNA that it is making is not a regular wala RNA. It is going to be a non-coding wala microRNA. I don't want you to know every step of how RNA is made. I just want you to know that pehle there were lots and lots of chota RNAs made. Then they decided we will pick out only one out of it. Then they decided that okay, all this structure is not needed. Ultimately, they have said that we will dice it. Can you see? Pehle there was a loop and then you said cut the head. How do I cut the head? I'm going to dice it. So who is going to cut the loop? Who is going to cut the loop? Dice the loop. Dicer will cut the loop. And now I have this RNA right in front of me. But ma'am, this is a double-stranded RNA. RNA कब से double-stranded हो गया? Please make the RNA single-stranded, and that is what I do. I convert the double-stranded RNA into single-stranded RNA. Now my microRNA is ready. What I want you to learn is 3 words in this ultra complex journey. 3 words. Number 1, microRNA काम करता है, कुछ काम नहीं करता, useless. Non-coding RNA, it doesn't make a protein. Question number 2, who has diced the head of the microRNA? It is diced by dicer. Question 2 done. Question 3, finally microRNA is a double-stranded configuration or single-stranded. तो RNA तो हमेशा single-stranded ही होता है. It is a single-stranded RNA. Now tell me, will this do any work? Will this let you make proteins? It will not. So can you see how did it not let you make proteins? This single-stranded RNA said, I will go, I'm too useless, I'm not going to make any proteins, I'm going to go and sit inside risk. What is risk? RNA induced silencing complex. See, everywhere the word that I'm highlighting is protein nahi banana. You don't have to make protein, you have to shut up, you have to keep silent. And that is what I've done. Now read the question. Risk combines with what? Did risk combine with this loop wala RNA? Did it combine with the double-stranded RNA, or did it combine with the single-stranded RNA? Now mark your question. Risk has combined with a single-stranded microRNA. Will this result in any protein formation? No. Silencing means there is no protein. routine. Is this okay for everyone? I know the first 1 hour will be the toxic 1 hour. After that you will get into that, oh ye to hame aata hai, confidence booster wala zone, wo bhi aa jayega. So I want to test your limits before I put you in your comfort zone. If I would have put you in your comfort zone first, then it would have been a problem for us, right? So now we've understood all these kind of questions also. Ab last cheese, imagine one day this dicer says I'm not working. This is a gynae correlation. If dicer mutation happens, what is going to be the tumors that can occur? It is the sex cord stromal tumors in the ovary. Kuch naam yaad dilao. Have you heard of fibroma, thecoma? You've read that in gynae. So maybe they will write what is the mutation associated with fibroma, thecoma in the ovary, sex cord stromal tumors. It is dicer. So now 4 questions done. Answer and move forward. Number 1, microRNA कुछ काम करता है? नहीं मैम, it is non-coding. It doesn't make a protein. Question number 2, who will cut the head off? It is going to be dicer. Question 3, if dicer is mutated, what tumors occur? Sex cord stromal tumors of the ovary. Question number 4 and last, the risk complex will combine with single-stranded RNA or double-stranded? तो RNA हमेशा single-stranded. Okay with everyone, the tough part is done. Now let's move on to something which is, as I said, 2-3 more slides, difficult wali. Infantile fibrosarcoma, these are some mutations which we never ever read, so those I'm preparing you for now. This might come. This used to be a very favorite question back in the day when you were dealing more with PGI separately, JIPMER separately, then AIMS में भी बहुत आता था. So now what I've seen is एक तो set of questions होता है in the exam which are like the sure shot 3 to 4 year repeat questions. One set of questions, approximately 20-25, are the ones which they've picked up either from previous years, old years, or they've tried to bring back that JIPMER PGI story again into it, and they're doing that gradually because ultimately they've also exhausted their Q bank, right? So they're trying to pick up questions from the past. Infantile fibrosarcoma, and I don't want you to learn all. I just want you to learn very limited ones. So firstly, I hope none of you marked 1122, वो तो नहीं mark करा ना, because this is for what? That I will tell you in a while is going to be for Ewing sarcoma. What did you mark for infantile fibrosarcoma? This is the tough one. This is going to be translocation 12-15. तो हमें कैसे याद करना है मैम? Infant कब बोलते हो? Infant is less than 12 months, 1 year. So infant का क्या age होता है? 12 months. And fibrosarcoma से you can remember 15, fibrosarcoma 15. So translocation, बस इतना सा याद करना था for INI-CET, not overdosing your mind with lot of information, just this much. Translocation 12 and 15 is going to be for infantile fibrosarcoma, and that is done. Now why did I not mark 1122? Because that is for Ewing sarcoma. So maybe the recent exam question of this actually came in FMGE exam, and now it has come previously in INI-CET, so वो इधर से उधर relay race चल रहा है. They are picking this again and again, and I will discuss over here again. They say anaplastic lymphoma kinase. Now from one question moving on to the other, and then I'll come back to that question. Anaplastic lymphoma kinase, ALK gene, is seen with which of the following tumors? I know you thought, oh, it will be associated with anaplastic lymphoma, but वो तो options में ही नहीं है. In the options, yes, again, if you go back to rapid revision videos ना, this is exactly where in neoplasia I have mentioned कि ये INI का topic है. But recently this has been asked in FMG exam also. Inflammatory myofibroblastic tumor. So let me talk about it. As soon as they write ALK gene, तो क्या क्या उसके नाम में से समझ आ रहा है? मैम, number 1, it will be mutated in anaplastic lymphoma, common sense. Number 2, it will be mutated in which particular tumor of the lung? In adenocarcinoma. Number 3, it will be mutated in which tumor? Inflammatory myofibroblastic tumor. Repeat one last time. Anaplastic lymphoma में तो common sense. Anaplastic AA adenocarcinoma lung में होगा, and inflammatory myofibroblastic tumor. Now I'll tell you exactly, ये तो पता था. FMG में जब question आया, it came very twisted. They said anaplastic lymphoma kinase gene is mutated in anaplastic lymphoma. It is a problem in anaplastic lymphoma, fine. What is the translocation which has resulted in it? So ALK gene is actually chromosome 2 related. So they will write translocation 2-5 to tell you that there is a problem in ALK gene. This was not at all expected in the FMG exam. If they have put it up there, they will put something similar to this in the INI-CET now, because FMG and INI, they like to pick each other's, they try to do that chori case ka question utha ke udhar dal do. So they try to do that. So remember, if they don't write exactly ALK gene, they will write translocation 25, and that is going to be indicative towards these three, that is ALK gene towards anaplastic lymphoma. और क्या बचा इसमें, ये खत्म कर दो. Ewing sarcoma अभी you will have, or you've had, probably you will have the orthopedic session, you will study about Ewing sarcoma. So why don't you tell me all the answers? Translocation क्या होता है, radiology में कहाँ होता है, which part of the bone does it occur in? So I'll start with that only. Which part of the bone does it tend to occur in? It tends to be in the diaphysis of the bone. Then every other question I have written for you. Radiology of Ewing sarcoma shows you what? It shows you that classical periosteal reaction. So onion peel, excellent. What is the translocation? यहाँ पर तो even path में question आता है. 1122, how did you learn it? When you say Ewings and sarcoma, it is obvious that it will be 11, and S से तो यही बन सकता है 22. Translocation, that's why I said ना दो ही याद करने थे. एक था translocation 1122, that was for Ewing sarcoma. Second, I told you infant for 12 and fibrosarcoma for 15. So 12-15 is going to be infantile fibrosarcoma. बस यही दो याद करने थे. Now if they ask you for Ewing sarcoma, what is the gene? Ewings sarcoma, तो EWS gene होगा, common sense. And which is the other gene? Wings will help you fly, so fly1 gene. So what is the fusion that happens? EWS and fly1 gene fusion happens. This also you know. Coming back, what is the microscopy? Microscopy is Homer writes pseudorosette. We will discuss this in a while. I hope you've not forgotten. Men are, sorry guys, but men are fake. So many times we've discussed this, है ना? So men are fake में, if you remember, all blastomas were showing you Homer writes pseudorosette. I'm not writing it here because I've written it somewhere else in the same PDF. Medulloblastoma, neuroblastoma, retinoblastoma. But which bone tumor shows you Homer writes pseudorosettes? It is Ewing sarcoma. So this is done. AIMS ka favorite question in, pick up any paper in the last decade and you will see that alternate year this question they have asked you, that which is the CD marker for Ewing sarcoma, or simple one-liner aata hai. What is the marker of Ewing sarcoma? It is either CD99 or MYC2 will be mentioned, and that is what you have. But if I ask you which is the ovarian tumor where CD99, I don't even want to ask you, you know it. If you studied from me, you know it even without revising. The 99-year-old granny, which you can never get wrong, that is going to be granulosa cell tumor. That is another one for CD99. I think all these questions are settled and we can move forward. Now let's move on to the next one, which is a question which I believe I decided बहुत toxic हो गया था, तो let me put up something which they know. Easy question, easy breezy question, which they will never get wrong, because after this I'm going to come to something toxic. The mutation seen in Cowden syndrome. तो सारी important वाला mutations I have put up over here. Mutation seen in Cowden syndrome is associated with which carcinomas? Have you forgotten 10-10-10? I hope not. As soon as I say 10-10-10, you know what is the gene that we are talking about. P10 gene. What is the chromosome on which it is present? It is 10 chromosome. What is the syndrome that we are talking about? Cowden syndrome. Now tell me what all is seen. Excellent. We all remember this. As I said, na, ye confidence booster after so much of toxicity. So what are the cancers that occur in it? Number 1, it has endometrial cancer. Number 2, it has thyroid cancer. Now INI-CET ना, तो कौन सा थायराइड कैंसर? पैपिलरी कार्सिनोमा थायराइड, फॉलिकुलर, मेड्युलरी, कौन सा वाला? तो पैपिलरी तो नहीं हो सकता मैम. पैपिलरी में तो वो ब्रैफ म्यूटेशन, अभी एक क्वेश्चन आ जाएगा, वो अलग है. वी आर टॉकिंग मोर अबाउट फॉलिकुलर थायराइड कैंसर ओवर हियर. More commonly follicular. Papillary नहीं mark करना. I'm not writing it here because that question is coming ahead. Papillary में BRAF mutation common होता है. Follicular is where you mark P10. Okay, now coming to what else with T? Some skin appendageal tumors. Which skin? This I've already got in the comments, right? Tricholemomas. Perfect. Tricholemomas में होता है. Another T. Then finally with P. P से what is not written over here? Polyps. GIT के वो polyps. वो याद है वो Peutz Jeghers वाला पूरा table, उसमें नीचे I have that again in this PDF coming up. P10 में भी polyps are seen. And what else when we were totally down and out कि अब कुछ नहीं बचा, यही fit हो सकता है. Even breast cancer can occur. So ultimately I realized everything can occur. This was not a question for marking. This was a question for revision. So 10-10-10 हो गया. Repeating polyps and breast, thyroid, follicular thyroid, endometrial. एक और question recently आया for follicular thyroid cancer. Which is the thyroid cancer which can spread to the bone and can show scalp metastasis? This was a surgery question. Which is was the only thyroid cancer that shows bony scalp metastasis. That was also follicular thyroid cancer. ये अभी PYQ you must have seen. Revising it one more time. The easy part is done. जो हमारे rapid revision में था, LRR में पहले भी किया था. Now I'm adding something which I have added in this time's update of version 11, and this is actually a PYQ only from INI-CET, but it was not a part of your rapid revision videos. If you're not viewing the updates, that's fine. आप LRR देख लोगे, your updates will anyway be covered when you are you are very short in time for INI, so don't spend too much time seeing too many resources. And many of you were asking me, is immunology also included here? So now you asked for it and you've ended up digging your own pit, and you're going to fall in it now. So we start with most important questions of immunology now. When I say affinity maturation, you've seen this in the past. Most of you are saying affinity maturation is due to somatic hypermutation. Okay, then अगले question का क्या answer है? In the naive B cells, when IgM and IgD are used as B cell receptors, which of the following is responsible for the same? So you are saying isotype switching? No, some of you are saying alternate RNA splicing. तो ये क्या है? What are we talking about? I'll try my best that in one slide and in the easiest diagram possible. I try to put this up to you. थोड़ा सा tough तब भी होगा, but we will try our best. So what I've done over here, I'll self draw it before showing you a picture. I have got an antigen. Let's say some bacteria virus has come, and listen to me just like a story. Story की तरह सुन लो तो याद हो जाएगा. If you go too technically into it, it becomes very irritating. Whenever an antigen comes, which is the first cell which will say, let me pick it up, it is going to be the B cell. B cell already has which two receptors? B cell के पास वो डिग्री है जिस डिग्री के लिए आप यहाँ बैठे हो. MD degree, the lucky B cell, God has given it MD degree by birth. के जाओ free में MD degree you will get. So as soon as this antigen will come, the antigen will be picked up by this MD degree. The B cell says, see, whatever God has given you, you want more ना. तो B cell के पास MD था. B cell says, I want super speciality now. I want to get all antibodies. So B cell wants that from Ig, M and D, we should end up making all antibodies. We should make all GAM-D antibodies. So it is becoming selfish, lalchi. It is becoming greedy over here. So now how should I do that? How should I convert MD? And I call B cell, if you look at the new videos, I have called B cell as the Nepo baby. The students had only told me in the recent classes कि मैम B cell is complete Nepo baby. वो कुछ काम ही नहीं करना चाहता. Firstly, it got MD degree for free. Then it says, I want to make all antibodies, but then it doesn't want to work for it. So what will it do? It says, I will take the antigen and I will just go and give it to my brother T cell. And let T cell do all the work. So T cell is not pagal that I will do free में I will get a degree for someone else. T cell says, okay, you are giving me the antigen, that is fine, but bribe me na, then only I'll do your work. मुझे कुछ extra पैसे दो, give me some extra money. So now the B cell says, I only have one thing to give to you. I have a CD40 receptor. T cell says, okay, I will bring CD40 ligand for it, and then CD40 reaction occurs. Now T cell says, okay, I am bribed. I have got my extra money. I will make the T helper 2 cells which will release interleukin 4, and interleukin 4 will do the job for you. So look at this Nepo baby. First, God gave him M and D for free. After that, T cell made interleukin 4 with the help of all this CD40, and T cell ended up making all the other antibodies also. So that is what B cell has done. So B cell, wish we were like B cell, MD भी free में मिल जाता, GAM-D भी free में मिल जाता. So can I say what is this process known as? This is known as isotype switching. You have switched from MD, you have made GAM-D, that is isotype switching. पहला concept समझ आया? I have a simple one-liner question for you. What is isotype switching? MD to GAM-D. Question 2. What are the things that help in isotype switching? 4 40 help in isotype switching, ma'am. 4 and 40. So 4 is interleukin 4, 40 is CD40. This is done. So I will write MD to GAM-D, I will write 4 40, and I will put a tick mark that I have finished isotype switching. But now, do you think truly B cell is Nepo baby? Let's assume I gave him MD for free, then I gave him GAM-D also for free, but he will have to work na to maintain MD GAM-D. So B cell says, अब बहुत हो गया Nepo baby tag, I want to get rid of it. I will also do something. B cell makes an enzyme called AICD. नाम सुनो और भूल जाओ, ठीक है? It is activation induced cytidine deaminase. They don't write the full form in the exam. They write activation induced cytidine deaminase ko they write AICD. Do you know AICD also goes and does the same thing? Because B cell is feeling humiliated कि सब लोग मुझे nepo baby बोल रहे हैं, तो मैं भी कुछ बनाऊंगा. I will also make AICD, and that AICD will also help in converting this MD to GAMD. And this entire process of what I have done, now I will show you the textbook photo that you can see. These are the B cells. This B cell normally was MD degree, and now I'm saying that because it is making this AICD wala enzyme, that is why it has ended up making this entire GAMD. This is known as somatic hypermutation. So basically I have changed. I have done a mutation in MD कि MD को बोला अब सिर्फ plain MBBS नहीं चल रहा था, plain MD भी नहीं चलेगा, अब आपको GAMD बनना है. So I have done a mutation in this MD. That is somatic hypermutation. How have I done a mutation in the MD? I have done it by AICD. So now what I'll do, that somatic hypermutation के आगे I will write the story of AICD. Is that okay? So that is what we've done. So ma'am, okay, you have made this GAMD. Shouldn't you be very, these antibodies should be so thankful कि हमें बनाने के लिए 440 also worked. Then AICD also worked. Don't you think these antibodies will now have an increased affinity to what? They will have an increase. They are grateful to whom? They'll say, why have we been made? Because some goddamn antigen came in our body. So don't you think they have an increased affinity to antigen? And what will this be known as? This will be known as affinity maturation. They are very mature. They are saying, we are very thankful. हमें बनाने के लिए so many people have worked. So I should be very thankful to the person who started it. And that is known as affinity maturation. So I have a question. Affinity maturation is due to this AICD वाला mutation that happened. Repeat with me. ये affinity क्यों बढ़ा? Why are these antibodies so thankful? Why are they having increased affinity? Because ma'am, ultimately a somatic hypermutation happened. It happened because of what? It happened because of AICD enzyme. Is that okay? 440, I'll repeat these three because now I'm just left with one more, and the toxicity of this session only will get over after this. Question, 3-4 words हैं which you need to be very clear with. Question number 1, what is isotype switching? When 440 are working and MD to GAMD is happening, that 440 story is known as isotype switching. Antibodies are changing. Simple. Switch is change. For change I need 440. Question 2. Has there been an element of mutation that has resulted in this change? Yes, that is known as somatic hypermutation. Which is the enzyme responsible for it? That is known as AICD. Coming to the third, these antibodies that are formed, are they having increased affinity for, or are they thankful to someone? Yes, they are thankful to the starting point. They are thankful to the antigen. That is known as affinity maturation. But now my question is, कितना easily बोल दिया MD से GAMD? How easy? Is it that easy to convert from MD to GAMD? And this is how they might want to give it to you, and INI don't get too confused कि अरे क्या दे दिया. It is very simple. What have they drawn? They are trying to tell you कि exon होता है, intron होता है. ये तो पता है ना? Have I written something very in some different language? नहीं मैम, exon होता है, intron होता है, exon होता है, intron होता है, ये हमें पता है. And now you tell me, do we remove all the introns normally? What is that process known as? Is this known as splicing? Yes. Is this known as splicing? Okay, some of you remind me, 1 hour done? Okay, no, 1 hour nahi done. We started 5 minutes late after orientation because I'm 3 slides away. Anyway, splicing. So splicing में क्या है कि ma'am intron is going to be removed, and I know that. So now tell me that if exon 1 and 2 will combine, मान लेते हैं IgA बना. If exon, tell me what is your wish? Exon 1 and 3 have combined, ma'am, then maybe IgE banega. Okay, then what is your next wish? Your next wish is exon 2 and 3 have combined, then maybe IgG banega. What I'm trying to tell you, that alternate combinations will form. Alternate splicing has occurred, and that is exactly what I'm trying to tell you in the question below. They say in the naive baby wala B cell had which degree? M and D. They are the ones which are used as B cell receptors. I know God has given them by birth M and D. Which of the following is responsible? Why is it that M bana, then D bana, then GAMD bana? ये अलग-अलग antibodies कैसे बन रहे हैं? How are they forming? They are forming by alternate splicing, because what have I done? If I make random alternate combinations, I will get different antibodies. So what have they done? See over here, they have randomly combined 2 things and they said IgM ban gaya. Then they randomly combined 2-3 things and they said, oh, IgD ban gaya. How is all randomly new antibodies forming? That is by alternate splicing. Okay, you want to call this the VDJ rearrangement. Okay, this means you've read a lot of बायोकेमिस्ट्री एंड आई एम सो प्राउड ऑफ यू. दिस इज अनदर वे ऑफ सेइंग इट कि हाँ ये VDJ का रीअरेंजमेंट हो रहा है, alternate थिंग्स आर जॉइनिंग, new antibodies are forming, and I'm done. Before I move forward, I'll just repeat. I was getting one question that, ma'am, if there is an AICD, I'll write it over here. If there is an AICD defect, तो कौन सी disease हो सकती है? So now you will only tell me this. Imagine this nepo baby, एक ही job इसको करना था, that is to make the AICD. It says I will not even do AICD का काम. Will it ever be able to change from MD to GAMD then? If the only job it is supposed to do making AICD, it doesn't make that also, then he doesn't deserve anything in life. He will not have any GAMD. MD to GAMD will not occur. What will that result in? Yes, hyper IgM. So now you will tell me hyper IgM syndrome can occur because of three things. Either there is a Char-Chalis problem, that is why MD to GAMD didn't occur. So Char-Chalis problem means there is a CD40 defect, or the only work that the nepo baby had to do is make AICD and it didn't make that also. तो AICD डिफेक्ट. प्रॉब्लम तो वही है ना, AICD नहीं बनेगा देन ऑल्सो MD GAMD विल नॉट अकर. Char-Chalis नहीं होगा देन ऑल्सो MD GAMD विल नॉट अकर. इन बोथ द सिचुएशंस द पर्सन विल लैंड अप विद हाइपर IgM syndrome. For everyone who was asking me this, before I move forward, because this is the toughest part of today's session and this is something which I expect in INI-CET, 30 seconds extra दे दो मुझे and now I will tell you. If I just say what is the process of MD to GAMD change known as, that change is just known as what? Isotype switching. How is it done? That is done by mutations. Which enzyme causes that mutation? Somatic hypermutation. It is AICD. If AICD is defective, then of course hyper IgM syndrome occurs. These new antibodies that will form, if they have more affinity for the antigen, what is that known as? Affinity maturation. Finally, how are so many antibodies forming? Because of that alternate splicing that we have occurred. And I think the tough part is done, which now gets me to कुछ easy बात कर लेते हैं मैम. Which of the following is a characteristic feature of Wiskott-Aldrich syndrome? Because इतना immunity बात करा, this is a question which somewhere I believe they have kind of forgotten. They have gone so much into the details of immunology that जो सबसे basic question था वो भूल चुके हैं, right? And this is something I feel that they might get back any moment. Which of the following is a characteristic feature of Wiskott-Aldrich syndrome? All of you are saying D, that is eczema. Okay, let's see what is Wiskott-Aldrich syndrome. We write it as Wiskott-Aldrich syndrome and that tells me the name of the gene. That is going to be the VASP gene. नाम से पता लग गया. Okay, VASP gene में कौन सा triad होता है? Bye-bye triad होता है. Number 1 patient says I'm having a lot of bleeding. Why bleeding? Bleeding तो तब होगा when the platelet will go down. Either the platelet count will go down or the platelet size will go down. तो thrombocytosis नहीं होता मैम, thrombocytopenia होता है. And whenever they say small sized platelet, now the only disease in path and medicine which has chota platelets is going to be Wiskott-Aldrich syndrome. No other place I will tell you that. Okay, then after the bleeding, next is infection, next is eczema. So eczema is the answer over here. Tell me the immunoglobulin profile. Before that, what kind of a disease is it? Is it autosomal recessive? No, this is an X-linked recessive disorder. Next, immunoglobulin profile. How did we learn it? Wiskott-Aldrich syndrome में we used to invert the M, W to M. तो क्या है? There is a decrease in IgM. It is not increase. Increase in IgM होता तो then तो we were talking about hyper IgM syndrome, right? This is not increase in IgM. This is a decrease in IgM. And whenever there will be eczema, eczema में which antibodies usually tend to be more? A and E tend to be more. So if IgM is low and A and E is more, that is the profile of Wiskott-Aldrich syndrome. So I have ruled out everything. The only right thing that I'm left with is going to be IgE, is going to be eczema. I have one question. If I increase IgM, right now all of you told me क्या होता है? Ma'am, it is hyper IgM. This is what you told me. And can I write hyper IgM is either a problem in the Char-Chalis or it is a problem in that nepo baby AICD? Is this a good tick mark? Hyper IgM, do I know? IgM increases is hyper IgM. IgM decreases is Wiskott-Aldrich syndrome. ठीक है. Next, what if IgG? Only they are focusing on IgG. Hypogammaglobulinemia, कोई disease याद आ रहा है? If IgG decreases, that is going to be Bruton's hypogammaglobulinemia. Do we remember B for Bruton's? It is a problem in the B cell. B for Bruton's is a problem occurring more in boys. B for Bruton is a problem involving the BTK gene and we are settled. तो उसमें IgG, hypogamma-globulinemia, IgG decreases. Last one, if IgE increases, I mean that is something which you can see in viscotaldric, but अगर बाकी सब नहीं लिखा, they don't have anything written, they only write one thing, hyper IgE, that's it. What is the disease that you think of? Very good, hyper IgE, no mention of any other antibody. अगर hyper IgE के साथ they would have written IgM is low and all that, bleeding हो रहा है तो viscotaldric. But if only hyper IgE था तो then I would think of job syndrome, and job syndrome का mutation भी बताते रहो. Leave your job stat, chill in life. Leave your job stat मतलब STAT3 gene defect is going to be seen in hyper IgE. Perfect. So these are all antibodies. I hope इसमें again I always like to give you those 20-second ultra quick revision modules. तो IgM बढ़ा हुआ है तो hyper IgM, IgM कम है तो viscotaldric syndrome. If IgE alone is increased, hyper IgE, job syndrome, leave the job stat, so stat defect. If hypogamma-globulinemia occurs, that is to do with Brutons. I think all antibodies, one flashcard we have made, and we can move on to the next one over here. This is something which is a very typical INI-CET type of a question, little lengthy. I hope the image is visible, which is now. So if you overall read, बीच में थोड़ा non-specific question लगेगा. It is a 27-year-old woman with lot of cervical lymph nodes, bilateral, increasing in size, multiple हैं, they are palpable. The largest one is huge, almost reaching 6 centimeters, and arms में भी nodules हैं, maybe axillary lymph nodes are there. Lymph node होगा तो हम क्या करेंगे? FNAC करेंगे from the largest lymph node. Image has been shown. I thought this was a giant cell. I mean, if I would have been at an undergrad level, मुझे लगता giant cell है. But giant cell के साथ फिर क्या होता? Will you think of TB? Does this show me this kind of a giant cell? No, TB तो shows me Langerhans giant cell, so that is out. Is this a case of Langerhans cell histiocytosis? Clinically it is not going, and Langerhans cell histiocytosis के लिए थोड़ी ना they will show me this giant cell, they will show me the tennis racket, which I will show you in a while. So this is also ruled out. Is it just a reaction? I mean reaction होता तो 6-6 centimeter के lymph node and in axilla, in cervix, all over the body, cervical, it is just not making sense. Finally, this is the only disease that fits into it, Rosai-Dorfman disease, and that is where I expect a question. ये PYQ 2019 में AIMS में आया था, before that INI-CET in life. That is where it came, and since then it has been an all-time favorite. This is not a giant cell, this is emperipolesis. Emperipolesis means cell-in-cell phenomena. So you actually notice this was a big cell. What is this? No one's asking you, ये सिर्फ आपका orientation है. This big cell is actually a macrophage, and it has eaten up these छोटा cells, only eaten up. Is there any phagocytosis, killing, कुछ और हो रहा है? नहीं मैम, ये बस एक ना time pass चल रहा है. One big cell says that okay, you can live inside me for some time, after some time you can exit. Entry, exit, free will allowed. So no one is eating anyone, no one is destroying anyone, no one is killing anyone. This is just a simple chill cell-in-cell phenomena called emperipolesis. It is seen in MARC. Number 1, myelodysplastic syndromes. The AIMS 2019 question was, it is seen in autoimmune hepatitis. Medicine में autoimmune hepatitis, please पढ़ के जाना. Next, Rosai-Dorfman disease, which is written over here, and also in CLL. I will tell you what is Rosai-Dorfman clinically. If you know the other name of Rosai-Dorfman disease, clinical आपको पता है. Do you know it is known as, very long name, sinus histiocytosis with massive lymphadenopathy. What does that mean now? Sinus histiocytosis with massive lymphadenopathy. So yes, do you agree with me on massive lymphadenopathy? Do you agree that someone having 6-6 centimeter के cervical and axillary lymph node is truly massive lymphadenopathy? I agree. Next, I say sinus histiocytosis. What is histiocytosis? Histiocyte is a macrophage. So that is what I was trying to tell you, that bada wala cell is a macrophage. And now read the name again. Sinus histiocytosis with massive lymphadenopathy. That shows you emperipolesis. This was not a question to be done on the image. Image was deceptive. No one at an undergrad level can measure this. This is not for your assessment. The assessment had to be done on the basis of clinical and more of ruling out कि TB के साथ फोटो नहीं फिट हो रहा, LCH के साथ फोटो नहीं फिट हो रहा, रिएक्शन के साथ क्लिनिकल ही नहीं फिट हो रहा. The only thing by ruling out I can come to with big lymph nodes is Rosai-Dorfman. Is that okay with everyone? Now we come to the next. यहाँ पे क्या लिखा था? FNAC was performed, obviously. So why don't we do a relay race and now go on to questions on FNAC, which is the image that is used in this OPD procedure. ये क्या है? This is, of course, it is not incision and drainage or tube insertion. It is FNAC. But is it FNAC or is it NNAC, again adding that INI spice to it. The INI tadka to it is it FNAC or is it FNNAC? So what is this handle that I'm seeing? FNAC के लिए कौन सा handle use करते हैं? What I call this a gun. It looks like a gun, right? A fancy gun. It is a Franzen handle. What am I going to put inside this Franzen handle? I will put this syringe and this needle. Question number 1. Needle का क्या size होता है? Usually 25 to 27 gauge PYQ. पतला सा needle होगा. You know ना, gauge number increases, the needle keeps becoming thinner and thinner, पतला. तो a very पतला needle is used because you are, let's say you are putting it in the thyroid. Thyroid is next to so many vital blood vessels. The needle has to be very thin, very patla, because by chance your hand is shaky and you end up pricking here and there, you don't want the patient to die. So very patla most needle, thinnest most needle you're going to pick up. So this PYQ is done. I attached it with a syringe. Syringe se to you will pull na, you will do aspiration. So this is aspiration cytology. FNAC is a fine needle, 25 gauge ka fine needle, aspiration cytology. Because if I would have given you only the needle and I would have said syringe is not used, means ma'am you are not aspirating, syringe nahi use kar rahe, you are not aspirating, then it would have been with fine needle, non aspiration cytology. Yahan to aspiration use kara, so this is fine needle, aspiration cytology. The questions don't end here. Yahan tak samajh aa gaya? Question 1 Franzen handle for FNAC, question 2 25 gauge needle, question 3 if you use a syringe you are aspirating, if you don't use a syringe you are not aspirating. Question 4 what are these situations? Do you want to do an FNAC? Yes, no, maybe. क्या होगा इसमें? Hydrated cyst में FNAC करोगे? In the liver, if there is, let's assume they are saying कि liver में ultrasound पे hydrated cyst लग रहा है. Do you want to do an FNAC? No, I don't want to. Because if you prick it, the fluid will come out. उस फ्लूइड से पेशेंट को एनाफाइलैक्सिस और डेथ हो सकता है. सो सेव द पेशेंट, सेव योर डिग्री, डू नॉट डू FNAC इन अ हाइड्रेटेड सिस्ट. ओके, डू यू वांट टू डू FNAC इन अ टेस्टिकुलर ट्यूमर? आई मीन इट्स नॉट कॉन्ट्राइंडिकेटेड. आप कर भी दोगे तो पेशेंट इज नॉट गोइंग टू डाई बिकॉज ऑफ इट. बट ethically, should you be doing in a testicular tumor, should you be doing FNAC? No, because there is a risk of spread. You are breaking the barrier. If this is a testicular tumor, you put a needle through it, you have made an opening, you made a break in the barrier. The cancer cells will spread out. So risk of spread hai. For testicular tumors also, I don't like to do FNAC. Next, is FNAC going to be useful in follicular carcinoma thyroid? It is not useful. Again, I'm not saying contraindicated hai, because imagine someone comes to you with a thyroid swelling. Just by looking at it with my eyes, I don't know na कि papillary hai ya follicular hai ya Hashimoto's thyroiditis hai. How do I know? It's just a big thyroid. I will put a needle in it. So I do FNAC in every thyroid swelling. But will it be able to give me a diagnosis of follicular carcinoma thyroid? And the answer is going to be no. Why so? Because this I get to another question, ma'am. For follicular thyroid cancer, the criteria, so much I did na about follicular thyroid cancer today. एक तो मैंने करा कौन सा म्यूटेशन हो सकता है, वो अभी P10 you were telling me Cowden. Then I told you this is the one that is going to also show you scalp metastasis. Now I'm telling you this is the one which cannot be diagnosed on FNAC. Because why? क्यों FNAC? FNAC is a patla sa needle. The criteria for follicular thyroid cancer says that you will have to see invasions. This capsule, can you see the capsule is broken? Capsule invade होना चाहिए. Then blood vessel के अंदर cancer needs to be sitting. Vascular invasion. One patla sa needle, that 25 gauge needle, will it be able to take out the capsule from the thyroid? नहीं. Will it be able to take out one full blood vessel from the thyroid? Again, the answer is no. So when you can't see it, you can't commit to the patient, right? When I didn't see the capsule and the vessel, how can I tell the patient you have follicular thyroid cancer or not? That is why for the diagnosis of follicular thyroid cancer, it has to be a biopsy. That is the gold standard. That is the investigation of choice. It is not FNAC. And that is everything about follicular thyroid cancer except one thing. Right now you told me P10 वाला Cowden syndrome वाला mutation होता है, वो तो as it is बता दिया था. But in surgery, ideally, which is the most common mutation that occurs in follicular thyroid cancer, it is the RAS mutation that occurs. It is RAS. Ab follicular thyroid ke questions done. Number 1 most common mutation RAS followed by P10. Question 2 FNAC kisi kaam ka nahi hai. I will have to do a biopsy because I want to see all of these invasions. Question 3 which metastasis can it show? It can show scalp metastasis. Now khatam karo. Follicular is done. Because you've done so much of FNAC, can you tell me कि अच्छा ये यहाँ पर coming back to our question, हमने Franzen handle से FNAC कर लिया, thyroid में कर लिया, तो thyroid के लिए what is the adequacy criteria? Again INI-CET PYQ. INI-CET PYQ over here, what is the adequacy criteria for thyroid FNAC? We follow the 6-10 rule. I have kept life simple. मैंने हमेशा क्या याद रखा, even in my practice I remembered 6-10 rule, because ऐसे पढ़ेंगे as the options, no one will get it right. I have decided I should see at least 6 groups. So let me draw them. I should see at least 6 follicular clusters or groups, and inside every group I should have at least 6 के बाद क्या 10. At least 10 cells should be present inside every group. I want to now ask you कि अगर ऐसे लिखा हुआ तो हर student mark कर देगा ना. When will they try to catch you? They will say this is a thyroid FNAC. Can you tell us whether this is adequate or not? Ab now become a pathologist and tell us. That is how they try to just add layers to every question. So now tell me, can you vaguely बैठ के बस exam में don't become overcritical कि एक एक cell गिन रहे हो and wasting your time. Vaguely try to find out, can I make 6 groups? I think I can. I can make one vague group here, one here, one here, maybe one here, maybe one here. मुझे बन रहे हैं, easily बन जाएंगे. 6 groups तो बन जाएंगे, and I don't want to count. Does every group have 10 cells? Obviously more than 10 cells I can easily see without counting. So is this adequate? Yes, this is adequate, and the point is okay. So 6-10 याद कर लो and that is done. Now, thyroid FNAC you have not done to see normal, you must have done to see some kind of a disease. तो कौन सी disease नहीं दिखेगी? As you said, follicular carcinoma नहीं दिखेगा, because follicular carcinoma के लिए I will have to do a biopsy. Indirectly, they asked you a question like this in one of the previous years. They didn't give you any photo, they give you a very, very lengthy question. That said, there is a female, anterior neck swelling since 4 years, धीरे धीरे it is growing in size, and whenever they want to say thyroid, they always, in clinics also used to say, na, moving with deglutition. तो मतलब they want to tell me thyroid. On FNAC, pathologist shows some microfollicular pattern, diagnosis of a follicular neoplasm. उसने vague दिया. Pathologist ने जब FNAC पे vague answer दिया ना, मतलब it is a follicular lesion that you are dealing with. That is why pathologist has not given a final diagnosis. So then they say there is a well encapsulated lesion, no vascular invasion, no break in the capsule, invasion नहीं है. Do you want to call it follicular carcinoma now? No ma'am, if there is no invasion, then I will say it is benign, and that is the role. If I would have seen all these invasions, I would have said follicular carcinoma hai, but if I'm not seeing, then it is a benign tumor. It is going to be a case of follicular adenoma, which I have put up over here. Now you will feel very weird that ma'am ने इतनी बड़ी tumors पढ़ा दिए. What I'm going to take you next is to the previous year question कि normal thyroid कैसा दिखता है, and that is a recent question. These days, 2 normal photos they love to ask you. One is a normal thyroid and one is a normal kidney glomerulus. ये दो normal photos हमें देख के जाना है. So one is a normal thyroid. How did you identify? I could see the thyroid follicular cells, and even a blind student right now will know. Totally, if you are blurred vision also, you know कि हाँ thyroid के अंदर कुछ colloid होगा pink color का. That is thyroid follicular cells. But then I can see one cluster over here अलग से. That must be the parafollicular C cells, and we know this is parafollicular C cells because it is going to release calcitonin, which gets me to a simple medicine question also, surgery question. मान लो all the cancers arise from follicular cells. Papillary carcinoma thyroid, follicular carcinoma thyroid, anaplastic carcinoma thyroid, all of these arise from follicular, but the only cancer that arises from the parafollicular C cell is medullary carcinoma thyroid. That is why medullary carcinoma thyroid का tumor marker is what? It is going to be calcitonin. आगे बढ़ते जाओ, it's a relay race today. Calcitonin will increase in medullary carcinoma thyroid and end up forming which amyloid? It is going to be amyloid of calcitonin variety. So a cal type of amyloid is going to be seen. अगला question, amyloid confirm करना है. What is that one tiny little thing that I will draw? What does amyloid show under the microscope? I hope it looks like an apple. Apple green birefringence is what you will see for amyloid. All these questions are coming up, and because like you said, I will just now अगला relay race चल रहा है ना, अगला set of questions is on amyloidosis only. But before that, tell me one more normal looking kind of cell for thyroid. ये thyroid का follicular cells था, ये thyroid का parafollicular cells हैं. If those thyroid cells change and start looking like big pink color cells, सब कुछ big pink color का मिला, तो Hurdle cells. Now they can write any name. Hurdle scientist लिखा, Ashkenazi scientist लिखा. These are oxyphil cells, oncocytic cells. ये सारे same नाम है. Basically any random name written for thyroid. Other than thyroid, if they write any other particular name for the thyroid gland, it is referring to Hurdle cells. और कोई cell होता ही नहीं है, तो या तो normal वाले thyroid cells होंगे या फिर they will write something of this variety. What do I mean by oncocyte? Previous year question. Oncocyte word is used whenever they want to denote a lot of mitochondria. So in simple words, Hurdle cell is composed of what? Ashkenazi cell is composed of what? Oxyphil oncocytic cells are composed of what? It is composed of mitochondria. That is why they look so pink in color. Hurdle cell. Excellent. Last question and we move forward. Hurdle cell is the hallmark of one thyroiditis and their favorite thyroiditis, which is Hashimoto's thyroiditis, which is obvious. Okay, now I've tried to show you pictures which I know on your own you're not going to see. I'm not showing you dumb photos like orphan annii nucleus, papillary carcinoma, wo to aap padhte hi ho. You know that. I'm trying to catch on things which for INI-CET on your own you would not be able to catch on to. So I think I have done that. And because you were talking so much about amyloid, तो अब amyloid के question and amyloid के दो tables कर लेते हैं. Which of the following statement is true concerning amyloidosis? Okay, for those, I don't know how many minutes or hours we are into the session, but we are on slide number 45. So I think we are doing good. Which of the following statement is true regarding, and that counting I'm not doing for myself, I'm doing for you so that you know kab tak baithna hai, till when do I have to survive, till where have I reached. So next I will let you know the moment we clock in the 50% of lecture, which should be somewhere around the 60th slide or so. So I'll let you know that half lecture done, half left, but it's going to be one shot. No one is going to ask me for a break because you're too close to the exam. Exam mein bhi to 4 ghante baithoge na, pre-exam, post-exam, orientation and all, setting your screen. So same 4 hours I'm asking for you today also. Same I will ask you in micro also. So asking too much, but let's get going. Which of the following statement is true concerning amyloidosis? एक एक करके पढ़ लेते हैं. SAA is a type in multiple myeloma. Hell no, multiple myeloma गलत नहीं कर सकते. Multiple myeloma में तो light chains होती हैं, तो that is AL type of amyloid. This is wrong. On Congo red staining, amyloid shows apple green birefringence. This seems to be a correct statement for now. Whenever you find a correct statement and your answer in the exam, overconfident nahi banna, read forward. You never know where the twist is lying, so never ever get your answer in A and B and settle with it. Always go through C and D. In AL type of amyloidosis, it is an acute inflammation, not at all. Acute inflammation में और basically inflammations में AA होता है. AL type of amyloidosis तो is in multiple myeloma. This is wrong. Beta 2 macroglobulin in systemic senile amyloidosis. No. In senile amyloidosis, which amyloid happens? ATTR. Anyway, macroglobulin तो वैसे भी कभी आता ही नहीं. When I say A beta 2 type of amyloid, किस में होता है? Hemodialysis के केस में. That is A beta 2 microglobulin. Anyway, let's revise now all these. I was right. I got my simple answer, which is great. But अब ये सारे amyloids एक बार revise कर लो. Firstly, if I ask you kidney में amyloid गया तो what kind of appearance does it result in? It results in waxy kidney. It looks, this is the only picture of waxy kidney that they have, by the way. और कोई photo ही नहीं है इनके पास. On Google they will give you this candle wax वाला waxy kidney. This is a case of amyloidosis. If you want to confirm what is the stain that you will put Lugol's iodine. Here is where you will make a mistake, because option A hoga Lugol's iodine, option B hoga Congo red. Our basic conscience is that when we read amyloid we say हाँ Congo red का answer है, mark करो खत्म. But the point is, if I ask you for amyloid, what is the gross stain that you are using? Congo red is what you see under microscope. Gross is what you will be adding on this kidney. Imagine taking a dropper and adding few drops of the stain on this kidney as it is, seeing it with your eyes. That gross stain is Lugol's iodine. If they say which is the best microscopic stain, then I agree with you, it is going to be Congo red. Understood the difference? Congo red mein I'm not writing. It is going to show you that apple green birefringence. Can you just tell me which microscopy do you see the apple green birefringence on? It is going to be the polarizing microscopy. But hum itne rich hai hi nahi, ma'am. We don't have a polarizing microscope in our lab. We have the usual garib wala light microscope in our lab. Can I add Congo red and see amyloid? Yes, we will get the salmon pink color. So they will give something to do with salmon pink color on light microscope. That is also repeating Congo red lagaya. If you have the usual light microscope, you will see salmon pink color of amyloid. If you are rich and you have a polarizing microscope, then you will see the apple green birefringence. But if you are even richer and you say I have UV light also, in my lab I have UV light, now which stain can I use? I will say TUV. So if you have UV light, you will use thioflavin T. Then you are further, you are an extreme, you are Ambani, मतलब आपके पास electron microscope भी पहुंच चुका है आपके lab में. You are very very rich. So then I will say that okay, on electron microscope I will be able to see the diameter of amyloid. Only the diameter you have to learn, and that is going to be 7.5 to 10 nanometers. Previous year question. But now you have a question, ये apple green birefringence क्यों दिखा? Because AIMS is always like, AIMS is not interested in asking you fact. AIMS will or INI will get into it and say कि अच्छा क्यों दिखा? Why apple green birefringence? What do I mean by birefringence? It means having two refractive index. तो ऐसा क्या है? Amyloid कैसा दिखता है? Why does it have different refractive index? Because it looks like this. It looks like beta pleated sheets, and because of beta pleated sheets, it has, imagine na, light is going through this, so light is going through different planes. दो रिफ्रैक्टिव इंडेक्स हैं अमाइलॉइड के, दैट इज व्हाई इट शोज यू बायरेफ्रिंजेंस. हाउ डिड आई गेट टू नो दैट इट हैज टू रिफ्रैक्टिव इंडेक्स? इट लुक्स लाइक अ बीटा प्लेटेड शीट. ऑन विच टेक्निक? ऑन एक्सरे क्रिस्टेलोग्राफी. सो नाउ ग्रॉस रैपिड रिवीजन करते हैं. LRR का फर्दर LRR, ग्रॉस के लिए कौन सा? लुगॉल्स आयोडीन. माइक्रोस्कोपी के लिए बेस्ट वाला कॉन्गो रेड, बट इफ यू हैव UV लाइट यू विल यूज थायोफ्लाविन टी. इलेक्ट्रॉन माइक्रोस्कोपी का डायमीटर 7.5 to 10 nanometers. Beta pleated sheath, how did you get to know? On X-ray crystallography. One last question. You have a patient and you want to know two questions which I have added also in rapid revision version 11. How do I know the extent of amyloidosis? That okay, 10%, 20%, 50%, itna body is affected. What is the technique that we have now found for doing the extent of amyloidosis? It is known as scintigraphy. A very an AIMS vibing wala question. So scintigraphy is done to know the extent of amyloidosis. Question 2. There is a patient of amyloidosis, any random amyloidosis, they will write AA, AL, ACAL, and he has landed up with bleeding. This is the point that I have added up also. Amyloid और bleeding को कैसे correlate कर रहे हैं? How is that making sense? Patient has, I'll write it over here. Let's assume patient has amyloid. I will write all these AA amyloid, and this patient has landed up with bleeding episodes because amyloid has a property. Amyloid acts as a magnet for factor 10. Amyloid says that I will to keep factor 10 with me. Factor 10 was supposed to make blood clot. Factor 10 was supposed to make all my clotting pathway and make my blood clot, but now this factor 10 is all busy with amyloid. So what will end up happening? Indirectly, I will end up having less of factor 10 to work in my body, and I will end up with bleeding. So they will ask you why in amyloidosis, if they give you those, although pathology doesn't get you too many assertion reason type of questions, but if they want to give you that there is a patient of amyloidosis and presenting with bleeding manifestations, the reason would be that amyloid tends to absorb all the factor 10. There is no factor 10 available. That is why patient lands up with bleeding. Okay with everyone? Can we move forward? This is something which I'm not going to go into detail. इसका एक 15 second में फटाफट बता दोगे? Will you quickly tell me, just tell me the different amyloids in each one of them. Initially, I thought I will give it to you like a bonus slide, but you guys have been very nice and cooperative, so I thought that why not finish it. But yes, 15 seconds is all that I've got for this, okay? So for all inflammations, cancers, fevers, which kind of amyloid? Very good, AA. All chronic inflammations except one which I'm sure you know, that is chronic bronchitis में there is no amyloid. बाकी सब में all inflammations, cancers and fevers AA. Tell me for medullary, you've already told me calcitonin वाला. Tell me for these tough वाला, old age वाला amyloid is also TTR amyloid, and nerves वाला polyneuropathy amyloid is also TTR, but the difference is as the age of the patient will increase, it's the quantity of TTR is going to increase. Whereas if the nerve is a problem, it is a mutation in TTR that is going to happen. That's the only difference. So age बढ़ा, quantity बढ़ा, nerve में problem, so it is a mutation. Coming to Alzheimer's, we had studied if there is one brain, which I hope we are left with till the exam, it is one beta, so A beta type of amyloid. And in hemodialysis, because we have two kidneys, so it is A beta 2 type of amyloid that we have. Multiple myeloma is AL type of amyloid. This you know, one rata question, but will get you a question. Out of all of these, the only primary amyloidosis is multiple myeloma, because everything else other than multiple myeloma comes under secondary amyloidosis. ये आजकल इनको basic वो second prof वाला classification में जाने का मन है. Okay, can we move forward without spending any more time on this? Another PYQ coming your way. Which method is employed for the detection of autoantibodies? You remember this question of AIMS, which everyone was very tensed about. Let me just rule out and see. फिश कब करते हैं? फिश तो करते हैं फॉर क्रोमोसोमल थिंग्स लाइक ट्रांसलोकेशन एंड ऑल, नॉट फॉर एंटीबॉडीज. PCR, ma'am, you have already spent so much of time on PCR for genes, genetics, ruled out. So immunofluorescence is what you're talking about. And there are two immunofluorescences. I'll tell you in one simple word, and there is no other way of solving the question. If you want to detect antigens, you will be doing direct immunofluorescence. If you want to detect antibodies, you will be doing indirect immunofluorescence. Question में क्या पूछा? You want to detect auto antibodies. Antibodies के लिए क्या करते हो? You do indirect immunofluorescence. So simple, direct immunofluorescence for antigen, indirect immunofluorescence for antibodies. And now when I'm saying immunofluorescence, does that ring a bell? Have you been troubled with one immunofluorescence which has given you sleepless nights? And that immunofluorescence has to do with all these autoimmune disorders. Yes, these immunofluorescence patterns that we study. So here you have four patterns over here, and then now from here you will be able to tell me कि अच्छा कौन सा pattern select करें for CREST syndrome. Meanwhile, as you decide कि अच्छा कौन सा pattern select करें, I will take that opportunity to do an ultra quick revision of what is CREST syndrome so that something comes back to your mind. CREST syndrome में patient has a lot of things happening in the fingers. So सबसे पहले you will see calcinosis के big nodules of calcium on the fingers. Another thing, color changes of the fingers, temperature वाला color change, Raynaud's phenomena. Then you will see sclerodactyly. The fingers will not, you won't be able to open the fingers like this. The fingers will be very stiff, like something like a claw hand, you can say. So sclerodactyly will happen. Other than that, the esophagus will be not having proper motility. So eating food, swallowing will be a problem. And there will be dilated blood vessels, telangiectasia. That is CREST syndrome. Meanwhile, most of you said that CREST syndrome is going to be answer option D. So you know what I'm going towards. I'm going towards all the patterns on immunofluorescence for anti-nuclear antibodies because autoimmune disorders. तो अभी immunofluorescence का एक question तो हम करके आए थे. Direct immunofluorescence कब करते हो? When you are wanting to check antigens. Indirect immunofluorescence you do when you want to check antibodies. And on Monday when we will meet, we will talk about this fluorescent जो पढ़ रहे हो ना, fluorescence, immunofluorescence, तो fluorescent microscope में पढ़ रहे हो ना. Fluorescent microscope के दो questions micro में integrate होंगे. Which is the light that you use in a fluorescent microscope? Ultraviolet light. What is the mirror that you use in a fluorescent microscope? It is going to be dichroic mirror. If you know this, excellent, amazing. If you don't know it, Monday तक का wait कर लो, you will know it eventually, but ideally you should be. Anyway, ये बाद की बात. अभी coming back, what other questions do I get on immunofluorescence are this, and how do I test for patterns of anti-nuclear antibody? It is tested by this mnemonic which makes no sense, and that happens with a very weird spelling, but there's no other way to learn it. So there are two ways, and when you suddenly you'll see I'll decrease my speed because when you get this question in the exam, remember my words that if you're solving questions at let's say a 2x speed, please come back to 0.5x speed. इस वाले question पे give it that full 1 minute that it deserves. Be very slow in attempting this question. Attempt it in two layers. पहले photo को देखना, stare at it till it starts talking to you. Stare at the picture. Number one, I notice that the entire nucleus has become green. पूरा homogeneously green. I will first only talk about what is seen. Homogeneously green. This means the antibody has actually gone and attacked every aspect of the nucleus. It has attacked the chromatin, it has attacked the histone, it has attacked basically the entire nucleus. The anti-nuclear antibody has attacked the entire nucleus. ये समझ आ गया? Anti-nuclear antibody, entire nucleus तो homogeneous दिखा. In the next one, what did I notice? I saw over here, it is particularly the periphery that has become a little more green. So I called it the peripheral or the rim pattern. Let us draw it. This is how it's looking more green at the periphery, and how I have drawn it. Imagine a DNA sitting over here, because this time the antibody has only gone and attacked the double-stranded DNA. See, you need to, यहाँ पर concept वाली बात आ जाती है. You need to understand, we always feel nucleus and nucleus is made up of DNA. No. DNA is just one thing that the nucleus is made up of. Nucleus has the entire world in it. Nucleus has chromatin, nucleus has histone, nucleus even has little bit of RNA, it has DNA, it has ribose, it has so many things. So now which part of the nucleus are you attacking? If you are attacking everything, you will get a homogeneous pattern. If you are only attacking the DNA part, you will get a peripheral or rim pattern. if there are antibodies that are going to be against the RNA specifically, imagine this is the nucleus, a pura nucleus you're not attacking, you are only attacking that one tiny little dot in the center, that is actually a little bit of RNA present, and that is known as the nucleolar pattern. Nucleolar is going to be one RNA that you are attacking over here. Then coming to speckled, speckled mein kya dikh raha hai? The entire thing is, in a way, if you look carefully, you feel that the entire, is it homogeneous? Let me rule out for you. Is it homogeneous? नहीं मैम, कुछ तो मुझे बीच में मिसिंग लग रहा है, समथिंग लाइक अ ब्लैकिश, some part is missing, it's not fully green, it is not homogeneous. Second, is it only peripherally green? No. Is it just one tiny dot nucleolar? No. This is green but not green. That is how I learned it. It is mostly green but then not green also, so that is known as the speckled pattern, which you see in almost every kind of autoimmune disorder. Can you tell me? Anti-Smith antibody is the antibody for which autoimmune disorder? SLE. Anti-Rho and La antibodies are for which autoimmune disorder? Sjogren syndrome. So can I say speckled pattern can be seen in any autoimmune disorder? It is the most common pattern that I notice. Now if I ask you this question, as soon as you start seeing कि क्रोमोसोम्स, ये वो माइटोसिस में पढ़ते थे ना स्कूल में, कैसे क्रोमोसोम्स आर गेटिंग अलाइंड, दे गेट अलाइंड इन द सेंट्रल प्लेट. व्हेन यू स्टार्ट सीइंग क्रोमोसोम्स गेटिंग हाइलाइटेड, दैट इज द सेंट्रोमेरिक पैटर्न. इट इज द एंटी सेंट्रोमेरिक एंटीबॉडी विच इज द कॉजेटिव फॉर क्रेस्ट सिंड्रोम. क्रेस्ट सिंड्रोम किसकी वजह से होता है? इट इज एंटी सेंट्रोमेरिक एंटीबॉडी. विच pattern will you see? Obviously D. Can you now mark over here ये कौन से patterns हैं? What is this? Without zooming in guys, because you will not have the option to zoom in the exam. So what is this? Full green. This is the homogeneous pattern. Next one, the periphery is green, so peripheral pattern. Next one, there's only a dot, so nucleolar pattern. The next one, I can see proper chromosomes getting highlighted. That is the centromeric pattern. That is anti-centromeric antibody for Crest syndrome. Are we okay? Immunofluorescence के कुछ questions बचे हैं. Yes, but I had thought that I'll give you as bonus slides, but then now you guys have been very nice with me and very cooperative, not asking for break, not asking for any extra silly mistake wala questions also. So then I've decided I will revise this, but I'll keep a target of 2 minutes. Jitne bhi immunofluorescence patterns of dermatology that can be asked for you, we will quickly finish off those also, so that immunofluorescence pura jo INI ka ek core topic hota hai settled for us. Quickly what you'll do from the clinical, you'll go to the histopath, you'll go to the immunofluorescence and you will finish it off. Very good. Flaccid, bilkul fuss wala, flaccid wala bulla, that is pemphigus. Amazing. And when I say pemphigus, number one you think of pemphigus vulgaris and then you think of pemphigus foliaceus. Pemphigus foliaceus is first wala desmoglein. Only desmoglein 1 is affected. Whereas pemphigus vulgaris mein, it is desmoglein 3 and 1 both that are affected. This is, I'm just revising quickly because derma bhi to karna hi hai, right? So foliaceus mein first, vulgaris mein dono 3 and 1. Foliaceous में first वाला layer is going to get split, so that is stratum corneum. The first वाला layer is split. So what is the split? It is going to be first वाले layer में subcorneal split. Whereas in pemphigus vulgaris, the basal layer, stratum basal, is left, and the split is occurring above it. It is a suprabasal split, and these basal layers are standing as it is, like stones. In a graveyard, you see those tombstones. So that is known as the row of tombstone appearance of pemphigus vulgaris. दोनों में flaccid fuss वाला, if you want me to write flaccid bulla दिखेगा. दोनों का immunofluorescence will show you which pattern, their favorite. Fishnet दिख ही रहा है fishnet. They don't write fishnet. They don't even give you the picture. They will write reticular word for it. Something that doesn't match at all, but then that's INI-CET, right? So if they say there is this kind of a clinical or a histopath image with a reticular immunofluorescence given, they are talking about the same fishnet pattern. This was pemphigus. अगर fuss वाला flaccid bulla की जगह I make it a very tense bulla which has the fluid filled inside it, then I will be thinking of bullous pemphigoid. Bullous pemphigoid, the full epidermis is going to go away. It is a subepidermal split, and inside this, what do you see? You see a lot of eosinophils. Lots of eosinophils are noted. Full epidermis has gone. So what kind of an immunofluorescence do you see? A linear बोले, ribbon, candy बोले, ribbon, line, कुछ भी अपना imagination करें. Basically one line has to come, and this is where the dermatology question comes. How do you differentiate between bullous pemphigoid versus EBA? Because INI-CET में ऐसा ही question आएगा. Epidermolysis bullosa acquisita. पहले तो दोनों का मुझे defect बता दो. When I say bullous pemphigoid, there are antibodies against bullous pemphigoid antigen. There are antibodies against bullous pemphigoid antigen. Whereas in epidermolysis bullosa acquisita, acquisita, the defect is going to be in collagen 7. दोनों में कौन सा pattern दिखता है? दोनों में I can see a line, I can see a linear immunofluorescence in both. But if I see a linear immunofluorescence on the roof of the bulla, on the top part, bulla is a cavity na. Imagine this, if I see the linear immunofluorescence on the roof of the bulla, it is bullous pemphigoid. If I see it on the floor of the bulla, that is going to be epidermolysis bullosa acquisita. Repeating, if I see it over here on the roof, that is BP. If I see it over here on the floor, it is EB. And we had learned bullous pemphigoid sounds like God, and we all believe that God is above on the roof. And epidermolysis bullosa acquisita sounds like aqua, water. We believe water is all on the ground. So for there, we will say this is going to be present on the floor. God is above, water is below. So pemphigoid is above on the roof and EBA is going to be on the floor. This is also done. एक और चीज़, अगर they say कि same, epidermis gone, subepidermal bulla, but now there is a history of person consuming some gluten wala food. Now the story becomes that one of those barley, rye, oat and wheat, celiac disease का gluten wala history दिया है, and they give me a subepidermal bulla. I'm thinking of dermatitis herpetiformis. We have always learnt it as dermatitis herpetiformis because it shows you the tip lesion. Tip ऐसे एक पहाड़ जैसा, एक mountain जैसा tip बनता है. Which antibody is making this mountain or tip? It is IgA. Why IgA? Because ma'am, when someone had gluten, which antibodies formed? IgA antibodies formed, and now that IgA has gone in the skin and resulted in what? Dermatitis herpetiformis. What is the drug of choice for dermatitis herpetiformis? It is dapsone. Celiac ki history. So this means if you want to control dermatitis, you will also have to control the diet. Dietary factors will also play a role. Now that you mentioned this celiac disease, and because we are running a relay race, I have only 2 questions of celiac disease for INI-CET exam. वो barley, rye, oat, wheat तो आपको पता है. My question is, which HLA polymorphism occurs over here and what is the name of the criteria? Tell me those 2 questions and we move forward. HLA कौन सा? DQ2, DQ8? Before, I don't want to wait for that lag. DQ2, DQ8 polymorphisms are responsible for celiac disease. Amazing. And what is the name of the microscopic criteria in medicine and path? They ask you for celiac. It is going to be the Marsh criteria, which is the derma finding with celiac disease, bro cereals. It is going to be dermatitis. This is done. Abhi immunofluorescence is still not over. Can you tell me what is this immunofluorescence? I mean, all of them look the same, but then why so many? Why are there 6 photos put up? And now I will label it. This first photo is of IgM, this next photo is of IgA, the next photo is of IgD, the next photo is of C1, C3, maybe another complement protein over here. What is this? Amazing, ma'am. So many antibodies are there in the same organ. And then they will give me a history of kidney. Yes, this is a full house effect. Full house means all antibodies and all complement proteins are getting deposited in the kidney, which is seen in SLE. But if in medicine they would have asked me, ये तो obviously full house effect किस पे दिख रहा है? Fluorescent microscope, that is why we are reading. But SLE in the kidney on light microscopy shows you what? The wire loop lesion. SLE in the kidney on electron microscopy shows you what? It is going to be thumbprint appearance. So if they say light microscopy, you will be marking wire loop. Fluorescent microscopy, you will mark full house, and electron पे तो दिख ही रहा है thumbprint. That is known as SLE. They might want to write it as lupus nephritis, which pretty much means the same. Is there any other immunofluorescence left? Yes, one last is left over here. So this is again, you can see these gola structures will always be glomerulus. Although I'm being mean over here, they'll give you a history. Huh? They will write something to do with kidney, proteinuria, hematuria, वो सब लिखा होगा. We are trying to skip that line and come to the real point. So what are these 2 immunofluorescences? Can you just differentiate between the 2, because everyone has told me ma'am kidney का immunofluorescence में problem आता है. So let us zoom in and see. Here I see the same green color as if I took a green color pencil, and everywhere with the same green color intensity I have drawn. But here I think I have made some areas shining more. Some areas are a little dull like this. Then suddenly in between one star is shining. Amazing. So the first one that we have is the linear pattern. When I say linear, and I hope you don't get confused, ये linear pattern कहाँ है? ये kidney में linear pattern की बात हो रही है. So I will think of RPG and type 1, which is Goodpasture syndrome. Whereas some time back, when I showed you the linear pattern in dermatology का बुल्ला वाला question, it was a difference between BP and EBA. वो derma का linear pattern था. ये kidney का linear pattern है. Here I'm talking about RPG and type 1. Goodpasture syndrome. Please revise 1, 2, 3, 4 with me for Goodpasture syndrome, because for my own satisfaction, I will know that I have completed the topic. What is 1, 2, 3, 4 of Goodpasture syndrome? It is RPGN1, which is showing me the linear pattern. I mean, obvious. Which type of hypersensitivity reaction is it? Antigen-antibody reaction. Am I hypersensitivity to? What did I say? Antigen-antibody reaction. So antibodies against what? Antibodies against the alpha-3 chain of which collagen? Of type 4 collagen. What is type 4 collagen? It's nothing but the basement membrane. Excellent. All of you have been very kind in revising everything with me. Perfect. Now let me move forward. ये तो RPGN 1 था. 1 में एक line जैसा, 1 जैसा होता है ना, line जैसा linear pattern देखा. Whereas over here you said this is like stars are shining. Do we all agree with this, or you are just being kind to me कि ऐसा मैम ने बोला तो हमने मान लिया? Can you truly see that some areas are shining a little more green in color? That is the starry sky appearance which you see in RPGN2, because RPGN2 basically includes what? Things like PSGN. So if they say PSGN shows you starry sky pattern or RPGN2 shows you starry sky pattern, it's the same. PSGN आगे जाके ही तो makes RPGN type 2 ना. Now tell me, PSGN occurs in which population? It occurs in bachas, pediatric population. And IgA nephropathy occurs in which population? Adults. Both of them in the future can form RPGN type 2 and both of them can show you the starry sky pattern. So I think this is settled for us. Starry sky, okay, very good. Because INI tha, I thought ये तो बहुत basic है, आता ही होगा. Starry sky is also seen in that Burkitt's lymphoma, very good. Starry sky is seen in PSGN and RPGN type 2, यह भी पढ़ लिया. Starry sky radiology में भी दिखता है. One brain वाला कीड़ा, brain wala parasite, it is neurocysticercosis also shows you that starry sky pattern. Just random revision. Anyway, let's come back to our point. Is there still any other immunofluorescence left? And I promise this is the last one. After this we will be done with this irritating immunofluorescence once and for all. But you have realized that we picked up a topic, one topic which sounded very small, called immunofluorescence, but in that I have finished the kidney part also, the vasculitis part also over here, then we've done dermatology, we've done the micro revision also. So if you pick up topics like this and do a relay race, which I know is very difficult to do on your own, but that's why LRRs are for, that relay race will actually help you touch upon almost everything that will integrate it under one roof, right? And that finishes off the last immunofluorescence. ANCA, anti-neutrophil cytoplasmic antibody. Pura nahi puchenge. They will ask you C ANCA, P ANCA. Naam batao, disease batao, over. And the best part is they don't tell you to identify on the basis of the photo, because so many of you have sent me screenshots, ma'am, P ANCA, C ANCA ka photo nahi samajh aa raha. Samajhna hi nahi hai, to why are you breaking your head over it? Na? They will never give you a photo like this and say batao. They will give you either some history or they will write some hint about the name, and then the photo becomes useless. Don't pay that attention on the photo. You just need to make sure, what have they asked me? Have they asked me C ANCA or have they asked me P ANCA? C ANCA ka naya naam, what are the new names of C ANCA? It is PR3 ANCA. What is the new name of P ANCA? It is MPO. Don't get confused. C ANCA का दूसरा नाम CPR, okay? C ANCA का दूसरा नाम PR3 ANCA, and P ANCA का दूसरा नाम, other name is MPO ANCA. Now if I see Wegener's granulomatosis, that can show me both. Blood test of Wegener's granulomatosis will show me both C ANCA and P ANCA, but if I have to select one over the other, it is going to be C ANCA over P ANCA. I think we all remember that World Cup story which we keep doing, कि World Cup में हमेशा याद रहेगा, World for Wegener's. Wegener's shows you both C ANCA and P ANCA, but C comes first, so C ANCA more common than P ANCA. After this, everything in the entire world shows me P ANCA. Now the best part is Wegener's is the only thing that can show me World Cup C ANCA. बाकी पूरी दुनिया क्या show करता है? P ANCA. So they ask me, can Wegener's show P ANCA? Yes. Sherk-Strauss syndrome, microscopic polyangiitis, सब में P ANCA. Tell me one disease of the intestine which shows you P ANCA, one disease of the liver that shows you P ANCA, सब में P ANCA जाएगा. One disease of intestine, you know it, ulcerative colitis. One disease of liver, primary sclerosing cholangitis. All of these tend to show you the P ANCA. मतलब जब doubt हुआ, सब में P ANCA. The only place C ANCA comes is going to be your Wegener's. Finally, all the immunofluorescence is done. Before I move on to the next topic, I have one ऐसी non-toxic question, because बहुत ज़्यादा extended हो गया ना for ANCA and for immunofluorescence. So let's come to this. Which of the following are pathognomic for malakoplakia? Another INI-CET. Anyone who marked asbestosis, you have slept off, so wake up. Asbestosis तो वो dumbbell shaped वाला body था, which is going to go and affect the lungs. I will always get a history of shipyard industry. I mean, I'm trying to squeeze in as much as of revision that you can. तो ये asbestosis तो नहीं है. Then I think of ash of bodies. Then again you've slept off because ash of bodies are seen in rheumatic heart disease. Again wrong. Then Samoma bodies, so if you've marked, then I'm truly upset. It cannot be Samoma bodies. For Malakoplakia, you know it is a case of Michaelis-Guttman bodies. So let me just ask you the quick questions. What is Malakoplakia? It is a problem in which pathway? It is a problem in a phagocytosis. Okay, this is a picture of a urinary bladder, and in the urinary bladder I can see these yellow plaques. Honestly, if I would have seen this on a cystoscopy, if I would have seen this with a camera on the screen, these yellow plaques inside someone's urinary bladder, I would have thought of urinary bladder cancer and I would have been very worried for that patient. I would have immediately taken a biopsy and sent it to myself, that is to a pathologist, and I would have seen it under the microscope and been very happy कि cancer नहीं दिखा, because Malakoplakia seems to be like cancer but it is not cancer. I was very happy because all that I saw was blue color calcium, and that blue color calcium is Michaelis-Guttman bodies. Okay, so that is made up of calcium. Michaelis-Guttman bodies are seen in Malakoplakia. They are made up of calcium. They look like cancer but they are not cancer. Okay, so where are the calcium present? So this is actually a problem. किसमें बोला? Phagocytosis. Phagocytosis मतलब macrophage. Macrophage is wanting that I should eat all bacteria and I should do phagocytosis like I always do, but it can't. So all that bacteria ends up sitting inside a macrophage and उसी के ऊपर calcium आ गया. So this calcium over here is the Michaelis-Guttman body, and this entire macrophage, as all our knowledgeable students were telling us, this is what this cell is known as the von Hansmann cell. तो अब basically 3 fancy words हैं जिसमें story खत्म हो जाती है. LRR का LRR we are doing after every slide today, right? Malakoplakia is the first fancy word. That's the name of the disease which mimics cancer but is not. Question 2, what bodies does it show you? Michaelis-Guttman bodies which are seen due to calcium deposition. What is the name of the full cell inside which Michaelis-Guttman bodies are seen? The name of the cell is the von Hansmann cell. किसी ने ऐसा बोला von Cosa stain. So now you have started your own relay race. I had done 90% of it. Bacha, you have done. Very good. For calcium also, what stain can we use? We can use von Cosa stain. Very good. So everything about Malakoplakia now becomes von Cosa stain wala calcium bodies are seen, von Hansmann wala cell is seen, which is amazing. Excellent. Okay, now after one random question we come to this. I think you remember this from INI-CET. This, by the way, was an LRR find. Till 2 years ago, this was not a part of the main videos of rapid revision because we were like, ये बहुत difficult है, MD level है, ये नहीं पूछेंगे. That why in immunohistochemistry do we get a brown color? And randomly someone asked me in LRR once and I just mentioned it to the student, and that LRR was 2 days before the exam and it ended up in the exam 48 hours later, and we couldn't have been happier. This question has been an LRR find. So what is the brown color of immunohistochemistry? Because of it is diaminobenzidine. और क्या question आ सकता है इसमें? What is FITC? FITC का full form नहीं पूछ रहे. Fluoroisothiocyanate, कुछ तो fluoro है, something that shiny fluoro, but that is the fluorescent color that you use in flow cytometry, which I am coming to write after this. तो flow cytometry का question आएगा, तो I will mark with stain, I will use FITC, but यहाँ पे brown color of immunohistochemistry was asked, that is diaminobenzidine. Nothing more to tell you in this one. Benzidine कौन सा कैंसर करा सकता है? Asking you from medicine. Benzidine कौन सा कैंसर कराता है? Benzene कौन सा कैंसर कराता है? That's the tough part which they will ask. If they sound so similar, right, but they cause totally different cancers. If they say benzene is a risk factor, that's a risk factor for blood cancers like AML. Benzene से AML, whereas they say benzidine इससे bladder का cancer होता है, urinary bladder cancer. Repeat with me, benzene, AML, benzidine is urinary bladder cancer. This was off track. On track is, why is the brown color in immunohistochemistry? That is because of diaminobenzidine. सिर्फ DAB याद करके जाओगे चलेगा. So now that you've started with immunohistochemistry, you know your next set of 5 questions are everything about IHC that they will ask you in the exam. There is a very छोटा सा बच्चा, 3-year-old baby, vaginal mass. The vaginal mass has been shown over here. Does it look like a bunch of grapes? Whenever they show you this kind of a bunch of grapes, you're talking about sarcoma botryoid. Sarcoma because it is a cancer, and botryoids means it is a bunch of grapes. Okay, now they say there is a tumor. Which immunohistochemical marker is going to help in the diagnosis? Most of you are writing A, vimentin and vimentin and desmin, because as soon as you say sarcoma, ma'am, every sarcoma will be positive for vimentin. तो vimentin वाले मुझे 2 answers देखने थे, but when I say this is actually which kind of a sarcoma, let's write everything. It is an embryonal, क्योंकि छोटा baby में था, Rhabdomyosarcoma. Rhabdomyo basically means skeletal muscle. Skeletal muscle के लिए पहले तो sarcoma के लिए क्या करा? Vimentin करा. Skeletal muscle के लिए we do desmin and myo D1. So that is why the answer is desmin and myo D1. If it would have been, let's say, a 33-year-old woman with a uterine mass, repeating 33, 43, 53, जो मन कर रहा है, some old woman, 33, 43, 53-year-old woman with a uterine mass, and they would have said that uterine में क्या होता है, uterus में तो smooth muscle होता है, तो वहाँ पे थोड़ी rhabdomyosarcoma होगा. smooth muscle का कौन सा कैंसर होगा? It will be leiomyosarcoma. तो uterine हो जाता है, it would have been leiomyosarcoma. Then for sarcoma you would have still selected Vimentin, but for smooth muscle what would you have selected? You would have selected smooth muscle actin for smooth muscle sarcoma. Okay, so now better है कि पहले तो ये ख़त्म करते हैं, then we'll revise all these markers in by 30 seconds. Let me start. When I say sarcoma botryoids, I've understood bunch of grapes. I've understood it is an embryonal rhabdomyosarcoma. So I saw all the cancer cells were limited to the layer above. ये कौन सा layer हो जाता है? This is known as the cambium layer. Cambium layer basically means all the cancer cells are limited and they have concentrated in one area. When I zoom into those cells, I notice that those cells are looking like straps, as if they are long tennis rackets, or they are like straps. So you can call them strap cells, you can call them tennis racket, and I will come to a lot of tennis rackets in a while, but पहले सारी immunohistochemistry मुझे revise कर दो. One shot, one flashcard for all immunohistochemistries. I've written everything, so we'll make it very quick and you will revise it for me. Any carcinoma being asked, C for C, carcinoma का IHC marker is cytokeratin. For sarcomas, I have already told you it is going to be Vimentin. अब कौन सा वाला sarcoma मैम? Smooth muscle वाला या skeletal muscle वाला? If it would have been smooth muscle का sarcoma, you will write smooth muscle actin. If it is skeletal muscle का sarcoma, you will mark desmin and myo D1. यहाँ पे skeletal muscle का sarcoma था, that is why you mark desmin and myo D1. Smooth muscle का होता, you would have marked smooth muscle actin. If it would have been carcinoma, you would have marked cytokeratin. Carcinoma तो था नहीं, this is a sarcoma. Coming back, what about this melanoma? Because dermatology question आएगा तो HMB45 and S100. Don't forget HMB45 especially for melanoma. What about lymphoma? वही Hodgkin's, non-Hodgkin's lymphoma. L for L, LCL, leukocyte common antigen, and for INI-CET you should be knowing it is also known as CD45. So this is also settled for us. Coming to the last, Langerhans cell histiocytosis. वैसे तो we are studying immunohistochemistry. For Langerhans cell histiocytosis, is immunohistochemistry the gold standard? No. For LCH, the gold standard is going to be this black and white electron microscopy, which shows you the tennis racket, another tennis racket added. So abhi I had studied that embryonal rhabdomyosarcoma ke cells are tennis racket. Abhi I am studying that LCH ka gold standard is also electron microscopy showing me tennis racket. But if I have to do IHC, I think I've got my answer. The most important marker is CD1A, but you have to learn all four. INI ke liye all four. Baki sab exams ke liye CD1A will suffice. But for INI, you have to remember all four. It is CD1A, CD207, HLA-DR and S100. Try not looking at it and repeating it once, assuming that you don't have time to view this over and over again, and this is your final revision that you're doing. Maybe one more you'll do with the PDF later on, but that's about it. So maximally you need to drain your brain and revise as much as you can over here. CD1A, CD207, HLA-DR and S100. That is the four things, but gold standard of LCH will be tennis racket wala electron microscope. Is there any other tennis racket other than embryonal rhabdomyosarcoma and the LCH ka granules? What are the two tennis rackets that you see in microbiology? Monday ke liye Giardia lamblia, that Dadaji also can look like a tennis racket. And which Clostridium? Tetanus or tertium? So we had studied tertium looks like tennis racket. Clostridium tetani to looks like drumstick, जो हम बाद में पढ़ेंगे. Tertium looks like tennis racket. Amazing. All tennis rackets are done. Let me move forward. यहाँ पे एक और चीज़ लिखा था CD99, but ये ऑलरेडी हमें पता है ना, अगर CD99 बोन ट्यूमर में आया तो it is going to be Ewing sarcoma, and if it is a 99-year-old granny, it is granulosa cell tumor. I'm not writing it because we've done that earlier. I move on to the next, which is an INI-CET find. It was never taught before it came in the INI-CET exam. Every year you will find one INI-CET question जो वहीं का एक originated question होता है and keeps getting added in our knowledge. 70-year-old person is having liver metastasis. They want to know what is the primary tumor. मुझे कुछ भी नहीं पता ना, तो if I know my theory also very well, the most common cancer that spreads to the liver is colon cancer. That is what my surgery theory tells me, and that is enough to mark this. कि अगर मुझे पता भी नहीं था बीच में क्या चला, the most common cancer that spreads to the liver metastasis का most common origin is from colon cancer. But they said on immunohistochemistry the CK7 is negative and CK20 is positive. That is also seen with colon cancer. So this is what you will fill for me, and it is very different how it is given in the books. It is very different how we are going to do it. In the books it is lists and lists which are endless and no human brain can learn it. We will learn it in one word ताकि हमें याद रहे एग्जाम में. If I say everything is positive, CK the same cytokeratin, तो अब एक क्वेश्चन आता है CK या तो 720 प्रोफाइल पे क्वेश्चन आता है विच यू आर डूइंग ओवर हियर, बट बिफोर दैट इन लिवर यू हैव समथिंग कॉल्ड CK8 and 18, and that is the composition of which bodies in the liver? Those are the Mallory hyaline or the Mallory Denk bodies. If they ask you what are they made up of, I'll make a small little liver over here. They are made up of CK8 and 18. ठीक है, वो अलग CK चल रहा है. This is the other one, CK720. CK everywhere means the same, and that is going to be cytokeratin. Now coming back, CK720 अगर both positive है तो दो ही conditions में हो सकते हैं. एक तो urinary bladder का cancer हो सकता है, and दूसरा ovarian, a particular type of ovarian cancer, that is ovarian mucinous tumor. What is it both? Everyone repeat with me. Bladder, urinary bladder का cancer हो सकता है या फिर ovarian mucinous हो सकता है. That is when both are positive. अगर सब कुछ negative आता रहता है, negative, this is all CC tumors that they will tell you. So if they say renal cell carcinoma, hepatocellular carcinoma, squamous cell carcinoma of the lung, or they say small cell carcinoma of the lung, anywhere they will write all these CC tumors, तो negative चलता रहेगा. Coming to the next, only lucky number 7 positive, lady luck. Think of lady luck, lucky number 7, CK7 positive. Why did I say lady luck? All female cancers. So now I don't want to write it. Breast cancer लिखेंगे, cervical cancer लिखेंगे. Maybe they will write ovarian cancer other than mucinous variety. और कौन से any other endometrial cancer that you think of. All these female cancers will be lady luck 7 positive, and anything above the colon. अब above the colon तो आधी body आती है मैम. So if they say, let's say salivary gland cancer, or they say thyroid cancer, or any goddamn organ coming above the colon, I will mark CK7 positive. But if they say only CK20 positive, then I will obviously want to go below the colon. Below the colon will be everything from colon down. So colon, फिर colorectal, that is one thing. So one is going to be colon cancer, and दूसरा हो जाएगा Merkel cell carcinoma. Merkel cell carcinoma for INI-CET students, it is a neuroendocrine tumor. So only two things which are going to be 20 positive. यहाँ लिखा था 7 negative, मतलब lady luck नहीं है. This is only 20 positive. 20 positive में दो ही tumors आते हैं. Either it's a colon cancer or it's a Merkel cell carcinoma. Here it is colon cancer which is spread to the liver, and we are done. A 20-second recap. Both are positive is bladder and ovarian. Sub negative is CC stuff. 7 positive is lady luck and above this colon, and below the colon and Merkel cell is going to be 20 positive. Okay, someone gave me a reminder. Very good. 2 hours are done. Where are we? Not bad. We are on the 59th slide. So we are very close to our target. We had to finish 30, right? We had to finish 30 each, so 60. We are very close to it. Amazing, guys. You are doing great. And इसी से आगे चलते हैं ना. What are you saying? Merkel cell carcinoma क्या है? Neuroendocrine tumor. तो can you tell me all the neuroendocrine tumors in the entire body? सबका सेम इलेक्ट्रॉन माइक्रोस्कोपी, सबका सेम इम्यूनोहिस्टोकेमिस्ट्री. तो नाउ इन वन स्लाइड यू विल फिनिश 10 इन अ वे, बिकॉज नाउ दिस इज व्हाट वी हैव सेटल्ड. ऑल न्यूरोएंडोक्रीन ट्यूमर्स. फर्स्ट क्लिनिकली यू विल टेल मी विच इज द न्यूरोएंडोक्रीन ट्यूमर. राइट नाउ यू डिड इन द स्किन. मर्कल सेल कार्सिनोमा कहाँ होता है? इट इज इन स्किन. तो दिस इज अ न्यूरोएंडोक्रीन ट्यूमर. टेल मी द न्यूरोएंडोक्रीन ट्यूमर इन द एड्रीनल ग्लैंड. फियोक्रोमोसाइटोमा, ये तो हमें पता ही है भाई. एपिनेफ्रिन और एपिनेफ्रिन. वी आर नॉट गोइंग टू. एंड इफ यू वांट मी टू राइट, व्हाट शुड आई राइट? रूल ऑफ 10 लिख लेते हैं. I have a question of FIO that is coming up, so we will discuss that. Then tell me the neuroendocrine tumor in thyroid. Medullary carcinoma thyroid. Everything about medullary carcinoma is different. ये कौन से सेल से आता था? Parafollicular C cells, calcitonin वाला that you just now discussed, and now I'm saying it is a neuroendocrine tumor. Which cancer of the lungs is neuroendocrine? That छोटा packet, small cell lung cancer is actually a neuroendocrine tumor. And which cancer of lungs and GIT together दोनों जगह होता है carcinoid? That is also neuroendocrine. Why did I make a list of all these neuroendocrine, because all neuroendocrine tumors on electron microscopy will show me the same neurosecretory granules. तो अब now one image wraps up everything. चाहे इनमें से कोई भी दिया हो, any neuroendocrine tumor will show me the neurosecretory granules. But for INI-CET, the tough part comes now. All neuroendocrine tumors will show me the same immunohistochemistry markers. This is not what I want you to learn. This is what examiner wants you to learn. So sorry, but पढ़ना पड़ेगा. कौन कौन से होते हैं neuroendocrine markers? in इतना तो याद कर ही सकते हो. Synaptophysin, chromogranin, bombicin, and this has been, I would never want even my MD students to learn this, but yeah, INI-CET का previous year question है, so then I'm not left with an option but to make you learn this. Which was the new marker that they taught us? Before that even we didn't know that अच्छा ये कोई rare marker है, which is the only nuclear marker that is positive in the neuroendocrine tumor immunohistochemistry. It is INSM. So the year that it came, students were not aware. We were also not aware. कुछ journal में कहीं कुछ rare सा research हुआ था, no one knew about it. We also read it. We got to know, acha, they've given one googly question, that is fine. But still students got it right, because when in the exam, when everyone is against you, then sometimes your luck factor works. They said, acha, ये सारे options में थे. They had to pick up which is the only intranuclear marker. Some students said कि बाकी सब तो पढ़ा है, अगर वो intranuclear होता तो मैम would have told us. मैम ने तो ऐसा बताया नहीं. So then by ruling out they said, oh, this must be the answer. Some students thought IN stands for intranuclear. They made their own mnemonic in the exam. IN does not stand for intranuclear. But sometimes when luck is by your side, you can do random stuff in the paper and still get it right. And they thought that IN stands for intranuclear, but it worked. तो कई बार ऐसे भी काम आ जाता है. You never know, it's your lucky day. That's why they say don't lose hope till the very last moment, because you really don't know how your mind and luck will work on that day. And for students who thought that way, उनका ठीक हो गया, even without having 0% knowledge about it. But now you know all these in markers, they will be for neuroendocrine tumors. Then NSC, CD56 and CD57, ये short forms. Please repeat with me, all in markers, NSC, CD56, CD57. So अब इनमें से कोई भी ट्यूमर लिखा हो, सबका इलेक्ट्रॉन माइक्रोस्कोपी सेम, सबका इम्यूनोहिस्टोकेमिस्ट्री सेम, एंड सबका लाइट माइक्रोस्कोपी ऑल्सो सेम. ब्लैक एंड वाइट एरियाज, which means all of them show you salt and pepper nucleus. Let me make you solve some questions so that you know that what you're reading can be applied, applicable है ना. 29-year-old man coming to the clinic with intermittent episodes of headaches and sweating. शायद इसमें palpitation भी होता तो triad पूरा हो जाता मैम. Headache, hypertension, sweating, VHL gene mutation is there. Then they found a 5 centimeter tumor in adrenal gland. I only know of one adrenal gland tumor, that is pheochromocytoma. Adrenalectomy is done. Which immunostain? Pheochromocytoma, neuroendocrine tumor, synaptophysin, chromogranin. Answer is done. Everything about pheochromocytoma put up over here. VHL, previous year NEET PG का question है, can be asked in INI in so many ways. VHL gene or VHL syndrome is presence. Which chromosome deletion? VHL gene कौन से क्रोमोसोम पे होता है? तो VHL syndrome is going to be a deletion. Chromosome 3 what? 3P. Very good. It is going to be 3P. Amazing. VHL, 3 alphabet, 3 chromosome. Very good. Pheochromocytoma, ma'am, shows you that classic Zellballen pattern. Zellballen matlab there are going to be bird eggs and then there is a nest around it. So nesting pattern. These bird eggs are the main chief cells. ये है वो neuroendocrine cells. These are the ones positive for in all this synaptophysin stuff that you are seeing. But the nest is always supported na. So these are the supporting cells on the outside. Supporting cells को बोलते हैं sustentacular cells, which are S100 positive. I think that's easy. I'll repeat. Nesting pattern का मतलब पहले तो मैम you have put the main eggs inside it. These are the chief cells. These are the neuroendocrine cells, which are everything in. But the supporting is done by the supporting cells or sustentacular cells, which are S100 positive. Now I have a question. Rule of 10 we all know in medicine, which is well known. Rule of 10 में हमें पता है कि 10% of the times वो bilateral भी हो सकता है, 10% of the time वो extra adrenal भी हो सकता है. I'm not writing it. Can you quickly tell me extra adrenal? If it is in the adrenal, I called it pheochromocytoma. If it is outside the adrenal, we call it paraganglioma. Okay, 10% of them can also be showing metastasis. So that's the question. Oh, okay. No, I gave you the answer. 10% of them can also be malignant. So that's the question. Okay, what is the criteria for malignancy? What is the criteria for malignancy? Is me, a pathologist, going to tell you that pheochromocytoma is, because everywhere I tell you, na, cancer hai ya nahi hai. Pathologist has the final say. But for pheochromocytoma, the malignancy criteria is actually seen clinically and radiologically. It is decided on seeing metastasis. So they ask you this question: what is the criteria for malignancy for pheochromocytoma? When you get to see that it has spread, it has metastasized, that is when you say that it is malignant. Say 10% of them can be that. Are 10% of them occurring in families? Is that rule still valid? And put a big cross over here. The only 10% rule that has changed, pehle kehte the 10% of them are running in family, that is out. Now they say 25% of them are occurring in the families. So that is not a part of the 10% rule. That is what I wanted to highlight. All neuroendocrine tumors and their applications are done. I think one is left. Ye sirf time pass ke liye, because I know you know it. It's a very NEET PG-ish type of a question. But never underestimate lung tumors when it comes to any exam of our country. So it's my duty to make you revise this. Chronic smoker, shortness of breath, mass is located in the lower lobe periphery of the lung. Biopsy is performed in histopathology. They've been kind enough to tell you lung adenocarcinoma. They are saying the biopsy will be positive for adenocarcinoma के लिए क्या होता है? A सारे AA वाले markers and 1-1 वाले markers. That is 1 and 3. Do I have that as an option? Yes. Just a quick tip: whenever you get such questions in the exam, please don't look out for the answers that examiner has given you. अपना पहले एक tentative answer बना लेना कि मुझे लगता है 1 and 3 होना चाहिए. Do I find that combination? Because that makes it a little easier. Once I start reading examiner's combinations, I forget mine. So just a quick tip to approach such questions. So now, yes, for adenocarcinoma, all AA1s, that is napsin A, TTF1, MUC1, okay. For squamous cell carcinoma, do you remember it shows you the keratin pearls? So, sare PP wale markers, P40, P63, out of them, which is the best one? PYQ, P40 is the best one. And I am not repeating this small cell carcinoma. If I just write it as a neuroendocrine tumor, then I already know कि इसमें वो in wale markers होंगे, INSM, all that I know. So there is no point in revising all of this. Now, if I ask you a quick review of all the histopathology, as you said, squamous cell carcinoma में क्या दिखेगा? Pink वाले keratin pearls. Any adenocarcinoma of this planet will show you the same thing, and that is going to be the round glands. And small cell carcinoma is going to show you what? It will show you Azopardi effect. What is Azopardi effect? It's a blood vessel. It looks everything but a blood vessel. It does not look anything bloody. It does not look red. It's actually a blue blood vessel, and that is what I call as an Azopardi effect. So bus imagine, they, instead of writing this to you, they would have given me a picture of this, that is, it is a lung tumor showing me glands. Then you would have had to guess कि अच्छा adenocarcinoma है. That is why all the 1-1 and AA wale answers I'll mark. Okay, if I have gone up till here in immunohistochemistry, then why should I miss out on this? It is the immunohistochemistry for breast cancers, and you know, for breast cancers I will have to do which 3 immunohistochemistries do? We do ER, PR and HER2/neu, right? ये 3 immunohistochemistry कर रहे हैं ना for all breast cancers in surgery. This is like a must know question. So before I start with this, if you tell me the basic, I will tell you the advanced. So I'll just skip a few slides and first go forward, and first you will tell me this कि ER/PR HER2/neu breast cancer में क्या classification बनाता है. Then I will come back and I'll explain it to you. Excellent. So if I say ER, PR and HER2/neu, everything is negative, that is a triple negative breast cancer, as easy as it can get. If I say only HER2/neu is positive, only HER2/neu is positive, that becomes HER2 rich. This is also common sense. So now if HER2 was positive, it is HER2 rich. Ulta kar dete hain. Let's assume if ER/PR is positive. If ER/PR is positive and HER2 is negative, now that becomes luminal A and B. तो ये तो same लग रहा है. How should I differentiate? To differentiate luminal A and B, I will do Ki-67. If Ki-67 is less than 14%, it is luminal A, and if it is more than 14%, it is going to be luminal B. What is Ki-67? MIB1 bole, Ki-67 bole. It is the proliferation marker. So if I twist the question and ask you, out of the 2 luminals, which has a low proliferative index? Low proliferative index, less than 14%, luminal A. High proliferative index, it is more than 14%, luminal B. I have another question for INI-CET. Because you had something called triple negative breast cancer, maybe they want to ask you, is there something existing like triple positive breast cancer? तीनों चीजें positive हो गई. Rarely, but yes, that can happen. Sometimes in luminal B, everything ends up being positive, and then in that situation I will refer to it as a triple positive breast cancer. Now that I have done all of this, I will ask you that ye kaise detect hua? Who is seeing all this? I am seeing all this on the microscope. On which stain? I am detecting all of this using immunohistochemistry. But that is a kind of a jugaad, or a very shortcut method that I have used, because breast cancer is rising so much in our country. Every female has to be tested for ERP or HER2/neu. So I started doing immunohistochemistry because I could do it very quickly. Originally, when this classification was made, that's a previous year question, what is the basis of the classification? It is gene expression profiling. This luminal A, B and all was, a lot of genes were studied, then they decided on it. But you tell me, doing genetic studies for every female of this country with breast cancer is going to be very, very expensive. We won't be able to afford this. So we took a shortcut for genetics and we found out immunohistochemistry. Now coming back, yes, the same brown color means diaminobenzidine. Now I can go all the way back to the slides that I skipped. On immunohistochemistry, I will get that brown color. For ER and PR, is there a scoring, because we are going in for the INI-CET exam? Is there a scoring for ER and PR that is known as all red scoring for immunohistochemistry, which says एक cell be positive आया, you will consider it as positive. Imagine if one cell comes out to be brown, I will say she is ER positive, she is PR positive. 1% is all that I need. But for HER2/neu, there's no name to the scoring. We have different scorings that is done, and that is learned as 0, 1 plus, 2 plus and 3 plus. Do I have to know photo wise kaun sa 0, kaun sa 1 plus? Nahi, because if you look carefully, examiner likhega 0, 1 plus, 2 plus and 3 plus. That is examiner's job. सब हम थोड़ी करेंगे, कुछ तो examiner भी करेगा. So he will write for me 0, 1 plus, 2 plus, 3 plus. That is HER2. If HER2 is 0 and 1 plus, this means HER2/neu gene is not affected. It is a very chota brown color. I will ignore it. HER2 is not amplified. Do I want to give any trastuzumab over here? I do not. If it is 3 plus, like in this case, which is staring at me, brown as hell, then in that situation it is positive. And now I of course want to give trastuzumab, Herceptin, because I'm very sure that acha isme to HER2 gene is amplified, but I'm doubtful in 2 plus. ये वाले situation में I'm like brown है भी नहीं भी है. It is equivocal situation. How should I confirm it? I should go in for fish. If fish will say that हाँ chromosomally it is amplified, I will. If fish says it is positive, I will give trastuzumab. If fish says it is negative, I will not give trastuzumab. So 2 plus. And how will the question come? They will give you these 4 A, B, C, D. They will say, in which situation do you want to confirm further by doing fish? So which is the situation of HER2/neu immunohistochemistry? 2 plus, very good, which all of you have anyway told me. Analysis of fish will not come. I know I have taught you in your other lectures, but वो एकदम से counting करने को नहीं बोलते. They just ask you in which situation will you do fish? That is going to be in 2 plus. अभी breast cancer की बात करी. So I'm feeling a little bad कैसे breast cancer की photos देखे बिना कैसे आगे चले जाएं. तो just 3-4 photos quickly. You have to see the images of breast cancer that they will ask you, which we usually don't study in pathology. We leave it कि surgery में कर ही लेंगे. But today, let's say you've been nice. Now, if you are nice, then I would want to cover more for you. Anyway, this was anyway in the plan, even if you wouldn't have been nice to me. So firstly, mucinous or colloid carcinoma. ये एक तो होता है regular वाला breast cancer. They will not give you photos of the breast cancer that is happening every day. They will give you little rare photos. तो कुछ ऐसा catchy वाला photo होगा ना. Mucinous, when the entire thing is only talking about mucin. हर जगह बात है, there is lots of mucin, there is lots of mucin. There will only be one breast cancer called mucinous carcinoma. So much of mucin that the blood vessels got entangled, like वो earphones का wire होता है ना, वैसा wire बन गया मैम. Chicken wire blood vessels are seen in mucin, that is mucinous carcinoma. Then the tumor cells are looking so small because I have pools and pools of mucin. That is going to be mucinous. Then they write colloid carcinoma for it, which is very stupid. It's a misnomer. It has nothing to do with thyroid. वो ऐसे ही पता नहीं किसने नाम बनाया. They will write this in the exam. They write so much of mucin, but the options don't have mucinous carcinoma breast. The options have colloid carcinoma breast, and that is what we have to know. Okay, then you know the surgery question, the peau d'orange appearance, that is inflammatory breast cancer. The PYQ was, why does this appearance come? The cancer cells have infiltrated into which part of the skin? Into the subdermal lymphatics. Previous year question. तभी वो peau d'orange orange peel like appearance बना, inflammatory breast cancer. The third breast cancer they will ask you is where all the tumor cells are in a straight line, like army men, very disciplined, standing in a straight line, and that is known as the Indian file pattern. You know that is invasive lobular carcinoma. And the next question has to be the genetics, which many of you had told me. What is the genetics? It is loss of E-cadherin. इतना easy नहीं पूछेंगे. Either they will write CDH gene, that means the same. So this is how they will be writing it. There is CDH gene mutation. That is E-cadherin gene mutation. If E-cadherin, what is E-cadherin? E-cadherin याद है फेविकॉल था, glue था. E-cadherin usually holds all the cells together like this. It's the fevicol. Right, the day this fevicol will go, the day there is a loss of E-cadherin and all these connections will be gone, that is the day when glue will be gone. You know the Go-Lu tumors occur. When glue will go, what is Go-Lu tumor? One is Go and Lu. So Go is diffuse gastric cancer, the same one which causes linitis plastica, wahi wala, diffuse gastric cancer. And the other one is Lu, that is invasive lobular carcinoma, which you are reading over here. Glue gaya to Go-Lu tumors occur, you know that. Amazing. Okay, let's move on to the next, and this is it. Total twist, all immunohistochemistry done. Did you notice along with immunohistochemistry आपने color भी पढ़ लिया, आपने सारे sarcomas भी पढ़ लिए, then you did LCH also, you did the table also, you finished breast cancer also, and that is what I mean by integration. Pick up a topic wherever you have studied it in different chapters, that is in the subject integration. All of you have focused too much on inter-subject integration, but in the subject also you can do a lot of integration, and that's a very, I don't teach this way for NEET PG and for FMG. I go very topic wise for NEET PG FMG, but when it comes to INI-CET, they have this habit. They'll start with fluorescence, then they'll go to the microscope, they'll start with immunohistochemistry, they'll jump to breast cancer. So that's the integration that they do within. Very good. Many of you were like, meanwhile ma'am, while you were giving us this lecture, हमें ये समझ में आया कि कुछ तो लॉलीपॉप बना, और लॉलीपॉप के साथ हमें एक ही चीज़ समझ में आ रहा है यहाँ पे, that is Castleman disease. Another INI-CET favorite topic. I've switched the topic now. Gone is immunohistochemistry. Let's move forward. Okay, what is the likely diagnosis? Abdominal distension, fever, peripheral smear finding is normal, so they're wanting to tell you leukemia तो नहीं है, blood cancer तो नहीं है, lymph node is resected. Lymph node disease ही होता है Castleman. So I can see whenever you see this lollipop follicle, what is this lollipop? That is what they will ask you. ये जो इसका stick है, that is actually a blood vessel, and lymph node resection हुआ ना, so these are going to be all the lymphocytes. But can you see those lymphocytes are arranged like a round lollipop? So that is known as the onion skinning of the lymphocytes. वैसे round है, so that is onion skinning. पूरा follicle you've told me. Tell me the virus also. It is due to human herpes virus 8. Yes, the same human herpes virus which on Monday we will study in microbiology. Number 1 causes Kaposi sarcoma, number 2 causes primary effusion lymphoma, and third causes Castleman disease. Perfect, all of you told me. Great. तो इसमें I have nothing more to tell you. ये सिर्फ एक random question था. Now tell me this, which will give you a shocker. What is the marker for the NK cells? I mean, the question is not a shocker. The topic that I'm starting with is going to be a shocker. Firstly, I see a lot of CD markers. Instead of calling it CD markers, can I now be a very knowledgeable person and say, oh, ये तो immunophenotyping होता है, and immunophenotyping के लिए which machine is used? Flow cytometry is used. So now tell me what are the markers? 16, 56 and 94. Another INI-CET find. Earlier we only study 16 and 56. Then they said, what is the new marker for NK cells? So, you know, our notes becoming bulky is not the student or the faculty making it bulky. The notes becoming bulky is every year they're adding new random questions to the pool, and then everything keeps getting bulky with every year. So 94 is the new marker for NK cell. Sorry for this, but you will have to tell me all the CD markers. Anyone preparing for FMG can take a break right now, because this will never be asked in so much of depth in the FMG exam. It's a very core INI vibe question. So let's start. Because if you know this is like your base. ये आता है तो आपका theory question भी होगा, your flow cytometry graphs will be done. This is where it starts. If you know this, then you can conquer any question. If you don't know this, then all your questions will have a problem with, right? Let's start. For blasts, we will always think of TDT. Basic तो पता होना चाहिए, TDT and CD34, and maybe HLA-DR if you can learn, but TDT and CD34 for blasts you have to know. What is leukocyte common antigen? That is CD45. ये तो अभी पढ़ा था. Again, not very important. T cells का बताओ. I'm putting a star in some places, and those will be the ones with जिसके बिना, I mean, you know, you cannot go ahead. So T cells 1 to 8, 28. How easy? CD 1 to 8, CD28. So learn like a song with me. 128, 28. Out of which is the most important out of these? The pan T cell marker that you always study is going to be 128 में से कौन सा? CD3. Then let's talk about B cells. B cells कैसे पढ़ा था? Double करते जाना मैम. Start from CD10, then after 10 go to 20s, after 20s go to 40s, keep doubling. From 10 we go to 20s का series ना, तो 19, 20, 21, 22, 23 चलता रहेगा. Then from 20s we go to 40. So how can I forget that 440 वाला story, isotype switching? So CD40 on the B cells we have to do. Out of this, now if they ask me which is the pan B cell marker, that is going to be CD19. Very good. If they ask me which out of these is also known as CALA, common ALL antigen, that is the other name given to CD10. So repeating, T cell 128, 28, B cell 10s, 20s, 40s done. NK cell, what you were calling as Bahubali, so you said, oh, that 16-inch bicep Bahubali will have, and then 56-inch chest, and then obviously the weight is going to be a lot because of so much of muscle mass, that is 94 kgs, so 16-inch bicep, 56-inch chest, and there is going to be 94 kg weight, 16, 56 and 94, the Bahubali. Now coming to myeloid, so if they want to say myeloblast, myelocyte, कोई भी myeloid lineage होगा, that is going to be 1333, 1333, and you cannot mess out with myeloperoxidase for myeloid lineage, ये तो obvious है. Now coming to mono, you all remember how we studied mono, forever single, sad story is going to come. Sad story क्या है? Mono, forever single, 1-1. 14th February को भी single, how sad, and then single till he dies, so 14th के बाद 64 years तक single, so 1-1 single, 14th Feb को single, 64 की age तक single, that is single monocytic lineage. So they say monoblast, they say monocyte, you are thinking of all the forever single, very sad story. If this resonated with you, then I truly feel very sad. I hope that situation changes in your life very soon. Coming to the next, mega karyocytic, the mega gun, PUBG lovers love this. So mega gun में क्या आता है? M416 gun PUBG का होता था, तो that was a mega big gun. तो उसी के साथ हमने mega करा. 41, 61. So what are the CD markers? 41 and 61. अब बीच में कुछ कुछ अगर ऐड कर दें वो 42 and all, तो उनकी मर्जी. मेन क्या है? It is 41 and 61. M416 gun. Okay, now coming to, we are not done. What is this? PNH, ये तो पता है. Paroxysmal nocturnal hemoglobinuria में what are the CD markers that are missing? CD55 and CD59 go missing. I mean, I know this. Can you tell me these two first, then I'll come to lymphomas together. What is for plasma cell and multiple myeloma? Normal plasma cell बता दो पहले. Normal plasma cell is a very, this is where INI-CET students will pay more attention, because बाकी सब तो चलो चल ही रहा था. This is where they will catch you. Normal plasma cell, ma'am, plasma cell is a white blood cell. Every white blood cell has to be CD45 positive. Plasma cell comes from what? B cells or T cells? Plasma cells are from B cells. What is the main B cell marker? CD19. तो अपने origin को तो याद रखना पड़ेगा ना, that I am a white blood cell, I am a B cell origin, but then you will have to make your own identity. So plasma cell said I am also 38 and 138 because that is my identity. CD38, 138. A normal plasma cell is a good boy, a good girl who said I will remember my parents also and I will make my own identity also, till the day he became cancerous. The day he became cancerous, he said parents को भूल जाओ, chuck the parents out of the home. तो उसने parents को बाहर निकाला. 45 को भूल गया, 19 को भूल गया, he forgot his origin. He said, I am selfish, I will only remember myself, 38 and 138, and that is why it's a bad cancer, right? It's a bad child, forgotten the parents, that is multiple myeloma. So normal plasma cells are positive for everything, origin also, apna also. Cancerous one says, chuck the parents out of the house, unhe bhul jao, only remember myself, 38 and 138. Okay, now coming to these three lymphomas, because जब ये पढ़ लिया, before I go on to all these flow cytometry वाले questions, lymphoma ख़त्म कर देते हैं. और what I'll do, just remind me, okay, because this is going to come in 5 minutes. लिम्फोमा को थोड़ा ब्रेक लेते हैं. आई वॉन्ट यू टू फिनिश ऑफ कि ये जो CD मार्कर्स आपने पढ़े, ये पढ़े कैसे, ऑन विच टेक्निक, फ्लो साइटोमेट्री. आई कम टू लिम्फोमास, प्रॉमिस, बट पहले मुझे बता दो ये फ्लो साइटोमेट्री के क्या क्या क्वेश्चंस हैं. फ्लो साइटोमेट्री का आई थिंक राइट नाउ आई जस्ट टोल्ड यू व्हाट इज दिस फ्लोरेसेंट ग्रीन कलर दैट आई यूज, फ्लोरोआइसोथायोसाइनेट. दो ही तो डाइज पढ़ी, इम्यूनोहिस्टोकेमिस्ट्री का डैब था, diaminobenzoidine, flow cytometry का फ्लोरोआइसोथायोसाइनेट, that we have studied. Tell me what is this light anyone can say it is a blue color light. So they will not ask you कि कौन से color का light use हो रहा है. They will say what wavelength of light is used. 488 nanometers का wavelength of light is used. That's the question. When it will strike the cell, do you notice some light goes forward, that is known as forward scatter. Some light goes sideways, that is known as side scatter. Forward scatter is a measure of the size of the cell. Side scatter is a measure के cell अंदर से कितना complex है, granularity. I'll give you examples. Forward scatter will depend on the size. ये small cell, ये medium cell, ये large cell. Can you see small cell का scatter, medium cell का and large का? So size will increase, the forward scatter of the light will increase. Whereas the side scatter will depend how complex the cell is from inside. So side scatter is a measure of granularity. तीनों questions आपके सामने. The dye FITC, blue 488 का wavelength का light, forward scatter tells me size, side scatter tells me granularity. Now this is how the INI-CET question was asked कि वो सब तो machine के अंदर हो रहा है. How are you as a doctor reading the reports? The two reports that you can get, either you can get a histogram, this looks like a PSM na, either the machine will make these graphs like this and bring it to you, so that is a histogram, or the machine will start making some dots. Every cell will be depicted like a dot. दो ही तरीके, या तो every cell is depicted like these arrows, that is histogram, or every cell on the computer will be depicted as dots and that is known as dot plot, and that is where you do the analysis. एक y axis होगा और एक x axis होगा. Without putting too much, let's assume यहाँ पर randomly I'm writing anything. Let's assume I have written CD55 over here and CD59 over here. मन मर्जी I have written, okay. So now tell me, the cells which are in this quadrant are the double positive cells, means they will be CD55 positive also, 59 positive also, because ये तो दोनों ही axis पर it is pretty high. The cells which come in this quadrant, ma'am, they are very low, they are double negative, they are 55 negative also, 59 negative also. So for your exam, because now I will make you solve questions, you have to be very clear over here. ये है DP quadrant, ये है double negative DN quadrant, then this one over here that you have, it is closer to which axis? X axis, na? So it is only 55 positive. And these cells over here are closer to Y axis, so they are only 59 positive, as easy as that. Apply करके देख लो. Over here, can you tell me, they will say what is the analysis. I know you won't be able to read, I've written it at a higher magnification. यहाँ लिखा है CD10, यहाँ लिखा है TDT. First, in your mind when you get such questions ना, markers के साथ अपना आंसर बना लो कि TDT means they are somewhere trying to tell me TDT is a marker for what? It is a marker for blast. And that 10, 20, 40 wala series was to do with B cell. This I know. Now they have labeled this quadrant, which is the double positive quadrant, right? And if 10 is positive and TDT is positive, तो ये blast भी है. Blast मतलब ALL. And कौन सा वाला ALL? It is a BALL. So now what do I have? Do I have BALL in the option? Yes, just imagine, just giving you an option. Same TDT होता, but यहाँ पर it would have been CD3. CD3 is a marker of T cells. तो क्या आंसर बनता? T cell का blast होता तो क्या आंसर बनाते? TALL. ये B cell का blast है तो क्या आंसर बनाया? I have made it BALL. Okay. Maybe solve another question over here. Same I have got, which I was giving to you as an example. ये CD55, ये CD59. They said what is the analysis? They have not labeled any arrow के कहाँ, बस अपना answer बताओ. So I see that most of the cells over here are in the double negative quadrant, means they don't have CD55 and CD59. That makes it a case of PNH. But थोड़े से cells are in the double positive quadrant also. Why? Because PNH, I have taught you this in your rapid revision videos. PNH एक genetic problem नहीं है. PNH is what? It is going to be an acquired problem. It doesn't come from your parents. It is acquired. If it would have been coming from parents, say autosomal dominant recessive like that, then all the cells would have shown me the disease. But this is an acquired problem. So yes, most of the cells are diseased, but some normal cells still remain because ये acquired defect है. Now that we started the story of PNH, तो then you will have to tell me only कि सभी कुछ बता दो मुझे PNH का. Paroxysmal nocturnal hemoglobinuria, गोल्ड स्टैंडर्ड क्या है डायग्नोसिस के लिए, जो अभी आप बता रहे हो. फ्लो साइटोमेट्री इज द गोल्ड स्टैंडर्ड फॉर द डायग्नोसिस, नो अदर टेस्ट. What is the drug of choice for PNH? If CD55 and CD59 are not there, you give a proxy drug which will act as CD55 and CD59, and that is known as eculizumab. Very good. But is eculizumab the drug? Yes. Is it the curative final treatment? No. If they write, what is the curative treatment? Option A will be eculizumab, wo mat mark kar dena. That doesn't give you cure, that only gives you support. The curative treatment over here is hematopoietic stem cell transplantation, which you will be marking. Amazing. Okay, now before you ask me, from one question only we are going to the other. ये option में क्या लिखा है? T regulatory cells, because this is something for which we have recently got a Nobel Prize. By the way, ये जो नवंबर 25 वाला क्वेश्चन हुआ था, उसमें INI में क्वेश्चन था, for what discovery has a Nobel Prize been given in the year 2025? It was given last year only. So it was given for T regulatory cells, for which our scientists have got some Nobel Prize. They don't give you the name of the scientist. Those three people have very very difficult names, मुझे भी याद नहीं हो पाते. They are of a different country, so they don't ask you the names of the scientists. They will just ask you किस चीज़ के लिए Nobel Prize मिला. They got it for T regulatory cells. So their next question will be, what are T regulatory cells and what is the function of a T regulatory cell? So T regulatory cells are nothing but CD4 cells. वो normal हमारे CD4 cells हैं with something extra, and that extra is CD25 and FOXP3. These are the two things that have made it a little extra, and by extra I mean usually T cells क्या करते हैं? T cells increase our immunity. They help in fighting bacteria, viruses. They increase our immunity. But T regulatory cells have an opposite function. They decrease our immunity. They have an immunosuppressive action that you need to know, and that is why they are different from all the T cells. So question 1, T cells are CD4 with an extra spice of CD25 and FOXP3 gene. They decrease our immunity, and the medicine question that will come is that if one day this FOXP3 gene decides that I am not working, what is the syndrome that the person can land up with is going to be the IPEX syndrome. Yes, I had planned on teaching this in micro because all the scientists and Nobel Prizes I'm teaching you there. But now that I've taught you here, I will not be. So let's assume over here, just giving you a very random question on how this could come if they wanted to ultra integrate things, making a question on the spot. If they over here say कि यहाँ लिखा CD25 and यहाँ पे लिखा FOXP3. So here they've written CD25 and here they've written FOXP3, and all the cells are in this quadrant. You'll say, oh, this is the double positive quadrant. Double positive means it is positive for CD25 and for FOXP3. Which is the answer that you will mark then? You will be marking the famous T regulatory cells. Are we okay with this? Flow cytometry almost done. Now I can finally come back to what I had left. This is the question: in a patient presenting with cervical lymphadenopathy and positive translocation 11-14, which of the following markers will you use to confirm the diagnosis? Another INI-CET PYQ. Over here, what will you be using for confirming the diagnosis? Many of you are saying C and D milake. Okay, so what lymphoma did you make? You made mantle cell lymphoma, na? So pehle to you will tell me how will all these genetics come into place. Then I'll go back to that chart and fill in the blanks. Then I'll tell you some other questions. So every time when you want to revise the genetics, should we do the same story like we've done always? Whenever something 8 comes up with an even number, which means I'm starting with the lymphomas, and I'll promise that within 10 minutes I'll be done. I don't know how I'm going to do it in 10 minutes, but kar lenge. Socha hai to karenge. When I put 8 and any even number, what is the lymphoma that I think of? It's Burkitt's. Now they can put anything with 8 and I don't care as long as it's an even number. It should be 8 and 14. Yes, it could be 8 and 22. Okay. It is 2 and 8. Chalega. 8 के साथ कोई even number होना चाहिए. Why my obsession with 8? Because 8 is the c-MYC gene and that is the one that is mutated in Burkitt's lymphoma. So now I know. Now let's talk about age groups. बच्चे का age group 11, 12 तक बच्चा होता है. 18 का तो age group goes into adult, and then somewhere in between 14, 11, 14 and 18, which tells me that if I plan to match the margins, the bacha and the adult, margin match kara to marginal zone lymphoma. If I match the two teenagers, the only two teenagers, 14, 18, teenagers best friends with each other, which is the most friendly lymphoma, best lymphoma to have? I mean, God forbid, but best lymphoma to have. Friendly wala, teenage wala, follicular lymphoma. And then what am I left with? Translocation 11 and 14, teenager with a non-teenager, everyone going mental, that is mantle cell lymphoma. And this was a case of mantle cell lymphoma. I'll come to the markers. Chromosomal translocations are okay with everyone. That is done. Now let's come back and fill in the blanks for the CD markers that we left. When I say CLL, SLL, ma'am, CLL 3 markers देखने हैं, CD5, CD23 and CD200. CLL, SLL is सब कुछ positive. What did I say? CLL, SLL, whatever they will write in the exam, 5, 23, 200, सब कुछ easily positive. Marginal zone में margin को कौन देखता है मैम? हम तो मार्जिन को तो फोकस ही नहीं करते. वी ओनली लुक एट द सेंट्रल टनल विजन. मार्जिन देखते ही नहीं, तो मार्जिन को इग्नोर करो. एवरीथिंग विल कम आउट टू बी नेगेटिव. 5 नेगेटिव, 23 नेगेटिव, 200 नेगेटिव. नाउ आई एम लेफ्ट विद दिस मैंटल. मैंटल आउट ऑफ ऑल ऑफ दीज हैज़ ओनली वन थिंग पॉजिटिव, CD5. बाकी सब कुछ भी नहीं. इट ओनली हैज़ वन थिंग पॉजिटिव, दैट इज CD5. सो दैट इज वाई आई डिसाइडेड that other than that it will have 2 more markers to compensate, SOX11 and cyclin D1. Now come back. The question was on mantle cell lymphoma, because I know from 11-14 it is mantle cell. You said कि ma'am compensate करने के लिए you had SOX11 and cyclin D1 and hence I marked it. What does this cyclin D1 remind me of? Cyclins कहाँ use होते हैं? In the cell cycle. Do you remember धोनी एक अच्छा batsman? I mean, this is a very naive baby question for INI-CET, but never underestimate an easy question. You never know when it appears for the paper. So cyclins का order क्या होता है in the cell cycle? It is cyclin DEAB. धोनी एक अच्छा batsman. So out of those cyclins, I picked up cyclin D1, and that is what is problematic in mantle cell lymphoma. Okay, now this is not where the story ends. In INI-CET, they love to ask you the lymphoma and the origin from the area marked over here. So now the area that I have marked in this lymph node with an arrow is the germinal center. They have asked you which of the following lymphoma does not take its origin from germinal center. Out of these, which of them does not? It is going to be marginal zone. Have you seen these questions in PYQs and obviously run away from them always? Hopefully after today you will not run away from these in the Q bank also, because we will try to cover this in 2 minutes, but in a very easy way, not in the way it is given in the textbooks, because that's very toxic. हम सोचते हैं ये lymph node, this is our MBBS college. Okay, that only started sounding toxic, but anyway, this is a lymph node, this is our MBBS college, this is you, the 17, 18, 19-year-old person, baby person, naive chota baby who decided I will go into MBBS. You are a naive B cell. One day you said I'm going into MBBS, and then you entered. When you entered, the first 1 month was all of your orientation. People were very nice to you. आपको पता ही नहीं था NEET PG, FMGE, INI-CET exist भी करता है. You were in your own sweet world enjoying life. Basically, you were not at all challenged. You were in an unchallenged environment, and that is mantle zone. Dhire dhire this B cell got to know that life is not that good. When he reached the center, what is the center? The germinal center. He got to know what real MBBS is, and you have to study for NEET PG also. After the entire MBBS or germinal center got over, now he got so bugged with life कि मुझसे तो हो ही नहीं रहा. I am going and sitting in the margin. मुझे नहीं करना कुछ NEET PG FMG, मुझे सिर्फ शांति चाहिए. I am going in the mountains and sitting. So the B cell says I am going and sitting over here, that is in the margin. Some students said कि नहीं, I have studied so much, I should now join NEET PG, INI, FMG coaching, and I should increase my memory. So some B cell said I will become memory B cell. Then some typical type A personality students said नहीं इसी साल MD करेंगे फटाफट, उसके साथ we will do DM MCH also. So then they decided we will become super specialists and we will become plasma cells, right? So now what are we going to understand from this? कि पहले एक baby B cell था, it went into the unchallenged zone, mantle zone, then it went to the germinal center. After germinal center, either it said going to the mountains and sitting in the marginal zone, or it is using its memory and doing NEET PG prep, और इट इज़ बिकमिंग सुपर स्पेशलाइजेशन. उसको NEET PG उसका टारगेट ही नहीं है. उसका टारगेट है MCH, DM और बहुत सारे 10-20 एग्जाम पास करना. तो वो सुपर स्पेशलाइजेशन करना चाहता है. वाई डिड आई से? बिकॉज नाउ यू विल गेट टू नो द ओरिजिन. फ्रॉम द बेबी B cell, what arises? CLL, SLL. From the unchallenged mantle, what arises? Mantle cell lymphoma. From the margin, what will arise? Common sense, marginal zone lymphoma. What will arise from GC, germinal center? It is BFL, FL मतलब follicular lymphoma, BL मतलब Burkitt's lymphoma, and DLBCL, diffuse large B cell lymphoma. So FL, BL and DLBCL, all three of them arise from germinal center. What does not arise from germinal center is marginal zone lymphoma. फिर ये मेमोरी बी सेल ने क्या बनाया? मेमोरी विल ऑलवेज रिमाइंड मी ऑफ ब्रेन, हेयर. तो मेमोरी से क्या बना? हेयरी सेल ल्यूकीमिया. एंड प्लाज्मा सेल से तो कॉमन सेंस क्या बनेगा? इट इज़ गोइंग टू बी मल्टीपल माइलोमा. बट मैम यू आर फॉरगेटिंग वन वेरी फेमस आउल आई अपीयरेंस वाला हमारा हॉजकिंस भूल गए आप. हॉजकिंस कहाँ से आता है? समवेयर इन बिटवीन. हॉजकिंस comes from the post germinal center B cell. Okay, it has passed the germinal center. but internship मान लो. It has passed the germinal center, but it has not decided what am I doing, somewhere stuck in between. So that post-germinal center B cell is going to be giving rise to Hodgkin's lymphoma. Finally, now all your origins are done. Try solving a few questions today from the Q bank of lymphomas. These origin wale questions will come. Hopefully now you will not have a problem. Okay, now markers, I think baat ho gaye. Someone asked me, can follicular have BCL6? Yeah, it can. I mean, can का answer तो yes है, but in the exam do you have to learn it and go? No. For follicular you will remember more of BCL2 and you will not think of any BCL6. Okay. Now this is a blank thing that I have left for all of you, because when I will give the PDF to you, तो आपको क्या करना होगा, in front of all this you will have to write कि अच्छा इसका origin कहाँ से होता है. This is just a blank chart on the basis of this. So if you see a test which I have given in the PDF, so this is done. Meanwhile, I have a doubt over here which I'll take up. Someone is asking me, what is Richter syndrome? So Chona, what do you want to become in life? After this you will never ask me, ma'am, we want to become rich in life. Rich matlab abhi you are, let's assume you are a small person. You want to become rich, Ambani type. You want to become a big person. So think of a small lymphoma. Small lymphoma is small SLL. One day that small lymphoma says, now I'm sick of being small. I want to be big lymphoma, diffuse large B cell lymphoma. But small person becoming large person is becoming rich. That is Richter syndrome. When SLL changes to DL, BCL, that is Richter's. Yaad rahega, small person becoming large person, becoming rich in life. Done. Doubt is also over. Let's move on to another INI-CET type of question. Dual esterase positivity is seen in. Dual esterase positivity is seen in which of the following? Yes, we are 15 minutes away from clocking our 3-hour target, which is great. You guys are going pretty well. Very well, much better than my expectations. To be very honest, I'm not just faking it and saying it for you to sit longer, but truly saying it because I didn't expect this. Dual esterase positivity, AML M4, perfect. So now quickly what I would want you to revise, why dual esterase? Because this is just one line question जो आपको पढ़ के आगे बढ़ना है. M4 में I always study 2 का square, 4 का square, 16. I just keep doubling it like that. Why? Because when I'm talking about AML M4, I always think of only one chromosomal translocation that I have to learn, and that is inversion 16. And why 2? Because it has two type of blasts. Number 1, it has a myeloblast, and number 2, it has a monoblast. And now when I'll tell you this one line, this question will make sense. Do you know which is the esterase which is positive for myeloblast? It is chloroacetate esterase, E for esterase. That is a marker for myeloblast. And what is the esterase for monoblast? Non-specific esterase. So if AML M4 has both these blasts, this means both the esterases will come positive, and that is what we call as dual esterase. No one is asking you the logic behind it. They ask you a simple one-liner question, dual esterase bata do kiska marker hai. It is a marker for AML M4 because it has both the blasts, the myeloblast also and the monoblast also. Isliye dono esterase positive. Let's not break our head more on it. Let's move forward to the next question. Much expected. 55-year-old patient, dragging sensation of abdomen, something is pulling his abdomen down. Usually it is a case of massive splenomegaly that does that. CBC shows hyperleukocytosis and shift to left. What do you mean by shift to left? All immature cells. Look at this. Doesn't this look like a garden party? Every cell is different from the other. Everyone is enjoying big cell, small cell, neutrophil, orange wala, eosinophil. Sare cells hai, ma'am. Now they are saying bone marrow is shown, which I have seen. Information ke hisab se you have to pick out the incorrect statement. What did you mark? You said option B is incorrect. Okay, let's start. You are right. 210 kilodalton fusion is seen, which is correct, because when I say I'm thinking of CML, what were the two clinching features for CML? Pehla to splenomegaly, dusra this shift to left, and this garden party photo that was shown, where every cell, you don't have to identify every cell, you just have to make sure that har cell ek dusre se alag dikh raha hai. That is the garden party appearance. So it is the Philadelphia chromosome, it is the BCR-ABL fusion that you have. As soon as they say BCR-ABL fusion, you will say what is the weight of this BCR-ABL fusion. 2020 के increments पे रखना, 190 kilodalton, 210 kilodalton or 230 kilodalton, and think of LMN because 190 kilodalton is seen with ALL, 210 kilodalton is seen with CML, which is your case over here and is correct, and 230 kilodalton is seen with CNL, chronic neutrophilic leukemia. So think of 190, 210, 230, L, M, N, and your answer is done. So ये तो correct है. Coming investigation of choice is fish, that is also correct, because any chromosomal thing, let me show you. This is the fish. Any chromosomal thing will be detected using fish. Like over here they've said ABL को red color दिया, BCR को they have given green color. So usually it is red green अलग अलग. Suddenly I noticed that the red and green decided to fuse one day, and that is what is translocation 922 resulting in BCR ABL fusion. So for any chromosomal disorder, investigation of choice is fish. Are pseudo-Gaucher cells seen in CML? Yes, that is also a core INI vibe question. Pseudo-Gaucher cells, I mean they are very similar to Gaucher's disease. Gaucher's के cells कैसे दिखते हैं? Remember the crumpled tissue paper appearance, in case you've forgotten, the crumpled tissue paper appearance, that is Gaucher's disease, a totally different question. I don't have any plans of discussing this because it is so obvious, it comes in every paper. This crumpled tissue paper appearance wala question is actually Gaucher's. It is Gaucher's disease, कौन सा deficiency? Glucocerebrosidase deficiency. But I am saying when in CML such cells are seen, doesn't mean CML has become Gaucher's disease. Such cells are seen, and that is why I call them pseudo-Gaucher cells, and yes, they can be seen in CML. Okay, so the only incorrect statement that we picked up over here is option B, that is high lab score. Now what is lab score? Lab score stands for leukocyte alkaline phosphatase. If you want to call it NAP score, then neutrophil alkaline phosphatase, it means the same. Normal leukocyte alkaline phosphatase is between 40 to 100, and it is decreased in CML. It is decreased in CML. It is not increased in CML. It is less than 40 normally, not normally. It is less than 40 in CML. Normal कितना होता है? 40 to 100. CML में less than 40 जाता है. That is why this is the incorrect statement and the answer over here. Treatment, I think we all have already studied. It is imatinib, which is given. Imatinib is given only 2 places in the entire medicine and surgery. Number 1, it is given in CML. Number 2, it is given in GIST. And I think we are settled. Okay, please trick for lab score increase and decrease पढ़ लेते हैं. देखो CML के तो नाम में ही है ना small, लग रहा है ना small. तो lab score क्या होगा? Will it become big or will it become small? It will become small. It will become decreased. Whereas when is it going to increase? That is very famously learnt as lakes and ponds. We'll quickly revise this because again, in case you've not seen main videos, you might not know. But इसको ना ऐसे याद करने की बजाय, can you just learn that leukocyte alkaline phosphatase में कर क्या रहे हैं? We are looking at an enzyme called alkaline phosphatase. Where are you looking at this enzyme? In the neutrophils. So think of any situation where the neutrophil count will go up, automatically the score will go up. So if I say what will happen in a case of sepsis, ma'am, sepsis mein to neutrophil count goes up. If I say what will happen in a case of neutrophilia, of course neutrophil count will go up. What will happen physiologically in pregnancy, also you have studied, neutrophil count goes up. Do you know on consumption of oral contraceptive pills also neutrophil count goes up? And there is one syndrome, if I have any space left to write, it is going to be Down syndrome. Usme bhi neutrophil count goes up. Anywhere neutrophil count goes up, automatically the NAP score will also go up. तो याद करना है, ponds कर लो. And what is lakes? Lake stands for leukemoid reaction. Over there also neutrophil count goes up. The concept is the same. Wherever the neutrophil count will go up, automatically the score will also go up. And the only place where the score will go smaller or down is going to be CML. Okay, so leukemoid, pregnancy, OCP, neutrophilia, Down syndrome and sepsis. Coming next, ये वाला question skip कर दें. हो ही गया, मतलब क्या skip? Crumpled tissue paper appearance, if you see Gaucher's is going to be beta glucocerebrosidase. Gaucher's we always used to learn as Gaucher's, ouch, because the patient used to come to us with pain, bony pain, that we already know. तो आगे चलते हैं. A very quick question. I know I'm coming back. पूरा पढ़ के यहाँ वापस क्यों आ गए मैम? You've come back to flow cytometry. Here it is written CD 4161. I told you ना, think of your markers first. 4161 क्या था? ये तो वो M416 वाला गन था. M मतलब मेगा गन. This was mega karyocyte platelet वाला lineage. And now what they have marked, most of the cells that I notice are in this double negative quadrant. So what are they trying to say? That CD41 and CD61 are negative. तो इसमें से तो I didn't have to think of so much. The only disease which is corresponding to platelets is Glanzmann thrombasthenia. So there are 2 diseases that I think we all know. Number 1 disease that we know is that Bernard-Soulier syndrome, and the other one is known as Glanzmann thrombasthenia. In Bernard-Soulier syndrome, the defect is in GP1B9. Yes, that is the defect. And in Glanzmann thrombasthenia, the defect is in GP2B3A. Maybe you never noticed, but GP2B3A is nothing but 41 and 61, and that's where the real integration happens. कि आप 41, 61 पढ़ते तो जा रहे हो, but what is 41 and 61? It's the same GP2B3A. You are saying over here 41, 61 is missing. Indirectly, you are wanting to tell me GP2B3A is missing, and it is a case of Glanzmann thrombasthenia. And if I've studied this, then I'm going to enter now into a very toxic mode, which usually I tell students that you can read it from main videos, but time kahan hai ma'am, now 2 weeks left, what will I read from main videos? So now tell me all these tests in just 2 slides you have. That's your ultimate goal. आपको एक slide पढ़ना on platelet aggregometry, 1 slide on TEG, so that later on you don't have to open the main videos and get into that FOMO के हमारा रह गया. And I think by the time we finish platelet aggregometry and TEG, we will also clock in the exact 90 slides that we wanted to do. So let's keep a target of what? 6 minutes? Let's start. 6 or 8, 10 minutes. ठीक है, चलो, very good. Let's start. What is written over here? पहले तो what is false about Bernard-Soulier syndrome? Let's go one by one. Did we always study Bernard shows you big platelets, giant large platelets? That is correct. Did you study right now it is a GP1B9 defect of the platelets? ये भी ठीक है. Now they say, you are saying ये वाली गलत statement है. Ristocetin aggregation is normal. You are right. So what is this aggregation? Let's start. Let's do those 2 slides of platelet aggregometry. What am I doing over here? I am wanting to test for platelets. Everyone, what are we testing? Platelet. तो patient से क्या sample लोगे? Platelet का sample लोगे ना. So if they ask you what sample do you want to take from the patient, do you want to do platelet rich plasma or platelet poor plasma? तो please don't get too baffled. You have to put your common sense. मुझे platelet का testing करना है, platelet rich plasma लेंगे. And I might sound very dumb saying this, but exam में यही dumb वाला mistakes we do. So I will repeat this. Platelet aggregometry के लिए what sample am I interested in? You want to test the platelets, you take the platelets. But if I'm wanting to do coagulation tests, like you want to do PT testing, APTT testing, these are clotting factors के tests, ma'am. These are nothing to do with platelets. Should I take platelet rich plasma or should I take platelet poor plasma? Then take platelet poor plasma. So the common sense tells me platelet का test करना है तो platelet लो, platelet का test नहीं करना तो platelet मत लो. Get that concept? Okay, so platelet aggregometry, I took a lot of platelets. There are so many platelets, they are like in lakhs and lakhs. Can light pass through them? No. कैसे pass होगा? इतने सारे platelets हैं, how will light pass through them? It will not. So I decided that I am going to add some stuff. And what am I going to add? Number 1, I will add, can you tell me the 4 things we add? We add ristocetin. Next, we add ADP, epinephrine and collagen. And why am I adding this? Because as soon as I will add these 4 things, can you see platelets ने ऐसे aggregate करना शुरू कर दिया, तभी तो है platelet aggregometry. And as soon as they will aggregate, now the light will easily pass. जगह बन गई ना? Now they have made these small clumps. Now there is space for light to go. So can I say the principle of platelet aggregometry is what, guys? That's a question that they ask you. The platelet aggregometry ka principle is light transmittance. Question number 1. Actually 2. Question number 1, what sample do you take? Platelet aggregometry के लिए PRP. Question number 2, what is the principle? Light transmittance. Question 3, what are the things that you added? Ristocetin, ADP, epinephrine, collagen. तो 2 ही ग्राफ हैं. गूगल कर लो, नेट पे देख लो, जैसा मन करे कर लो. 2 ही ग्राफ है, वही आ सकते हैं. Either it is graph number 1 or it is graph number 2. I hope you will not mug it up, but this is how you have to learn it. As soon as you see this, please note, ristocetin tests for the first thing, GP1B9. If you want to test GP1B9, you are seeing the ristocetin graph. If you want to test for the other 2, that is GP2B3A, तो क्या चीज़ें ऐड करिए? ADP, epinephrine and collagen. So now tell me, this will not be written in the paper. It is common sense that red color will always be a color of alert. So this is the color that they have given to the patient. And then the remaining color that you have over here has been for a normal person. या आप assess करो exam में कि red color I will want to give to the patient sample because I want it to be alert signal, right? So can you tell me everywhere the normal and the patient, the normal and the patient, the normal and the patient are looking the same. So is there a problem with ADP, epinephrine and collagen? Is there a problem with GP2B3? No ma'am. Normal and patient are different in ristocetin. So can you tell me that in this patient, what is defective? GP1B9 is defective. If that is defective, what is it going to be a case of? This is a case of Bernard-Soulier syndrome. Does that make sense? Because these three are working exactly how it's working in normal people. The problem over here, the patient is different with ristocetin than a normal person. This means GP1B9 is defective, and that is Bernard-Soulier. Look at the next situation. In the next situation, look at the normal people's blood responding to ADP, epinephrine, collagen, and look at the patient's blood. Patient's blood is not responding at all. वो वहीं का वहीं है. The graph has not changed. This means over here the problem is with GP2B3A, and if that is a defect, what is that a case of? Glanzmann thrombocythemia. There is no other graph that you can get. If there is a problem with GP1B9 and ristocetin, it is Bernard-Soulier. If there is a problem with GP2B3A and all the others, it is Glanzmann thrombocythemia. Go back to the question. In Bernard-Soulier, is ristocetin aggregation normal? Of course not. यही तो है incorrect statement and answer. Ristocetin तो abnormal होगा ना. That is why we called it Bernard-Soulier. Is ADP, epinephrine, collagen going to be normal? Yes, because in Bernard-Soulier it's normal. This will be abnormal in Glanzmann thrombocythemia. Right? Now coming to the next, ये हमने एक चीज़ खत्म करी. The next thing that will finish off our 90 slide का clock is going to be in the emergency department. Child comes with, this is a very time waste wala question. This has been asked in the paper. There is a lesion on the forearm. As a surgery resident, you want to remove the lesion. You have decided it to be in the emergency OT. Totally off track. They ask you which of the following investigation will assess the complete coagulation pathway. Let's go option by option. APTT, PT, मैम ये भी तो clotting pathway assess करते हैं, but now tell me, PT tests for which pathway of the clotting factors? It only tests for extrinsic pathway. APTT tests for what? It only tests for intrinsic pathway. Bleeding time क्या test करता है? It tests only for platelets. Whenever, like in dengue fever or anywhere the platelet count is affected, that is where bleeding time will increase. So is there one test which can measure everything? Clotting factors also, platelet also, fibrinogen also, clot सब कुछ, and that is TEG. The only thing where the complete coagulation pathway is going to be assessed is going to be TEG. And we all know, you have seen the photo of the the instrument. This is how it looks like, this white color dabba. They will always give you what is happening inside that dabba, because every machine looks like a white color box. So you need to know, why is this the TEG wala box? Because here you have put the blood sample in this cup, and from the top, although you can't see it, but there's a very thin pin that is going to drop down. From here, a very thin pin will drop down. So just imagine if this is, for example, the cup, and from the top I have dropped this pin out here. So now what is happening? Either the cup is moving or the pin is moving. कोई एक चीज़ move करती है. कई बार दोनों are also moving. The point is, this cup has blood. If it will keep moving, the blood will start clotting on this pin. And the machine will feel, अच्छा, someone is pulling the pin down. Pin को pressure मिल रहा है. Because why? There is a clot forming over here. And that is what is TEG. TEG is measuring how a clot formation is occurring, and then this is put up on a computer screen. This is how it looks like on a computer screen. Machine में जो हो रहा है वो अलग. This is going to put down on a computer screen. Yes, we learn it as RK. Ranbir Kapoor is an alpha male. This is like that universal mnemonic. You read it from any subject, you'll read the same mnemonic. Some mnemonics work everywhere, like ship, drugs, pharma में भी है, path में भी है, medicine में भी है, same way. RK is an alpha male. So the first thing that you see, now keep correlating कि कहाँ पे क्या हो रहा है. Timings are not what they will ask you. No one will ask you 5 minutes कहाँ लगा, 10 minutes कहाँ लगा. They will ask you either label the parts of the graph or tell us the clinical application. What does it mean? बढ़ा हुआ है, कम है, मतलब क्या है? So the first thing that happens, we'll keep highlighting, is going to be what? Is going to be the R time. How much time is the blood clot taking? So ma'am, that is the reaction time, and that will be determined by the clotting factors. Clotting factor 1, 2, 3, 4, 5 and all. So that is the clotting factor, that कितना time लगा blood clot बनने में. After that, my next correlation will be, how strong is the blood clot? If I just look at this tiny little time over here, I have learned K time is for Kadak, because that will remind me how strong is my clot, how strong is it, and that is determined by factor 1. What is factor 1? Fibrinogen. That factor will determine how Kadak or strong my blood clot is. The next thing that I want to see, the speed that has gone up. The speed that has gone up is going to be the alpha angle. Alpha angle is also determined by the same fibrinogen factor 1. So can I say reaction time is determined by all clotting factors, whereas K time and the alpha angle, they are determined by the first clotting factor, that is fibrinogen. Finally, the blood clot has become to its maximum. इससे ज़्यादा blood clot बन ही नहीं सकता. What is this known as? Max amplitude. Now max amplitude means the blood clot is in its final stage. After this, though, it will break. After this, it can't form more blood clot. So that will be determined by both platelets and clotting factor, but more commonly by platelets. So instead of showing you, they say this is a normal graph. ये तो मुझे दिख ही रहा है. Suddenly they say the graph is looking like this. I mean, I hope, yeah, it's looking like a tuning fork. And what is the main problem you see in this graph? You will see कि मैम वो maximum amplitude तो एकदम से वो tuning fork जैसा बन चुका है. It's become such a small little maximum amplitude, minimum amplitude बन चुका है. So they will ask you what is the intervention you would want to take. Don't you think I would want to give this patient a platelet transfusion, because I think the maximum amplitude has had a problem. This means the problem in this person is actually in the platelet, something to do with platelet count or function. If I give him platelet transfusion, maybe his maximum amplitude will increase and his TEG will come back to normal. That is why I am saying it is so important to know and यही question है. PYQ में जाओगे तो ये है, maximum amplitude is a measure of platelet, clotting factors, or both. Answer is both. But if I say maximum amplitude is predominantly a function of which? Predominantly a function of platelets. Now I said TEG measures your complete clotting pathway. Clot बनना ही सिर्फ काम थोड़ी होता है. After you make a clot, you have to break a clot. So to break a clot also, you will notice that after maximum amplitude, fibrinolysis starts. The lysis occurs at 30 minutes. Usually at 30 minutes, 8% of the clot breaks. Roughly it breaks. So it measures the clot formation also. It measures the clot breakage also. That is why the complete clotting pathway is measured over here. Are we okay with this? Can we move on to the next one? What I've got over here is a recent SE, क्योंकि अभी too many dabbas and machines you were doing. So one dabba and machine we will settle quickly over here. And that is hemat का एक और चीज़ ख़त्म करो. What is this Sally's hemoglobinometer? No one except for the examiner uses this ever, because now we have machines to do it. But they actually asked you, okay, what is the principle of Sally's hemoglobinometer? How are you measuring hemoglobin? You take blood and what do you add to it? You add N/10 HCl. Why are you adding N/10 HCl? Because you are trying to make acid hematin. You are trying to make acid hematin, and that is how we test. So इसमें क्या होता है? There is one dabba. This dabba is known as, it's written over here, comparator. The dabba is known as a comparator. Then you will collect blood in this tube. So because it's a Sally's hemoglobinometer, you call it a Sally's tube. Then this is the pipette. You can see a pipette जैसा लग रहा है. And then there is a thin glass rod. No one is telling you mark the parts. They just ask you identify this as Sally's. Tell us the principle, acid hematin. And as I said, I have never used it as a pathologist. It was used decades ago. अब सिर्फ photo आता है. Okay, now someone said. Okay, I think, yeah, now I got the answers. Perfect. If I move forward, I just want to scan through this. Have we completed 3 hours? Yes. If you're asking me where are we are on the 95th slide, going on to 95th. So we are exactly where we had decided we will be. In another 30 slides, we will be done with the session, and then you will have 10-12 more slides as bonus. वो तो last minute revision आज नहीं करोगे. You do it somewhere after 10th of May also. I am okay with it. Nothing that requires immediate intervention. Let's start with this. Last 30 slides. Thank you for the cooperation, guys. I'm truly indebted for that cooperation of yours, because I didn't expect that you will sit with so much of zeal, determination, and so much of discipline. Been very kind. Okay, chalo, liver biopsy है, 4 साल का बच्चा है. There are some intracytoplasmic inclusions with PAS in a liver biopsy of a 4-year-old child with PAS. I don't want to look into all this. I think of only one disease, which is alpha-1 antitrypsin, because liver में PAS is only used for alpha-1 antitrypsin deficiency. They said which serum protein electrophoresis graph corresponds to this. Yes, so alpha-1 antitrypsin तो मैंने भी बता दिया. You have to tell me which is the graph which corresponds. So now this graph does not have any labelings also. हमें कैसे समझ आएगा? You must have seen a lot of people on on YouTube and otherwise also give you this hand mnemonic कि अच्छा, whenever you want to test for serum in the blood, if you want to know which protein is there, you do serum protein electrophoresis. Examiner will write it as SPEP. Serum protein electrophoresis ऐसे याद करोगे. In our blood, what is the maximum protein that you have? The maximum protein is albumin. Then you have these 3 fingers ना, तो 3 छोटा proteins. That is going to be alpha-1 protein, alpha-2 protein, and beta protein. And then you have one mountain, small little hill over here. That hill is going to be the gamma protein. You know na, gamma is what? Immunodeficiency immunoglobulins. So that is the antibodies. So repeating, max is albumin, alpha 1, alpha 2 and beta, and then you have the gamma. So now without showing you graphs, put your common sense. Suddenly if there is a deficiency of this alpha 1, तो you will say अच्छा वो alpha 1 antitrypsin deficiency हो गया. Suddenly if I say कि अच्छा gamma immunoglobulins have increased more, so immunoglobulins, maybe it is a case of multiple myeloma. So let me show you the variations. This is normal. Can you see maximum is albumin, then alpha 1, alpha 2, beta, and then that hill over here is going to be the gamma. What do you see has happened here? Suddenly that alpha 1 peak has gone down. Is this a case of alpha 1 antitrypsin deficiency because that has gone down? Yes. Let's move on to the next. I suddenly notice, and they will always give you a normal se comparison milega, because randomly looking at it you won't be able to guess, right? Now let's see over here. If I look at the normal albumin, suddenly the albumin levels have gone down. Albumin levels यहाँ पे भी कम है, albumin levels यहाँ पे भी कम है. Always think of two organs. Either the liver has some problem, synthesis में problem हो गया, बन ही नहीं रहा, or the kidney is having one of those nephrotic syndrome days where all the albumin has gone out into the urine, massive proteinuria has occurred, so the poor albumin in my blood has gone down. So liver या kidney का problem है. Suddenly when I saw that the albumin has gone down, there is also a beta gamma bridging that has happened. Can you see the beta and gamma, which were supposed to be like beta alag, gamma alag, suddenly they have become beta gamma bridge. That is what you see in a case of cirrhosis of the liver, because when the albumin levels go down, it is a compensatory mechanism. Beta gamma bridging occurs in liver cirrhosis. On the other hand, when albumin has gone down, why? Because kidney ने सारा कहाँ निकाल दिया? All of it has gone into the urine. Then what does your body start doing? Your body says, अच्छा, one protein has gone, so let me increase the other proteins, alpha 2, beta. Body starts making other proteins, so they increase, and this will now remind you of nephrotic syndrome. I'll repeat this once again. This first graph over here is normal. Suddenly if the alpha 1 dips, this was the answer over here, this is alpha 1 antitrypsin deficiency. In the next, what do you notice? यहाँ पे beta gamma bridging is happening. This must be a case of liver cirrhosis, and this is a test for you. What is this last one? This is what? इसमें suddenly the gamma has gone all the way up. This is the M spike. This is a case of multiple myeloma. यहाँ पे क्या mark करना था? यहाँ पे alpha 1 antitrypsin deficiency सोचा. Tell me all the questions of alpha 1 antitrypsin deficiency for the exam. You will tell me the chromosome of alpha 1 antitrypsin gene, and that is chromosome 14. They love asking you chromosome 14. It's a very NEET PG-ish question, but I think it can be asked here as well. You never know, with multiple options coming in INI, they ask you chromosome 14. But what's the name of the gene? It is not alpha 1 antitrypsin gene. The name of the gene is the SERPINA gene. Exactly. Okay. Whenever alpha 1 antitrypsin is deficient in someone, which are the two organs affected? I told you ना, ये autosomal recessive disease है, तो छोटे बच्चों में होता है. छोटा बच्चा, we named him as Lal. The favorite nickname of our country for any छोटा बच्चा is Lal. लाल को लाल होने वाला है, मतलब alpha 1 antitrypsin deficiency में what are the two organs getting affected? The liver and the lung. Liver में क्या होगा? Cirrhosis. Lung में क्या होता है? Emphysema. They ask you which type of emphysema. That is pan-acinar emphysema. And what is the special stain? I think I have already taught you. PAS. One question I have for PAS for INI-CET students. PAS positivity can be seen in the entire world. I mean, I can list 30 things which are PAS positive, but I don't want you to go through that torture of learning. So I will just say PAS positive आया, then read diastase sensitive or diastase resistant. As soon as they say diastase sensitive, you will think of glycogen. As soon as they say diastase resistant, you will think of anything else. Like over here, if they ask you alpha 1 antitrypsin deficiency is PAS positive, diastase sensitive or resistant, you'll say glycogen hota to sensitive hota. Anything else I will put under diastase resistant. So can I say PAS positive, diastase resistant? It is what I will mark over here, and this is also settled for me. This I had put up as a test for you, but I think you already have answered for me. इसमें क्या disease का answer बना के आओगे? You will mark it as multiple myeloma. Why? Because of a monoclonal gamma spike. So your test is already done. Moving on to the next. Clocking in the 100th slide. What is the interpretation of iron deficiency anemia? Which is dumb question hai, but some things I've kept for completion, के syllabus completion करना है. So iron deficiency anemia में तो सब deficient होगा मैम. Ferritin will be low, transferrin saturation will be low, iron तो obviously will be low. That is why there is going to be an increase in the TIBC. Everything is right. So as I said, it's sounding very dumb. So when I say serum iron, iron का transport partner कौन है? Transferrin saturation. Then what is the storage form of iron? It is going going to be ferritin. And then what is the last parameter? Total iron binding capacity. Fill in the blanks for all of these. Very good. Iron deficiency mein to ma'am everything is deficient. That is why our hunger for iron binding capacity is more. This is the poor sad story, poor poverty wala story. Then let's come to the Ambani rich story where iron is in excess. There is so much of iron, so much of transference, so much of bank account ferritin that the hunger for iron automatically decreases. So ek dusre ka bilkul opposite. This is deficiency, this is overload. But the story always messes up with anemia of chronic disease. Their favorite chronic disease is rheumatoid arthritis. They will ask you which interleukin is responsible for anemia of chronic disease. It is interleukin 6. What is happening in anemia of chronic disease? Initially it looks like an iron deficiency anemia कि iron कम है, transferrin saturation कम है, but the story flips at the bank account. The bank account shows you a lot of ferritin, a lot of iron, and that is why the total iron binding capacity tends to decrease. These are the questions for iron. See, initially this also looks like IDA and this also looks like IDA. So always look at the bank account. If the bank account doesn't have iron, it is IDA. If the bank account has iron, you will think of anemia of chronic disease. For iron deficiency anemia, the treatment is that you will give iron supplements. Either you give tablets or you give tonics or you give parenteral iron therapy doge. But in anemia of chronic disease, you will be treating the chronic disease. Let's assume over here you will be treating rheumatoid arthritis. Done? Okay, so इसमें तो कुछ extra है नहीं, but maybe some bodies and all extra you would want to know. Let's do that with the help of this question only. A patient presents with increased serum ferritin, okay, decreased TIBC, increased iron and increased transferrin saturation. Everything is increased. It's an Ambani situation, a rich situation. I think this is a case of sideroblastic anemia. Most probable diagnosis, okay, why did I waste my time? It is sideroblastic anemia. Which of the following peripheral smear findings best correspond to the same? So what did this question number 1 teach you? That sometimes you get so stuck on the first 2-3 lines, you don't get a basic vibe of the entire question. Getting that hang of it is so important. Kai baar aap pehli line pe oh no, I didn't revise serum iron, now it has come. But maybe if you would have read, you would have learned that examiner has wasted your time and given you the tentative answer and you were just panicking over nothing. So now tell me which peripheral smear finding A, B, C, D में से कौन सा? You are saying B वाला. क्यों बी? क्या लग रहा है? कौन सा बॉडीज? सिड्रोब्लास्टिक अनीमिया इज जस्ट एक्सेस ऑफ आयरन एंड आयरन इन एक्सेस रिजल्ट्स इन विच बॉडीज? द पैपेनहाइमर बॉडीज. यस, पैपेनहाइमर बॉडीज आर बेसिकली मेड अप ऑफ आयरन. एंड हाउ डिड आई आइडेंटिफाई दिस टू बी पैपेनहाइमर बॉडीज? बिकॉज मैम यहाँ पे बहुत सारा डॉट 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 दिख रहा है इन द रेड ब्लड सेल, बट इन द फर्स्ट फोटो ऑल्सो आई सी सम डॉट्स, इन द थर्ड फोटो ऑल्सो आई सी सम डॉट्स. सो वेन एवर यू स्टार्ट सीइंग डॉट्स, दे कैन जस्ट बी 3 फोटोज दैट आई एम नाउ गोइंग टू टेल यू. तो तीनों फोटोज में कैसे डिफ्रेंशिएट करना है. फोर्थ वन तो आई एम नॉट इवन बॉदर्ड अबाउट बिकॉज यू नो दैट स्कैबो रिंग, वो तो फिगर ऑफ 8 वाला पता ही है. राइट नाउ आई एम टेंस्ड अबाउट दीज बॉडीज. वेन एवर यू गेट सच अ क्वेश्चन इन द पेपर, यू विल गेट इट इन सो मेनी डिफरेंट वेज. यू विल सी इज द स्लाइड लुकिंग रेडिश इन कलर, बिकॉज यूजुअली तो रेड कलर होता है ना. यूजुअली वॉट इज द हेमाटोलॉजी स्टेन दैट आई यूज? इट इज गोइंग टू बी द रोमानोव्स्की स्टेन दैट वी आर गोइंग टू यूज फॉर entire hemat. But in the third photo, I have not used Romanovsky stain. I have used something different. It's not looking red. It's looking something grayish, dull sa bad color it is looking. Because till the time I'm using Romanovsky stain, I can see all the bodies. But which are the bodies that you don't see on Romanovsky stain is Heinz bodies. Heinz bodies are seen in G6PD deficiency anemia. क्या होता है Heinz body? खराब वाला hemoglobin, denatured hemoglobin. See, normal hemoglobin I could see on Romanovsky. But bad denatured hemoglobin I won't be able to see on Romanovsky. For denatured hemoglobin I have a special stain, and that is going to be the crystal violet stain. So there are so many ways of asking you this question. Question 1, Heinz bodies are seen in G6PD deficiency. Question 2, what is the composition? Denatured hemoglobin. Question 3, which is the body not seen on Romanovsky stain? Heinz body. Question 4, what is the special stain for a Heinz body? Crystal violet. Every possibility is there. तो ये तो आइडेंटिफाई हो जाएगा. अब जो रोमानोव्स्की में है, यू विल सी, एम आई सीइंग 1-1 डॉट? Every cell has 1-1 dot or every cell has many dots. अगर 1-1 dot है, that is the Howell-Jolly body, and अगर many dots हैं, they are going to be the Pappenheimer bodies. Pappenheimer bodies I've told you they are iron, seen in sideroblastic anemia. Doubt हो रहा है, confirm करना है, तो iron के लिए we all know the special stain, which is a very basic thing to write right now. That is going to be pearls or Prussian blue. Whereas अगर single dot देख रहे हो, तो that is going to be the Howell-Jolly bodies. Howell-Jolly I already told you, happy and jolly to be single. I mean till your exam you can be happy and jolly that we are single, no distractions, no one to bother us, no one to fight with us. So happy and jolly to be single. It is single dot, and that is seen in megaloblastic anemia. It is also seen post-splenectomy, which is their favorite clinical question, ke post-splenectomy patient tha, what is the finding that you will see in the blood? You will see the Howell Jolly bodies. Now coming to the last one, only for your completion, cabo ring dikh raha hai. Cabo ring is made up of mitotic spindles, as you can see, and it is seen in the same megaloblastic anemia or vitamin B12 deficiency. But yahan pe sideroblastic tha, my answer is option B, which is done. So many dots you have studied, ek ye wala bhi bata do. When the entire red blood cell is full of these dots, what is this known as? Both of them showing over here. That is known as basophilic stippling. Now there are two things. Either the basophilic stippling will be very, very chota dots, that is fine, or the basophilic stippling is going to be extremely mota dots, and that is going to be coarse. Now fine basophilic stippling can be seen in thalassemia. I mean, they don't ask you much. They can be seen in so many diseases. Fine basophilic stippling can be seen in thalassemia. It can be seen in megaloblastic anemia. वो मेरे लिए point of concern ही नहीं है. I want to know where is this mota coarse basophilic stippling seen, and that is seen in lead poisoning. That's a question which I would want to know. I have two more questions for you. For lead poisoning, number one, you see coarse basophilic stippling. Number two, does it cause microcytic anemia or macrocytic anemia? Because I remember lead poisoning was also a part of that Sita Sheetal mnemonic. So we had studied it as a part of microcytic anemia as far as I remember. Last question that I have from the last page of your notes, whether main videos, rapid revision, or any notes that you studied. Vacutainer. If you are suspecting a patient of lead poisoning, which is the color of the vacutainer in which you will collect his blood? It is going to be, we had learned lead, tan, tin, so tan color vacutainer. Which color vacutainer? Tan color vacutainer. Basically, it's a vacutainer that has EDTA only. वही पर्पल वाला, बट EDTA पर्पल वाले में होता है, EDTA tan कलर में भी होता है. तो प्रेफरेबली वी विल बी यूजिंग विच EDTA कलर कोडिंग फॉर वैक्यूटेनर फॉर लेड पॉइजनिंग. वी हैड स्टडीड लेड, टैन, टिन जैसा, लेड जैसा, तो दैट इज tan color vacutainer. Okay, so all lead वाले questions try to simulate. Now let's come to, because you started doing bodies, from 1 cell we will finish 1 anemia. Let's plan that way. Which is the first cell that you see over here? This is the bite cell. Bite cell is also known as what? Bite cell is also known as the dog bite की तरह याद रखना. It is known as the degmacyte. It is seen in G6PD deficiency. तो सब तो पढ़ लिया. G6PD deficiency shows you these Heinz bodies, crystal violet वाला. G6PD deficiency is going to show you the degmacyte or the bite cell. Okay. What is this next? Who will forget the sickle cell? Sickle cell थोड़ी ना लिखेंगे. They will write drepanocyte. Drepanocyte is nothing but the sickle cells which you see in sickle cell anemia. We all know the sickle cell anemia का history. It is somehow always a 14-year-old boy with bone pain. I don't know 14 का कभी 16 या 12 भी नहीं हुआ. It is always a 14-year-old boy with bone pain. Why bone pain? Because these sickle cells, they tend to always stick to each other. So they tend to cause occlusion of the blood vessels, and hence they result in bone pain. Not to forget, there is an update which I know I'm entering into a major controversial zone. I know some other faculties will tell you कि ऐसा नहीं mark करना है and all of that. I'm telling you beforehand, before you come out to me saying कि ma'am so and so faculty told us कि ये update अभी मानो मत. It has not come in the books, and I agree, it has not come in the books. Earlier it was said that at beta 6 position in sickle cell anemia, glutamate can go and valine is welcome. So glutamate to valine होता है. But now they say that instead of beta 6, this has happened at beta 7. It's not that we knew something wrong, वो बस उन्होंने numbering change कर दिया. Methodology of numbering the DNA has changed. So now they say the position which was earlier read as beta 6 is now read as beta 7. So now there is, I know this, why would I want to go into controversy, but I know this will come your way when you read later on. So the only thing is it in the textbooks? No. Is it all over the internet in very valid high-end journals which are followed a lot over the world? It is there in the journals. What should you follow? My advice is that you follow this, and if you have an option of marking 7, you mark it, because A, you are appearing for INI exam. They are not going to give you redundant, obsolete knowledge. Second, I don't know how many of you have seen this, but go back to the papers of 2024 when this study was ongoing. And there was a question of sickle cell anemia. If you want to go into the, you want that evidence-based, I'll put it out for you. So many students came back from the exam in 2024 and said that, ma'am, there was a question on sickle cell anemia and they did not write beta 6. It was not there. So they didn't know what to mark, because tab tak to this was an ongoing research. So when it was ongoing and they gave it in the INI-CET paper, now it is a well-established research. Why would they not want to give it now? My advice, I would have been in your place after a lot of thought process, reading and everything that I have done. My final verdict is कि please mark beta 7. Yes, it is not in the textbook, but textbook का edition आता है 2-3 साल में. वो वहाँ तक आने में takes time. It can't be today it was discovered and tomorrow it will be printed in your textbook. It will come in the next edition. So don't wait till that. All said and done. पूरी कहानी इसलिए बताई because a lot of controversy is there. Please mark beta 7. Coming to the third one, ये कौन से cells लग रहे हैं? Can you see for me? Can you look carefully, look around? Are these cells looking as if they are crying, just like you crying right now at the end of almost 3.5 hours? So yes, that is going to be the teardrop cells. Teardrop cells are known as dacrocyte. Dacro word only means teardrop. Why did they become teardrop like this? Because in the bone marrow, I hope this looks like bone marrow. In the bone marrow, this is fibrosis, myelofibrosis. Basically, the bone marrow is fibrotic. So the red blood cells, while they were coming out, they had to struggle and come out. And in that struggle of coming out, they ended up changing their shape. So now the 3Ds are done. Degmacyte is bite cell, drepanocyte is sickle cell, and dacro matlab crying, and that is going to be the teardrop cells. We are still not done with the cells over here. This is what we come to. I'm constantly telling you slide number 104 for those who are counting. 125 is where you have to get. Okay, what is this cell over here? You all identified. This is going to be the सारे लिख दिए. This is going to be the target cell or the codocyte. Target cell कहाँ दिखता है? A quick revision, thalassemia. Then what is this cell? The one that shows you such prominent spikes, you don't even have to zoom in. This is known as the acanthocyte because acantho word only means spike or spur. Acanthocyte is seen in which disease? A beta lipoproteinemia. A for A. And finally, ये छोटा छोटा blurry वाला cell, this blurry वाला cell, little zigzag blurry, is known as the Burr cell or echinocyte. Burr cell is seen in Burns patient. Burr cell is seen in uremia patient. So simple question आता है, Burns का patient है क्या दिखेगा? Echinocyte. Kidney failure मतलब uremia का patient है क्या दिखेगा? Same echinocyte, Burr cell. A beta lipoproteinemia का patient है acanthocyte. Thalassemia का patient है target cell or codocyte. Okay, what is this over here? These cells are tuta futa and अपना imagination. Some say this looks like a hat, some say this looks like a helmet. You can use any random shape. They are fragmented, they are broken. What are fragmented red blood cells known as? They won't write fragmented. They are known as schistocytes. They are fragmented red blood cells. Umbrella, helmet, hat, whatever you want to call. It all means the same. Next, when the RBCs are like this, they are like one stack of coins. That is known as rouleau formation. Rouleau formation is seen in multiple myeloma. But if they are stacked and they are not stacked in a coin form, they are just agglutinated. तो agglutination कहेंगे इसको. कौन सा disease होता है? Cold agglutinin disease. Can you tell me cold agglutinin disease में agglutination? तो you understood cold occurs at which temperature? 4 degrees. And this is due to which antibody? IgG was working at G for garam temperature. IgM is the one that works at cold temperature. So at 4 degree, it is IgM which is resulting in this agglutination. Yes. Now coming to the next, Dr. Murli, any doubts or extra things? At the end of 4 hours, I'll be sitting here, so don't worry, we'll refer to those. Now my question is, why did this IgM suddenly start forming? Yes, it is because of a particular infection, bacterial infection, mycoplasma. So they will give you a history of mycoplasma, which we will study on Monday. याद है वो fried egg colonies वाला bacteria. So mycoplasma, fried egg colonies, वो IgM बनाता है. That IgM works at 4 degrees and it results in agglutination of the red blood cells. We will talk more about it. Let's come to the next shape. What is this? Spherical wala kya ban gaya? Spherocyte. As soon as I say spherocyte, what is the most common cause of spherocyte? Don't mark hereditary spherocytosis. I think I have told you so many times in so many places, but one last time, what is the most common cause of spherocyte? It is not a hereditary spherocytosis, it is autoimmune hemolytic anemia. So what you'll do with me, before you go to the second one, that is HS, you will actually revise all the points of autoimmune hemolytic anemia for me. You are saying autoimmune matlab cold या hot. Warm कब होता है? 37 degree पे. Which is the warm antibody? Warm antibody is going to be garam antibody. It is IgG that is working very good. Cold will obviously occur, ma'am, at 4 degrees. ये तो common sense है. तो cold is where the confusion occurs. Cold autoimmune hemolytic anemia occurs at 4 degree but is of two types. One type you have just now studied. You have already studied cold agglutinin disease where you have studied कि वो mycoplasma की वजह से है, IgM बन रहा है and all the RBCs are agglutinating like a group. You know that. But now I tell you one more type which is also occurring at 4 degree, and that is when the RBCs are breaking.
cold hemolysin. ऐसा क्यों हुआ? जब ये भी 4 डिग्री पे था तो break क्यों हुआ? Because now IgG comes into the play. Remember I told you the story that all IgGs are going to work at a garam temperature of 37 degree, but there's one IgG who decided, they say all students decide that we will do a mass bunk, but then one student decides, no, I want extra marks from the teacher, so I will go and sit in the class and get my attendance. So this is that one IgG who decides I will garam to theek hai, but I will work at cold temperature also. And this IgG is one which will work at 4 degrees and it will break the red blood cells, hemolysis. इसका नाम क्या रखा था? Very good. Donat-Landsteiner antibody. It's a special name given to that IgG which says I will ditch the group and I will work at 4 degrees also. Just like that student, do not be the Donat-Landsteiner of your batch. अगर mass bunk हो रहा है तो कर लेना. One day will not matter much in your life. Repeating once again, I shouldn't have said this, but one day only, okay, out of all the years. Autoimmune hemolytic anemia, warm, cold, temperature और antibody के basis पे हो जाएगा. Those show you the spherocyte. If it is not autoimmune hemolytic anemia, then what is it going to be? It is hereditary spherocytosis. Now tell me, hereditary spherocytosis, autosomal dominant hai, they will have to give me a history, father, mother, brother, sister, someone had it. What is the most common mutation of hereditary spherocytosis? It is going to be enchirin mutation. What is the screening test of hereditary spherocytosis? Osmotic fragility test. But now they ask you what is the confirmatory diagnostic test? EMA testing, eosin 5 malamide testing. I am going so much back, but when we were doing flow cytometry, do you remember I showed you one of the graphs of flow cytometry which was looking like a histogram? I don't know how many of you noticed it, but over here hereditary spherocytosis was written and that is what was done as EMA testing. EMA testing हो रहा था, तो खुद सोचो, a normal person with EMA shows you this kind of a graph. But hereditary spherocytosis का person shows you एक छोटा वाला graph. They won't ask you in detail, but I just want to tell you that EMA testing is basically done by which technique? EMA testing, okay, lots of slides I'll have to skip and come forward to, but yeah, EMA testing is done by flow cytometry and that is what we have. Finally, treatment. What is the treatment that you have? It's a hereditary disease. You can't change the genetics, but you can do a splenectomy to basically save the patient from hemolysis. So I think we have settled this. अगर HS भी नहीं है तो फिर तीसरा cause क्या होगा? G6PD deficiency. So now listen to two questions and answer. You have this spherocyte गोल वाला cells. If they say there is a pregnant female who is showing you this, what is the first thing that comes to your mind? The most common cause, autoimmune hemolytic anemia. If they say the same kind of history that you have over here, but this time the father also had it or the mother also had it, they've given you a history of family involvement, then straight away what will you mark? Then you will mark HS. Family history आ गया तो फिर please AIHA मत mark करना है. Family history comes, please mark or hereditary spherocytosis. Let's move forward to the next one, and this is more of a micro question, but I'll put it up over here. This is a bone marrow. On bone marrow, they will say this is some kind of an RBC precursor, and in this RBC precursor, I can see there are projections coming out like dog ear projections. Which virus causes this in the bone marrow? It is parvovirus B19 causes dog ear projections in the RBC precursors. Do you remember what parvovirus B19 does to the bone marrow? Shutter down. It says that the bone marrow, I will not let you work at all. I will make you undergo into aplastic crisis. Parvovirus B19. Why wait for microbiology? Parvovirus is a DNA virus, and I had studied all DNA viruses are double-stranded, but Parvo was like Aishwarya Rai from Paro Devdas. She was left alone. This is the only single-stranded DNA virus that we had. Then also she was crying because she was like, "Baki sabka to size acha hai. I am the smallest virus that they have made." So she's crying so much. She cried so much that her cheeks became red. What is that kid that is born with that or not going to have that slabbed cheek appearance? These were all the questions that you had with parvovirus. So she was the only single-stranded DNA virus, the smallest DNA virus, the one with red cheeks. Yes, and slap karne ke liye we needed 5 fingers. So this was also known as the fifth disease. Very, very good. What does this do to the bone marrow? In pathology, it says bone marrow, I will not let you work at all. You will have to shut down your work. That is aplastic crisis. What will the red blood cells show you? They will show you dog ear projections. So many images done. We can finally move forward and go on to the next question. This is more of, you will study this in medicine LRR also, I'm sure. There is a patient reported experiencing difficulty in breathing during physical activity for a period of 1 month. An echocardiogram revealed the presence of MS, and there is left ventricular LVH hypertrophy. To identify the histopathology has been mentioned, and then you have to tell me the diagnosis. On the basis of MS, a lot of people think it is rheumatic heart disease. It could be, but with rheumatic heart disease, photo bhi to ash of body ka hona chahiye. This is not a picture of ash of body. This is a picture of how the nuclei have become like boxes. And yes, the only one-liner that I wanted to teach you over here, boxcar nuclei in the heart are seen due to hypertrophy. This also reminds me of a boxcar bacteria. So isme to ek one-liner tha. Where do you see boxcar nuclei present in the heart? It is going to be in hypertrophy, which was mentioned over here, and I've got my answer. But which is the one? What do you see as Bacillus anthracis? Bacillus anthracis bhi to aisa hi dikhta hai na. Some people call it the bamboo stick appearance. Do you know in the FMG exam, instead of calling it bamboo stick appearance, they called it the boxcar appearance. This is a question that I've got from your Q bank only, PYQ screenshot. So yes, this is going to be the bamboo stick appearance or boxcar. So boxcar bacteria bola, Bacillus anthracis, boxcar nucleus bola heart mein, that is going to be cardiac hypertrophy. Then it will be just another PYQ Q bank say screenshots I have got, because I just want to tell you those easy questions jo I told you na last one are thoda easy ho jayega. So now here you will notice there's a classical, I'm not wasting time in reading how it is an MI question because this is not to do with ECG. They are doing an autopsy and they have stained it with TPTC, triphenyl tetrazolium chloride. Wahi to karte hain, easy question. They've asked you what color will be represented by the viable myocardium, by the normal myocardium, and that is brick red. So this is only for your revision. Whenever we have a case of myocardial infarction, what is the stain that we use? TPTC stain. TPTC is triphenyl tetrazolium chloride. This gives you very version 10 vibes, black background. Triphenyl tetrazolium chloride. And over here, you know, what does that stain? Fill in the blanks. It stains excellent. It stains LDH1. What is the color of the normal heart? Normal heart comes out to be brick red in color. What is the color that is given to the heart where MI has occurred? That is going to be a pale color. Next question. Within how many hours of death or of myocardial infarction will this be useful? TPTC, within 4 hours of MI death it is going to be useful. Amazing, great. So this was, I mean, nothing for me to tell. Another screenshot from your PYQs. Which of the following histopathology finding is most likely to be seen in cardiac reperfusion injury? We all understand what is cardiac reperfusion injury. Answer to pata hai, it is contraction band. I hope you are okay with the speed at which I am going, because these are, you've seen these questions so many times. I'm not wasting any one extra second also on them. ये जल्दी करने वाले questions है. What is this? This is contraction band necrosis. उसका क्या मतलब है? That in the cardiac muscle suddenly I'm seeing a lot of contraction bands. Why did that happen? Because let's assume this was the heart, and forgive me for this very bad diagram. My diagrams are anyway bad. And let's assume कि ये जो इसे coronary artery supply कर रहा था, इसमें एक blood clot हो गया था, and that is why this patient landed up with MI. Now what happens is you are going to open this blood clot. Either you will give a fibrinolytic therapy or you will do an angioplasty, stent लगाओगे. Basically you are going to open this, and that is what you call as reperfusion, right? But when you opened this blood clot, what actually happened in that duration कि जितना भी यहाँ पे free radicals था, जितना भी calcium था, all of that calcium and free radicals just ran to the heart. All that calcium will run to the heart so much that heart will contract. One last time it will contract, or all the free radicals will run to the heart and they will contract the heart, they will damage the heart. That is why these contraction band necrosis are formed. The heart ends up dying, and that is what you see with reperfusion injury. You see contraction band necrosis. Why? Because as soon as you opened the clot, all the free radicals ran, all the calcium ran. जो रुका हुआ था, like suddenly at the end of 4 hours when I'll finish this session, all of you will not even wait कि bye बोलने के लिए, will be like end the session and run away. Same thing happened. As soon as the block was opened, all of them ran, and they resulted in the heart contracting too much, resulting in contraction band necrosis. ये भी easy question. Moving on to next. Now I'm just, these are no questions like relay race. अभी relay race हो गया. Now we are looking at individual PYQs which are there in any subject, maybe integrated ones, random PYQs we are now solving. Which of the following are benefits of the pap smear technique that has been shown below? All are except. पहले तो कौन सा technique है? Is this the usual conventional pap smear? I don't think so. I can see a brush and I can see a liquid. I think this is the new wala liquid based cytology. Why has this been done? Does it make it easier for me? Yes, it's an ease, because look at this na, the slide is just this much of a small circle. मेरे लिए कितना आसान हो गया. I just have to look at this few 13 mm का circle मुझे देखना. I don't have to look here and there. It becomes very easy for me. Plus it's automated. It's a machine. Second, does it give a clean background? Again, yes, because when you are doing liquid-based cytology, this is all automated. Do you think the machine is going to catch all the blood and the mucus and the debris from the female genital tract, or the machine will catch the real cells, infections, cancers? So machine says, "Baki sab blood, mucus hata do." It gives a very clean background. That's an advantage. Will it waste the sample? Not at all. All the sample is put in this small dabba. There is no sample that is falling here and there. Minimal wastage. The one that is not going to definitely be an advantage to me is manual processing, because it is not a manual processing. This is done automated. This is a machine based thing. But I have a question. कोई भी टाइप का आपने वो करा, I'll just erase this for a while. If you have done conventional pap smear versus liquid based cytology, can you tell me the adequacy criteria for pap? And that question I asked because way back, I think 2-3 years ago, when we were doing thyroid का एक हमने 6-10 adequacy criteria करा था on FNAC. That is one INI question. Second is pap smear. Pap smear में अगर हमें endocervical cells देखना है, endocervical cells, whether I'm doing conventional pap or I'm doing liquid based cytology, how many endocervical cells should I see? 10. Even if I see anything equal to more than 10 endocervical cells, I'm like, it is adequate. But when it comes to ectocervical, कौन से होते हैं? Ectocervical are the squamous cells. For conventional, I should see 8,000 to 12,000, and for liquid based cytology, I should see 5,000. Very good. All of you are like, this is the Bethesda system, because pap smear has been given by the Bethesda system. So repeating, endocervical दोनों techniques से 10 होने चाहिए. I'll say it's adequate. For ectocervical, for conventional, it is 8,000 to 12,000. For liquid based cytology, it is 5,000. We move forward. These are some random photos from the same pap smear, because this will be a very good path micro gynae integration. सबसे पहले एक एक infection बता दो मुझे. Maybe one point about it you can tell. What is this cell on a pap smear, and what will you think of? I will be thinking of bacterial vaginosis, because these are clue cells. See, these are cells on which which bacteria? Can I write Gardnerella vaginalis? That Cocobacillus, that Gardnerella vaginalis has basically gotten stuck over here. And which is the criteria? 2 criteria for bacterial vaginosis. One is Amsel's criteria, और उससे ज़्यादा आजकल they like to ask that question on the other one, other than Amsel's criteria, Nugent criteria. Am I remembering it correctly? So Amsel's criteria, Nugent criteria, their favorite 2. इन दोनों में से clue cell कौन से criteria में आता है? Does it come in Amsel or Nugent? Please teach me little gynae. Amsel criteria says के clue cells दिखने चाहिए. At least more than 20% clue cells should be seen for us to call it bacterial vaginosis. Very, very good. Coming to this picture over here, this is still looking very classical. The classical cotton woolly ball. Some people say it's looking like rays of the sun. So sun ray bol do. People who like to learn from scientist names have already written this to be Gupta bodies. So anything that is looking like a dhaga, cotton, wool, sun, that is okay. Actinomyces, what is the history that I get in it? It's always seen in an intrauterine contraceptive device user. History शुरू हुआ IUCD से, photo कुछ भी हो, you will be marking actinomyces only. Coming to your favorite dish, kebab lovers, sorry for this. This is the shish kebab effect, where all the cells are standing as if they are pieces of a kebab on a stick. Shish kebab effect is seen in Candida. And what is the color of the discharge? It is a curdy white discharge that you see, you know this. Now coming to the picture where you will not understand anything. समझना भी नहीं है, because this will never come as a picture alone. They will always give you a history of a greenish color discharge. Either that will be the history, or they will make that famous strawberry cervix with that green color discharge on top of it. So what are you thinking of? It is Trichomonas vaginalis. Yes, it is a pear-shaped organism. वो कुछ समझ ही नहीं आ रहा यहाँ पे मैम. वो फोटो में भी नहीं आएगा, एग्जाम में भी नहीं आएगा, because in the exam when they will give you that strawberry cervix and on top of that they will write the greenish discharge, you will anyway be thinking about Trichomonas. Okay, so this is done. What I've not included HPV, which I should have, but then I have microbiology also to do, right? So वो तब हो जाएगा. HPV, HSV, some things I've not included right now, because let's do it at the right time on Monday when we will. Okay, let's move on to another thing which I just want to revise, without which I believe revision, but I know you know it. I'm just going to show you a big collage of a lot of images for 5 minutes, but that will be the best CNS revision that you can do very, very quickly. Firstly, this is a neurodegenerative disease. Which of the following common cause of dementia in humans? तो वो सुनते ही Alzheimer's वैसे याद आ गया. They've given me some brain biopsy. They've given me some cell over here. I hope you identified it. Looks like a fire. It's a flame cell. Maybe you thought of what? Neurofibrillary tangles, and you thought of tau protein. So let's discuss everything that is to do with Alzheimer's. Alzheimer's dementia है, वो तो we know. Alzheimer's में what we see the flame cell. Flame cell is known as neurofibrillary tangles, and that is seen because of tau protein. On the other hand, we see some bodies also which is known as Hirano bodies. What are they made up of? They are made up of actin. Okay, where should I have marked this? Alpha synuclein kahan dikhta hai? That is to seen in Parkinson disease. Parkinson disease was a condition with those tremors etc. where you see what? A pale substantia nigra. Look at the substantia nigra. It's not, look, this is normal one, you can see it's so brown. The pale substantia nigra, this is what you see in Parkinson's disease. And which bodies? Lewy bodies. Lewy bodies are made up of what? Then I would have marked alpha synuclein if I would have thought of Lewy bodies. So 3 bodies, 3 compositions. एक fourth body तो बहुत dumb है, वो negri bodies दिखता है ना brain में, rabies, वो कौन पूछेगा, you know that. We will talk about rabies on Monday, but अभी के लिए Alzheimer's disease shows you the neurofibrillary tangles made up of tau protein, Hirano bodies made up of actin, Parkinson's shows you Lewy bodies made up of alpha synuclein. Now, I don't know if this is a good idea or not, never done this earlier, but this is just one flashcard which has all the brain tumors, which might just give you a best 5-minute review of every brain tumor that you have to know. I know the labelings are very small, so what we are going to do, we are going to zoom into it and try our best that we can revise all of them in 5 minutes. So let's get going. When I start with the first one, see, it's all written, nothing for you to much, to use your brain much, but this is a revision that will help you a lot. As soon as they say there is something like tumor on the left and tumor on the right of the brain, so butterfly jaisa ja raha hai, so all things that is to do with animals, butterflies, snakes, etc. That is a glioblastoma. And now keep telling me questions. I won't write and won't make it messy, but I'll keep asking you questions. Whenever I say something like a blastoma, it is a grade 4 tumor, blast in the brain, so it is a grade 4 tumor, yes. Then you've spoken about butterfly, you talk about snake. What kind of necrosis does it show you? Serpentine necrosis, and all the tumor cells are around it, so that is known as pseudo-palisading of the tumor cells. If they ask you, agar chota sa kuch likhna hi hai, which is the mutation that you can see, it is IDH, usually of the wild type that we notice when it comes to the genetic alteration. So glioblastoma हो गया. दूसरा हमारा सबसे favorite अंडा वाला oligodendroglioma, which shows you the fried egg appearance. Wherever there is an egg, there will always be a chicken. So which kind of blood vessels do you notice? We see the chicken via blood vessels, as you can very nicely visualize over here. If they ask you what is the mutation over here, here also it is the IDH mutation, but is there any co-deletion that I can notice? There is a co-deletion 1p19q, both of which end up being deleted, and that is something for oligo. Very good. The next one, I don't think you're messing this up ever. It is arising from the meninges. It is the meningioma. Meningioma is the only tumor which is dependent on hormones, progesterone receptor positive. That is why it is more commonly seen in females. Meningioma में, because it is, see, we were very bad with men ना, हमने कहा था men are fake, so now let's be bad with women, otherwise equality नहीं होगा. So women always talk, they don't talk to the point, they always keep doing गोल गोल बातें, है ना. So meningioma में, because ये women में ज़्यादा है ना, everything is going to be गोल गोल. How are the tumor cells arranged, ma'am? They are arranged गोल गोल, that is whirling of tumor cells. How is calcium arranged? That is also arranged गोल गोल, and that is going to be samoma bodies, and that is in women, and that is going to be seen with progesterone receptor. Now, not writing, but radiology में वो dural tail sign दिखता है ना, that is also a very important clinching factor. Let's move forward. Let's talk about all the rosettes. Number one, if I see there is a blood vessel and then the tumor cells are around it, क्या बन गया? Perivascular pseudorosette. Perivascular pseudorosette is seen where? It is seen in ependymoma. On the other hand, if I see that there is a rosette and there is some pink material inside it, this was the men are fake, Homer right, pseudorosette. Right, that is going to be Homer right, pseudorosette, when there is all these cells and pink material. And if you remember, men are fake, men are pseudo. So now we've completed it. Medulloblastoma hai ye. Other than that, neuroblastoma, retinoblastoma, and also which bone tumor did we do today? That is Ewing sarcoma. If you want to see a higher magnification of these rosettes, I've got it on the next. If you see some pink material, to ye ban gaya Homerite pseudorosette, which is seen in men are pseudo. And if you see a clear center, like over here it is completely empty, that is going to be a true rosette called Flexner Wintersteiner true rosette, which is seen in retinoblastoma. So I have a simple question. Does retinoblastoma show you both Homerite pseudorosette and Flexner Wintersteiner true rosette? Yes. But if they ever want you, they won't put it up to you as ke ek hi batao type. But agar wo bol dein to true rosette is something which you will see more commonly, but that sort of a question shouldn't come. So I think we are done as a single word. Perivascular pseudorosette, ependymoma, Homerite pseudorosette, medulloblastoma, and Flexner Wintersteiner retinoblastoma. What is this chota sa bachcha? CCC, that is a child with a cystic lesion in the cerebellum. They will say, radiologist is saying there is a a nodule inside a cyst in the cerebellum of a child. It is juvenile pilocytic astrocytoma, and that is going to show you which kind of fibers. That will show you the Rosenthal fibers. Coming to the last, which they will tell you from radiology, case CP angle पर you are seeing the ice cream in cone appearance. Ice cream cone appearance schwannoma का होता है. Schwannoma में कौन सी areas दिखते हैं without me writing it to you. What is this area known as? Ma'am, this much of an area is known as lots of cells. A lot of cells, Antony A area. This is blank. Antony B area. And which bodies are seen? These bodies which are palisading wala Verruke bodies. So remember, ice cream cone, Antony A area, Antony B area, Verruke bodies. This makes it schwannoma. Schwannoma is which neurofibromatosis? NF2. NF2 is which chromosome number? Chromosome 22. Finally, all your brain tumors are done. Now, I just have, I think, one thing to add on, because I think I missed that, but you guys are very kind to inform me कि that was कि मैम आपने सारी bodies बता दी, एक body नहीं बताई, but you guys told me, and that was the Bunina body. Bunina body is seen in which particular condition? You've told me amyotrophic lateral sclerosis. Amyotrophic lateral sclerosis is which gene mutation? It is the SOD1 gene mutation. That is done. I'm sorry if I intimidated you too much with this flashcard, but I thought that this is the fastest way of doing it in 5 minutes. Otherwise, this topic alone ends up taking, if I teach it in a conventional way, it alone ends up taking 15 minutes. And we didn't have that much of time, right? So we had to do this. And now I would also want, when you get the PDF, you should actually study it in this way. This will be the best way of doing things very, very fast. I mean, the best way of actually, as per me at least, I feel. I think the last thing that I'm left with for today is another list, and then we'll be done, because after that I'll guide you towards how to utilize your how to utilize your bonus slides. But yeah, we've almost reached the end, almost, guys. Now if you've stayed here, then I think it's great. Find the incorrect match. I've kept the worst for the last. सारी renal diseases में कौन सा deposition कहाँ होता है? How do I catch that? Is this. Find the incorrect match amongst the renal diseases and the site of immune complex deposition. Just tell me the incorrect match first, and then I'll... Okay, you are saying MGN? Okay, perfect. That's wrong. So we'll just quickly revise it this way, which makes sense. What I've not included in this session is वो cast and crystal, because I know कि वो तो आता ही है. So all that is not omitted. It is there in the bonus slides. Like similar flashcards of images are there. I will also scan through bonus slides once after this. एक बार ये खत्म कर लेते हैं, then I'll tell you how to utilize those. Okay. Now coming to this, we have subepithelial. पहले तो क्या मतलब होता है? These are the podocytes. Remember, podocytes are known as epithelium. So either something is getting deposited below the epithelium, or if this is the red blood cell, this is the blood vessel, this means, ma'am, this must be endothelium. So something is getting deposited below the endothelium, or something is getting deposited in the basement membrane. So that is known as intramembranous. तीन ही जगह in the kidney it can get deposited. If not this, then what is the area that is left in between? That is known as the mesangium. So these 2-3 areas, not much. Trust me on that. When I say subepithelial, you are touching the feet. Who will touch feet? Let's go back to our basic culture. कि ma'am, very chota babies will touch the feet of very old people. So chota babies means PSGN will touch the feet of old people. Which kidney disease occurs in very old people, elderly people? That is going to be MGN. So this is okay. Repeating once again, PSGN and MGN, chota baby touching the feet of a very, very old person, that is subepithelial deposits, podocytes, okay. After that, mesangium. Mesangial reminds me of middle. Beach में क्या deposit होता है? That disease which is IgA nephropathy. IgA nephropathy में IgA gets deposited in between. IgA gets deposited in between. That is Berger's disease shows you IgA deposition in the mesangium. Now let's talk about the next. What is getting deposited? Subendothelial is everything that is left now. If I ask you, where is MPGN1 getting deposited? You will say subendothelial. If I say कि अच्छा SLE का wire loop lesion कहाँ पे जाता है? So you will say now whatever is left, ma'am, I'll keep adding over here. Okay, that is also going in the subendothelial. The only place where the membrane becomes thick, उसका नाम ही है dense deposit disease. The entire membrane becomes very dense. Dense deposit disease is MPGN type 2. So how I have learnt is very easily, middle, beach में तो Berger's disease happens out. Small kid touching the foot of a elderly person, so PSGN and MGN is podocyte subepithelial out. Everything else comes under subendothelial, and the only place where the basement membrane becomes very thick, called dense deposit disease intramembranous, is going to be MPGN. IgG and type 2, and these are all the deposits which will require not one but two revisions from your end also for you to actually, come to this. Now, when you will go back and you will do the bonus slides, because this is what you'll get in the PDF, please PDF के लिए panic मत करना. Even if it takes a little time for it to get uploaded on the app, within 15-20 minutes I will put it up on Telegram, ठीक है? So don't panic that something will be hidden from you. It will not. I will provide you. But अभी just focus. So what will you find in your revision? एक तो all these casts and crystals, they are already highlighted, labeled है, मतलब ये अभी भी नहीं revise करोगे चलेगा. 2-3 days before the exam, travel time के लिए रख लेना when you are on your way to the exam center one day before or whatever. So this you will do. I have got a small little test because this very obvious topic of vasculitis I did not include. It's a very NEET PG thing. It's not an INI thing. But then I didn't want to skip on it. So what I've done, I've given you some buzzwords of vasculitis. You will attempt it on your own and the answers are provided on the next page as well. So you will get your answers and you will be able to test yourself. Baki jo ANCA wale questions hai, wo to I've already told you. So that part I've covered. What else is there in the bonus slides? Yeah, you have these which I've taught you a million times, but again, like the brain tumors I put as one flashcard on one page. I have put all the vacuotenors as one flashcard on one page. So ye bhi 2-3 days before the exam. Just scan through this once. And yeah. That's all that we could have possibly done. Humanly, we could have done. Have we finished before 4 hours, which is only thanks to you. Thank you so much. But yeah, even in between, when you will be going through this PDF, in between as a surprise, you will see some slides which are nothing out of the box, very routine stuff which which I'm very confident which is nothing extra, not even INI-CET type, but sometimes you just want to revise because you want to complete your syllabus. So those kind of 2, 3, 4 slides, you might find extra labeled as bonus slides in between. Don't panic on those. वो बस एक बार देख के चले जाना. That is like, you know it, you just want to brush up on your memory. And thank you so much. GI polyps is one of them, by the way. So for those who are asking. But yeah, if you have any, many of you were saying, ma'am, hepatitis wali slides nahi hai. वो इसलिए नहीं है because hepatitis virus I will be discussing on Monday, and when I discuss the micro, I will include the patho along with. I mean, एक ही बार पढ़ेंगे ना. We will not study it twice over. So when I do hepatitis B and serology, I will study the ground glass hepatocytes. I will study the councilman bodies. वो सब उसके साथ ही कर लेंगे as one flashcard. And I will try my best, although I'm still in the process of making, I'm a very last minute person, just like all of you. I am still making the microbiology LRR PDF. I think I'll be making it till the very last hour before the class, but I'll try my best, and I am trying that I can fit in everything like I did brain tumors one slide. Na? I'm trying my best ke micro ke bhi LRR mein we can have those one slide things which can help in easy revision, because micro is where I think it is essential for us to do that kind of a revision, especially for things like bacteriology. The session will be on Monday, that's May 4th if I'm not mistaken. The session will be at 5 p.m. The session will be for 4 hours again. I'm sorry for it, but I hope you come back with the same determination that you have today. General pathology starting, so you will not realize, but general path has been included a lot as you were discussing. I mean, all this IHC, all the different genetic translocations that you were doing, ये सब कहाँ से जा रहा था? बीच में we were talking about stains like von Cosa pearls. Those were all elements of general path. Immunology is a lot of general path. Genetics में we did a lot of epigenetics. We did PCR. वो सब general. It didn't feel like that you did topic wise, but when you put it all together, you have touched on all the topics. So basically हमने ऐसे अलग नहीं करा कि पहले बताओ what is inflammation chapter, then tell me chronic granulomatous disease, which we usually do for all NEET PG FMG exams, but I wanted to take a different way of approaching INI-CET this time. So I decided to go topic wise and put everything related to that topic around it. INI-CET motivation. See, INI-CET is if it is your end goal, go all out. Even if it is not, maybe some of you are just giving INI-CET because, you want to give NEET PG, but you're considering this as a mock exam. Irrespective, kuch kar rahe ho, then give your 100% into it. Even if you're giving it as a mock exam, make sure it is the best exam that from your end, it is the best effort that you're putting in. So I'll give you a very, an example that I can talk about. Do you think this is the first LRR that I am conducting? Don't you ever wonder that how we have probably the same subject and same concept of LRR, but we do it 2-3 times over, once for NEET, once for INI, one for FMG. Sometimes it gets repetitive, but then every time I decide कि कुछ अलग mode में चले जाते हैं, let us find a way, because the concept is the same. Whatever you do in life, even if you're doing it for the 100th time and you feel very bored of it, you feel very monotonous about it, the point is that you have to give your 100% in it. And that is what I want to tell you. Even if your target is NEET PG, that I don't care right now. Right now, for me, the exam that is coming up is INI-CET. So mera pura heart, soul, blood and sweat has to go thinking about INI-CET, and you never know that the universe is watching this effort of yours. And what if you get a seat in INI-CET and you can save yourself from the torture of NEET PG? It would be the best thing you can do to yourself, right? You get the best seat, you get the best seat in one of the best colleges of the country, because you don't even know what NEET PG is. Now NEET PG will also have a counseling later on, which no one can predict when would it happen, how long would it take. So when you have an opportunity ahead of you, and if everyone starts thinking of this as a mock test, तो seat किसको मिलेगी फिर? किसी को तो मिलेगी. So maybe that someone is that you, it's what you can vouch for, you can go for that seat. I know it's a very short time, 2 weeks or so that are left, but even now, if you have studied in a decent fashion, it's a game of revision. If you revise well in these last 15 days, even if you do LRR PDFs के साथ अपना जो भी Q bank you have made, that also you end up bookmark questions, you end up revising well. INI will test you on first, second year subjects a lot, like the LRRs are happening right now. If you've done your rapid revision, then you keep revising from those. But those first, second year subjects will be tested. But having said that, I've seen a trend where people are ignoring medicine surgery. Guys, those are always going to be your core medicine topics. You can never ignore those big 4 subjects of medicine surgery, gynae and peds. वो तो रहेगा ही रहेगा. But yes, in comparison to NEET and others, INI tests a lot of path, micropharma, biochem. So those are also what you'll have to pay attention. Be very INI specific for 15 days, because वो करते करते भी आपका NEET PG काफ़ी हो जाएगा. And if you get a seat, you save yourself from so much of torture. So you will thank me later if you do well in these next 15-16 days. If you've done resolve session, then stick to that. And then LRR को अभी सुन लिया है तो फिर तो सुन लिया, very good. You just scan through the PDF once. That's what would be advisable. See, INI के लिए I always have something extra that you will find from the classes, because as we approach the exam, some new things happen. Sometimes you know that what is being researched about in a particular institute. AIMS में क्या research चल रहा है? So on the basis of that, we include things. So INI LRRs are always advisable to do over any other. So I would suggest do your resolve का basic PDF वो तो कर ही रहे हो. And this is just one session. Now if it took you 4 hours, anyway you will revise either on a 2x speed. खुद से नहीं भी revise हो रहा, put it on a 2x speed. In 2 hours you will be done with it. It's not asking for too much. उतना तो कर लो. What not to do in this crucial time is, Dr. Kirtana, do not listen to what others are telling you about कि paper मुश्किल होगा, difficult it will be, or it will be easier. So cut the noise is the first thing that you have to do. Secondly, nothing new until and unless it is something like a recent Nobel Prize that went out, or you get to know something in the news that a new drug has been announced. That sort of new information you can. But an altogether new topic which you have never studied, then don't go into the FOMO, and do not attend the revision of every platform, because every platform will be giving you a final revision. It is their duty to be with the students, but you as a student cannot do the end moment revision of every platform, because when will you do self-study? So do the revision from the teachers you have studied. I am not saying that you only do LRR of prep ladder. I am just saying आपने जहाँ भी जिससे पढ़ा था उनका रिविजन आप अटेंड कर लो, because you will be able to do that a lot faster. So don't fall for the FOMO of everyone doing 19 subjects, so you sitting on every platform and attending those lectures, because revision कब होगा, that is the main point. So don't fall for that trap. LRR for last moment is enough? Yeah, of course. I mean, now with 15 days left, I would love to say that read the entire syllabus, but humanly that's not possible. So let's not set unrealistic expectations out here. Okay, so anything else that I have missed out on? I mean, you can, pathology related questions, keep this thread. Let's keep this active till INI-CET. Whatever questions you have path related, वो इस वाले video के नीचे लिख देना. Whatever you will have micro related, you can put it up under the other video, so that you have one place to ask your doubts and me to reply till the INI-CET exam. And then otherwise there's the Telegram group, of course. Last 15 days में सिर्फ first year, second year subjects, no, happy soul. No, you can't do that. That's what I said. There is so much buzz around कि first, second year subjects are so important, but that doesn't make 100% of the paper, right? How can you forget your medicine surgery? How will you, even if you know rheumatic heart disease, but अगर आपने revised Jones criteria नहीं पढ़ा या infective endocarditis medicine से नहीं पढ़ा, तो only knowing ASH of bodies will not help, right? So they will come down to integration, they will come down to a lot of first, second year subjects, but the question will always have a clinical base, so you can't ignore. You don't want to become a PhD in any subject, right? You don't want to know it through and through, but you want to know a 60-70% of every subject before you appear for the exam, so that you can approach it like a patient and not like a subject on the day of the exam. So thoda you will have to study. Dr. Sai Karthik, 10-10 series continuing. I'll be updating that shortly on Telegram. I'll let you all know what the plan is. The plan is in my mind. Now I'll put it down on the group. Dr. Varun, no, I'm very used to taking lengthy classes, not tired. Any doubts you have? So this, the end moment I had kept only for this. Okay, before we don't put those breaks in between, we put it across. That's why we finished also before 4 hours, which was our estimated time, because we didn't put those doubt breaks in between. But at the end, now I'm okay with you asking me any questions, koi doubts. Hepatosplenomegaly approach in hemat questions, Dr. Itisha. There's no approach as such, but I can just tell you offhand end moment what is going to help you. When you talk about hepatosplenomegaly and a leukemia is being asked, they will think of they will think of chronic myeloid leukemia, CML. When they are talking about maybe the bone marrow showing you a fried egg appearance, so they will be thinking about hairy cell leukemia, that shows you hepatosplenomegaly. And to be very precise, to be very specific on that, they will be showing you massive spleen. And if they want to tell you about any microbiology infection, they will talk about Kala Azar. I mean, these are the 3 most important things that I can shortlist out here. Of course, there are a million other causes, but these 3 come out to be, 90% of the questions are sorted this way. Okay, all hepatitis doubts, be rest assured, वो Monday को हो जाएगा. You have done RR plus old LRR, which was in 2 parts. That is okay, never mind. Dr. Umang, what I'll say is that ye wala PDF abhi when you'll get in the next 15 minutes, na, just since you've done all of it, don't read through this entire PDF. Just scan through it. If you find something extra, just add that as a screenshot in your previous LRR, and that's about it. Baki, you can stick to that. No need to change your entire source right now. Or if at any point of time you feel that, there will come a time in the last 5-6 days when active recall, actively studying becomes very difficult because you're too panicky about stuff, right? Or you're traveling to your exam center or whatever is the reason. So that is when passive studies help. So you can play this video on a 2x speed, but it is not mandatory if you've done the previous LRRs. If you've done the previous RR also, तो ऐसा कुछ बहुत out of the box नया नहीं आ गया. So just scan through the PDF once in quickly 15 minutes if it helps you. Otherwise, it's okay. For those who are asking about lab 2, that will be updated regarding FMG students. आपकी live classes तो होंगी, अभी तो RRR भी होगा, LRR भी होगा, so be rest assured your lab 2 will also happen much before the FMG exam. Okay, nephrotic versus nephritic syndrome, एक बार, they don't ask you like this in INI-CET how to differentiate. I teach that more with regard to FMG, NEET PG, but if you want, एक बार either go through any rapid revision video of mine which will take 10 minutes or any previous LRR so that you can get a basic hang of where massive proteinuria is occurring, where mild proteinuria is occurring. That will give you an overall view about how this is happening. How to avoid mistakes from known topics. Because of overconfidence we make those mistakes. Like if you're so confident कि मुझे तो पता है कि iron is stained with pearls or Prussian blue, or maybe the CD markers which you read today, you are very confident about it, but then in the exam, just because you know a topic, don't go into that I know it all, superiority complex. That is the main issue, that when we know, we don't tend to read properly. हम वो से बहुत superficially deal करते हैं, right? So you just need to be very grounded in the exam, that even if I know it, I'm human enough to make an error out here. So you're just going to look at it with that view that I am a student, I am worthy of making a mistake, I am very possible as a human being I can make a mistake. तो उसे बस ध्यान से word by word पढ़ो. Because if you know it and you're confident about it, you might want to do it in that urge to finish it in 20 seconds, 15 seconds. You will go through it very superficially. And that is where you will make a mistake. तो जब भी आपको आता हो ना, उससे ज़्यादा grounded होके, ज़्यादा ध्यान देके पढ़ो. That is how you will avoid silly mistakes. Preparation not very good. should you continue with NEET PG? Dr. Ayush, what I would say is that right now, see, we as a human brain have this thing ना, जब हमारे को पता है कि exam है 15 दिन में, our way of studying will be very different in comparison to when I know my exam is after 2-3 months. You know, the speed and the absorption, your brain is like a sponge. The amount you start absorbing when you know that you have an exam in 15 days. So just imagine now, if you're studying for INI-CET, you will be sitting with me for 4 hours and watching this LRR. But if your exam is after 3 months, you will think अभी 1 घंटा देख लेते हैं, 3 घंटा बाद में देख लेंगे. That is how our basic nature is, right? Everyone, most of us, right? So now if you target INI-CET, I'm not telling you that you're leaving NEET PG, but you are doing 19 subject LRRs. Isn't that going to contribute in a way to your NEET PG? I mean, I say that TEG and platelet aggregometry are INI-CET topics, but you pick up previous year NEET PG papers, they have been asked over there as well. 80-85% of what I have taught you today has been asked in NEET PG also. So if you're preparing for INI, doesn't mean you're doing something completely different from NEET PG. You are on that journey of studying for NEET PG also. Take this as an exam, take it as a mock exam, and it is only giving 2 weeks of your life which are not wasted, which will be used later on. And the day you finish INI exam and your main target is NEET, take a 1-day break, because you need that after an exam for your mind to detoxify, and after that you sit down with a dedicated plan for NEET PG. So my advice is that you should go ahead with considering INI also as a good enough benchmark. You will know how do you respond under stress. Maybe you studied this LRR PDF very well. Let's assume with God willingly a lot of questions come out of it. तो उसके अंदर आपको आता था, and what if God forbid you make mistakes, at least you are now prepared for NEET PG, that what is it that I do when I'm under stress or panic? How does my body and brain react to stress? What do I have to improve? This will also be an excellent learning curve for you. Consider it as an exam that you want to go all out for and give it your best. CML हमने पढ़ लिया. Today, if you remember, we had a question where we were doing pseudo Gaucher cells, BCR, ABL. Just go back to that question and we have studied it. Fibrolamellar and FNH दोनों में scar होता. How to differentiate? पूरा नाम पढ़ो. FNH is focal nodular hyperplasia. It's not a cancerous condition. Whereas fibrolamellar is HCC. It is a hepatocellular carcinoma. So clinically it is so important that just because both of them show a central scar, that is okay, but one is a cancer, and if it's a cancer it will have a tumor marker. Fibrolamellar का neurotensin tumor marker होता है. Fibrolamellar का chromosome 19 deletion होता है. It is everything. It is going to spread because it is a cancer. FNH is not a cancer. It is just a condition associated with oral contraceptive pill usage. तो दोनों का clinical presentation is contrastingly different. Any telegram queries that students have, quizzes का, वो हमारा 10 series का, वो अभी after I put the PDF, I will be addressing that on Telegram. I will tell you the plan for the next 2 weeks, how I've planned it, how we are going to go ahead with it. So I'll put this up over there. Will there be LRR for NEET PG? Yes, there will be. For FMGE, yes, there will be. Okay, anything else that you feel? Let's assume I give you the PDF and you don't understand something from the bonus slide. It's not that I or you are running away anywhere. I can always cover that in the 10 series. I can always cover that as a voice note on Telegram. I can always cover that on Monday in the micro quiz also, or the micro LRR. So abhi ke liye my advice would be that you take your break, you get a PDF in 15 minutes, go through it on your own. Jo samajh aa gaya, excellent. Jo nahi samajh aaya, put me a message, comment it over here, put it on Telegram, and we will work out a way of how to go ahead with it. Nothing will be left. Okay. Dr. Cowden, Fragile X syndrome is both XLR or XLD. Single best answer as per Robbins and as per Harrison is going to be XLR, but it can also be XLD. Unannotated, Dr. Shivani, honestly, as you can see, this was actually a handwritten wala na, everything is handwritten. So I don't have an unannotated PDF. I'll see what I can do. Maybe I can erase all of this because all this I was not writing with you in class, वो already written tha. Let me see if I can work a way out and I can erase all of this, because this is a PDF, it won't be possible. But that is why I don't have an unannotated PDF. I will keep that in mind for micro so that I can give that to you beforehand. Right. I'm sure I must have missed out on a lot of things, just the influx of comments that fall that way. In case I have, firstly, sorry. Secondly, put it in the comments, put it on Telegram. I'm here. I'll be ready to solve them in whichever capacity I can. Thank you. All the best. Study well. These 4 hours will
let's keep our fingers crossed. Our effort will not go wasted and you will get a lot of payback from what you studied. Just keep up the spirit. Don't get demotivated. Don't listen to all the nonsense happening around. Be very focused on what you have set out for. Take this as a real exam, not just as a joke that I'm just going for the heck of it. Even if you have not studied to the best of your capacity, still consider it as a very, very good opportunity. If you get a seat, amazing. If you don't get a seat, you will learn so much that you will be able to apply all of that onto NEET PG and you won't do those mistakes again. Either which way, it's a win-win situation. You will get something out of INI-CET for sure. Trust me on that. You will thank me later. And with that, I'm going to sign off. All the very best. See you again on Monday, same 5 o'clock, LRR Microbiology. Thank you.